Good morning, everyone, and welcome to Taipei Valves 2026. We're joined today by world-class physicians, researchers from across Asia, Europe, and North America. A truly global gathering united by one goal, advancing structural heart therapy. Over these 2 days, we'll tackle live TAVR cases, the latest in mitral and tricuspid transcatheter therapy, and a head-to-head debate on universal TAVR, bicuspid aortic valve intervention, and lifetime valve management. In short, this is the most relevant real-world structural heart content you will find anywhere. I'm now honored to introduce the leader who will formally open today's program, Professor Jian Wei, President of Cheng General Hospital and a leading authority in cardiovascular surgery, have made Taipei a global center of excellence in valve intervention. Ladies and gentlemen, please join me in giving a very warm round of applause for Professor Jian Wei.
Good morning, co-director Dr. Jian. Ladies and gentlemen, distinguished guests, colleagues, and friends. I'm Dr. Jian Wei. Welcome to Taipei Valve 2026. The theme of Taipei Valve 2026 is Advancing Structural Heart Therapy, Innovations, Evidence, and Real-World Practice. Over the past decade, we have witnessed the remarkable progress in structural heart interventions, from transcatheter interventions for aortic and mitral valve diseases to emerging tricuspid therapies and pulmonary hypertension. At the same time, conventional cardiac surgery remains an essential part of the practice. Through this meeting, we hope to provide the most up-to-date knowledge and emerging discussions between surgeons, interventional cardiologists, image specialists, anesthesiologists, and all other members of the heart team. This year, we are especially excited to host 7 live cases, including cases from our center and the leading institutions across Asia. We are honored to collaborate with Professor Junbo's team from Zhongshan Hospital, Shanghai Fudan University, Professor Wang and his team from the second affiliated hospital, Zhejiang University, Professor Wang Guangyuan's team from Beijing Anzhen Hospital, and Professor Wang Yan from Xiamen Cardiovascular Hospital. In addition to the live cases, we have outstanding speakers, debates, and more than 40 case competitions. We have organized a session of hands-on workshop focused on the valve-in-valve procedures and electrosurgical techniques for structural heart interventions. These workshops provide participants with opportunities to learn through simulation, animal models, image analysis, and interactive discussion. This year, we are honored to welcome more than 50 international faculty members and over 50 regional experts. We are also delighted to connect with colleagues in joining us through online broadcasting and social media platforms around the world. Finally, I would like to thank all our faculty members, industry partners, organizing committee members, and participants for making this meeting possible. Thank you for your support, your friendship, your commitment to advancing structural heart therapy. I wish all of you productive meeting, stimulating discussions, and an enjoyable stay in Taipei. Thank you very much. It is now my great pleasure to invite Professor Jian, one of the world's leading pioneers in transcatheter valve therapy, to join us in officially opening Taipei Valve 2026 and sharing a few words with us. Please, Dr. Jian.
Good morning, Professor Wei, Professor Yin, and Professor Park, and Professor Wang. And also good morning to all of you for joining us from around the world. whether you are here in person or virtually, it is a true pleasure to welcome you to this 11th, yesterday I just confirmed, 11th Zhongshan Taipei Valve. So over the next 2 days, we're really gathering again as a community of cardiologists, cardiac surgeons, imaging specialists, or many other health professionals, basically by a single mission, is advance the transcatheter and the surgical therapy for valve disease, and eventually help our patient. That's our final goals. So this field is continuously evolving. As you know, 15 years ago, I believe in many centers, we were struggling trying to have a success case. What's the mean success? Just to make sure the valve placed in the aortic position, not in the ventricle, not in the aorta, or don't need to require ECMO or put on emergency cardiopulmonary bypass. That's probably 10, 15 years ago in many centers. But now this procedure becomes really daily, like a day procedure. It's in many situations actually simpler than coronary stents. I always speak to the cardiologist. I think nowadays you do the TAVI, it's really nothing. You can almost close the eyes to do a case. And you do a stent, take like 10, 15 minutes or more to do it, but for valve, take 1 minute. So you think about it, this is a field that's really like evolving rapidly. And in addition, transcatheter therapy for mitral valve and tricuspid valve disease also expanding rapidly over the past several years. But we're still facing lots of challenges, particularly like a complex decision-making in the young patient. What is the best, for surgery or this TAVI? Still struggling. And also we're trying to really optimize procedure and also the manage complication. Particularly now we focus on not the first TAVI, the next, like a subsequent, how to treat it, how to do it, how to manage the patient. So that's our new goals now. So this valve, I think also we see the witness evolving in terms of like the content of the whole programs. But now you can see the program so rich in covering all the TAVI, transcatheter for any kind of valve procedure and all the complications, and share all the knowledge about our new technologies. So we have many like pioneers, world leader, writing styles here to share their knowledge and experiences. So I wish all you have and a collaborative, enjoyable 2 days ahead. Thank you very much for joining us either in person or virtually. Let's start. Thanks.
Thank you, Professor Wei and Professor Ye. We'll move right into the action because nothing captures the reality of structural heart intervention like watching it unfold in real time. Our first session features live TAVR cases from some of the most experienced operators in the field. Please welcome our moderators, Dr. Wei-Shen Ying, Tok-Kuk Park, and Dr. Yong-Jian Wu to lead us through today's first live cases.
Let's get started. It is my great pleasure and honor to open this session, the first live transmission case from Zhongshan General Hospital. I'm Dr. Yin from Taipei Zhongshan General Hospital, and together with me will be D.W. Park from Korea, who is the leading expert in TAVR and the transcatheter intervention field from Korea. And we also have Professor Wu Yongjian online.
Yeah, hello.
Hi.
Hello, Professor Yang.
Hi.
Yeah, hello, morning.
Jian, good morning from Beijing. he is also a pioneer in this field. Together with us, we also have distinguished panelists from Taipei, Cao Dianping, Professor Cao Dianping, Professor Ko from Korea, Professor Hsin from Thailand, Professor Lin from National Taiwan University Hospital, and Tami from Malaysia, and Zhang Junjie also online.
Hello, Professor Ying.
Hi. And Fang Jun from Fudan.
Hello.
Hi, Professor Fang. And the first case will be a TAVI case from our hospital. And I see the Dr. Lee from on the air. Okay. Dr. Lee, would you like to introduce your case?
Okay. Thank you, Professor Yin and Professor Park for the introduction. And I will introduce the team first. And I am Yang Chai Li from Zhongshan. And next to me is Dr. Lin Huanqiu. And behind is Dr. Chai. We have an assistant, Dr. Zhou and Dr. O. And we have a nurse and Dr. Liao and Dr. Lin and Dr. Wang here. And also our transmission team and the perfusionist help us to please make the briefing case. Dr. Chai, please.
And this is a 79 years old male, and he had received AVR and MVR in 2009, and with positive mitral valve fail, and he has received mitral valve in 2018, and positive LT valve fail in 2018, and he received LT valve use the core valve Evolut R 26 millimeter, and now he had recurrent positive LT valve failure with critical AS. And previous CAG showed his coronary was patent. And his surgical valve was 90 millimeter Magna, and we did the BVF this time with 20 millimeter ATLAS Gold, and we deployed Evolut R 26 millimeter. And now his cardiac showed reserved LVEF, and LT valve has thickness and restrictive motion. And the mitral valve has mild paravalvular leakage, and the mitral valve function was patent. And he also has severe TI with RVSP 75 millimeter mercury. And here is the MSCT analysis. We can see at the surgical valve inner, we can see the diameter was about 18 millimeter, and his ascending and the sinus vascular structure was very large, and I think the coronary issue was risk was very low. And here is we can see VTC and VTS TJ was large enough for the third time THV, and we can see the lower THV was contracted with the surgical LT valve, and the node 6 the diameter was 19, but the node 1 diameter was only 60 millimeter. And his femoral SS was adequate, and with a horizontal aorta with 52 degree. So we will our main assets were from the right common femoral artery, and we will use the Sapien 3 Ultra 20 millimeter, and our implantation height was we will cover the node 2 to node 6. Yeah.
Thank you, Dr. Chai, and we will introduce our ICO coverage from the Liu Junting doctor, and please introduce the TE here.
Okay. Dear doctor, this is this patient's four-chamber view. You can see that this patient has a normal LV function. And at long SS view, there is a failure aortic valve. You can see that the leaflet is much more thickened and rhythmic motion. And as for this patient's mitral valve, there is nothing wrong. It's a normal mitral valve function. And you can see the color Doppler. There is a mosaic pattern, auxiliary flow of the failure TAVR valve. You can see that the short axis view, the leaflet is much thickened and the flow is restricted and pass only through the NCC cusp. This is the 3D model. You can see that only restricted flow pass through the failure TAVR valve. And this is a transgastric view. You can see that the LVOT flow, LVOT flow, a little bit paravalvular leak is noted from the transgastric view. And this is the picture of the patient.
Okay, thank you, Dr. Liu. And any comment from the audience or the panelists?
Well,
okay, thank you. This is a very wonderful case. So, and Dr. Lee, I think this is the third time attempt. 2009 perimount surgical valve, second time 2019 core valve. This is the third time attempt to use SAPIEN 3 Ultra 20 millimeter. So I think this patient having enough coronary sinus portion. So I don't much concern about coronary obstruction and the sinus sequestration, but I'm still concerning about the risk of prosthesis patient mismatch is you plan to the 20. So how do you expect the risk of a PPM? And sometimes if you put the SAPIEN valve 20, there are some significant remain the pressure gradient. It's how do you expect? How do you plan to that issue of a PPM?
Okay, thank you, Professor Park. This case is quite difficult, but fortunately the patient living style is quite static, so that I think in most of the time the PPM should be not a problem. At the same time, we will plan to do pre-dilation with nucleus valve balloon because the valve had been break before, and we'd like to for further dilation because of the narrowest part is only 16 to 17. So after 20 millimeter balloon dilation, I think should be fine and open a little bit. However, that's PPN still a problem. So the implantation height of this 20 HCU should be at node 6. And the constraint area should be in a higher position. So I think that should be solve some residual pressure gradient.
Yes, Dr. Lin.
Hello. So,
Dr. Lee, I'm Dr. Lin from NTUH. For myself, I think this core Evolut R is only live for 7 years. Is that right? Implanted in 2019. Yeah. It's a little bit out of my expectations to short. So follow the question from Dr. Park. So you think that the valve, this THV live so short just because of the previous, a little bit constrained by the surgical valve because you did not do the fracture in the last, already?
We did, but
already
did not do post-dilatation.
So right now, we will implant either smaller valve. So how do we expect that, because this gentleman is only 79. 79 is only. so maybe you can live longer, but so another 7 years or 5 years, I don't know how to deal with this issue.
It's a big issue. In the next section, I think we have talk about the lifetime strategy in this kind of patient. unfortunately, the current technology just solves some problem. And PPM is a problem. However, the longevity is still a big issue in this kind of patient. And now the SCU or SC 8 years result is as good as surgical aortic valve. So we hope that we can have the same result. But at the same time, is the Japan OCEAN trial have shown the comparable result between the small aortic valve and the larger one. So I think that we hope that in the future the patient should not become in again. And I think it's still a big issue, but it's the only way we to solve the problem, because the patient is 79, a little bit fragile, and he only do some daily activity, limited activity. So that we do the 20 sapien again, and we don't know that in the future there's which kind of the valve could be done at that period. However, that's another issue is THV toe-in-toe in the future should be okay, because we can implement even higher position for another or other Apex Plus, because there is a hole over there, so that's a sequestration problem should be fine.
Yeah, I just want to ask, because we are worried about the small diameter of the valve and also the PPM. So maybe the patient's sinus valsalva is quite big. So would you consider to just use toe-in-toe? That could be another option, because hemodynamic EOA is better.
Yeah, it's a big issue, toe-in-toe. We don't like the toe-in-toe because of a coronary issue. And even you use the Apex part in this case. In the future, we must do the limited modification for layman and RCA. So it's got very difficult in doing this. So that's we'd like to use the 20 SCU rather than the Apex Plus.
Yeah,
and previous show that the COVAV have better hemodynamic. However, in this case, it's only 7 years. But fortunately, most of our cases did not receive the second time of the THV, and the SAV.
Yeah, Professor Wu Yongjian, do you have any comments?
Yeah, thank you, Professor Yang. So thank you for you and your team to invite me to join the TAVI forum. But unfortunately, so this weekend I could not go to TAVI. Actually, so this is a very interesting the case. I think in the future, so there will be more and more the patients like this, because the volume valve and the cervical valve. And I think the first is the depend on the physical measurement before the cervical treatment. So I think that the measures from the original anatomy, so it's very important. It's very important to be considered. And I think now the minimal the diameter after 2 times of treatment. So now the maximum is the 27. So maybe it's the borderline the diameter for the TAVR. So it's possible for the third time of treatment. And another consideration is the coronary access. So I think for the patients who received the surgical treatment for the first time, and after that, although he received the second TAVR, the third TAVR, I think access, coronary access is not very big problem. And and the third, my question is depends on the age. So the age is the age 17 is not old. Maybe for the patient with a high age, for the treatment for many times, maybe the partial treatment is enough. We can't to get the optimal result. But I think the clinical program should be solved. It's okay. Okay, so this is my the opinion. Thank you.
Thank you.
Thank you, Professor.
I think this patient have a spacious aortic root, so coronary will not be an issue. The problem is PPM, as you mentioned. And personally, I prefer to do aggressive pre-dilatation to make the diameter as close to 20 as possible. Then the SEV, and then the BEV, 20 millimeter, also as big as possible. So I think the first valve failed because of under-expansion. May have some pinwheeling and the hemodynamic compromise. So maybe this time we should try that. Dr. Lee, do you have any other opinion or comment?
No, that's all. We will do the pre-dilation with 20 millimeter balloon first. And because of time, and we must start our procedure. So please, we have done the sentinel for this patient and cross the valve. Please show the cross valve picture. So for cross valve, you need to use the pigtail, especially for this kind of the valve, because when you directly use the AL1 and the straight wire, sometimes it will cross the stroke, and we have experience about that after the device in and found that the stroke was catch by the wire, so that's got a very difficult to management. So that you should use the pigtail for cross valve as possible. And now that we have a stiff wire inside, and we will doing the pre-dilation.
So this is the 20 blow.
20.
Yeah, 20.
Okay, yeah.
Dr. Lee, I'm Young-Guk Ko from Korea. So what is your target level for SAPIEN valves? Node 6, or would you go a little bit lower?
Node 6.
So I think it is important to not to have overhang of the have to more expansion of previous valve. Then maybe we need to target a little bit lower. So we have to see the heights of the SAPIEN valve, and maybe we need to adjust the level of the target.
Okay. So we do it, and please pass it on.
Yeah, let's see. Yeah, maybe yes, maybe not. Redo-TAVR, especially in TAVR in SAVR, is really, we only have 2 or 3 cases experience.
Okay.
Oh. Balloon rupture.
Which balloon you are using? This is
nucleus balloon.
Maybe you should use a non-compliant one.
So sometimes the sound of the rupture you can hear from other side of the body.
Yeah. But I think that in this case there is a mitral prosthesis, and the atherosclerosis is relatively longer, and I think that it may be injury to the functional mitral valve. So I decided not to use the atherosclerosis. And you can see the brain is still opening after we pre-dilation.
So now can you measure the diameter change or not with the echo?
I think it's
so now the SAPIEN series is still 22 or 20.
20.
Okay.
Was it possible that the biocore or the surgical valve was not successfully fractured the first time around, because the inner diameter is still 18, and from my limited experience, it's difficult to further dilate when you do TAV in TAV. You even Even though you put a 720 in that inner diameter of 18, it's still going to be 18. Because as you can see, it's expand, but it recoil. And now you have a surgical valve outside of it. It's even going to be very difficult to expand it further. Can we fracture it one more time?
Yeah, I think the first time the fracture is successful. So I personally consider to do it again. Because no, before. I prefer to do it before. Yeah.
So Dr. Lee can maybe retrieve this valve out and then.
So I guess this is lower than node 6, right?
Yeah, it should be higher.
A little bit stuck by the metallic frame of the So you want to a little bit higher, but the valve cannot move.
Maybe the previous dilatation has caused some leaflet injury.
再组起来，然后再那个弹幕组起来，会弹幕组起来会。So that the valve is stuck in the lower part. So we assemble the valve and let the try.
Position is acceptable. I think the position is acceptable. You just deploy it.
So now we hope that the position is to totally cover the first one, the last one, or is the same position.
No, assemble will not help to overcome such sucking.
Okay.
Totally, we will agree this position is good. Yeah.
I think that we use a balloon for the adjustment a little bit higher. And patient. 再快一点，慢慢的，转 LV 一点，LV 凹它一点，more。Okay, no problem. Okay.
Slowly, because okay, all the way up.
Okay. Pause.
Oh. So this nominal volume or
nominal volume plus one.
Okay, plus one. Okay.
Stop patient. Stop.
20 plus 1. You can see valve expansion after deployment of the BEV. So, Dr. Liu, can you tell us the current situation by T?
Okay, I'll follow. Okay. So we all do the post dilation again. Patient.
I think the first time we did balloon fracturing, we used Atlas and it was successful. So maybe this time you can try Atlas again.
Patient over. Picture.
What the size you would choose if you post die by Atlas?
20, still 20. Because a non-compliant balloon is safer and stronger. But if you use a non-compliant or semi-compliant, then the balloon might rupture because of overexpansion.
有2条 picture 吗？
This is an inherited problem with the small annulus. As you can see, it was a problem even way back with the surgical valve. And so now we see
Professor Leon, could you explain the echocardiography procedure?
Okay. I use the long axis view plus X-plan to see the new TAVR valve. And you can see that, let me adjust it. Because the basal of the TAVR valve is blocking by the mitral valve, so I can only see the middle port the TAVR valve here. The leaflet is quite functional, and if you just see the flow, it's much more patterned compared to the previous one. And of course, this patient have a large sinus of Valsalva, so there is no coronary obstruction risk. And to see the closer look, to have the LVOT flow, I have to go down to the transgastric view. Okay, I don't see any paravalvular leakage here. Oh, maybe a little bit. Only mild paravalvular leak was noted, and that's all about the patient currently. Thank you.
Can you measure the diameter?
And how about the gradient?
Gradient, okay, of course.
不要，可以。
Since the angle of the heart is not very perfectly parallel to the probe, so let me just measure approximately.
So the pressure gradient is 5.
And mean gradient about 2 millimeter mercury by echo.
So it's just about the same. I hope that this pressure gradient keep longer, and we will add some anticoagulant for this patient because of PPM and high risk of valve thrombosis.
Yeah, I mean, Dr. Liu, can you measure the inner diameter from short axis view?
Inner diameter, of course.
So I think for the different age of a patient, so the PPM should be different. Because for a patient with a high age, so because they have less activity, so the PPS is not highly requested.
Yeah, we limited the activities, yeah.
Dr. Lee?
It should be 1.7 or 1.6.
Dr. Lee, would you apply the nominal volume for SAPIEN valve 20 millimeter, or did you add more volume?
1 cc.
To 1 cc?
1 cc over field.
Yeah.
1 cc, because we hope to play up a little bit.
Yeah. Do you think double tap helps in this case? Double tap,
yes,
applies the same volume again.
Yeah, same volume again, same volume again.
Yes, I mean the additional dilation of the valve with same volume.
Yes. Because the valve is constrained, so that we hope that the double tap can open more forcefully and keep the valve round. So we do the double tap more often.
So with that gradient, do you still plan to post dilate?
Just use the atlas or the SAPIEN balloon. I won't use the atlas doing the further because I think that we did had already good for this patient, and I think it's okay.
Okay. You there? Yeah. You have
I'm sure after the Evolute 23 7 years ago, the gradient was like this, and 7 years later it failed. Now you get a single-digit gradient, but with a smaller diameter, even a smaller diameter, I think it's a real problem with the small annulus.
Yes.
Whether the valve would fail. The data in the literature, the annulus is not this small. Usually it's larger than this, but we're not talking about the SAPIEN 20 or the inner diameter of 16, 17, 18 very much. So looking back, maybe the patient should have had a second redo surgery with a larger surgical valve 7 years ago, and so he could have 2 more TAVR procedure without much of a problem.
I think if this case failed in the 4 and 5 years later, we should consider TAVR explant and
this case,
which one?
This case, the valve failure presented as AR, right? AS?
AS.
It is
More
AS.
severe AS. Okay.
Mostly
In our-
AS.
In our cases, we see more AR than AS.
Yes,
Yeah,
yes.
There's a
So that's why,
failure.
yeah, that's why I say it probably because of under-expansion.
I think he's 79 and a nicely done procedure, and we are hoping that give him 7 to 10 years. He's going to be 89. So I think he's done well, and hopefully a good dilatation, and perhaps not a further dilatation. I don't think he can stretch it anymore. I think it's a really good result, and I think it'll be a good outcome for this patient.
Yes, further because of
CT?
using balloon expandable valve, it can be rounded more and have a better radial force. So I think the result should be last longer.
Yeah, I agree. So
How amazing this case. The patient now already have 5 artificial valves inside the heart. Is it
Yes, I
broken?
think,
Yeah, mitral have 2, aortic have 3.
It's granted from the current technology.
Has broken the world record.
Yeah, in the future, he maybe have another mitral.
So, are you wanna say the age the era of transcatheter valve intervention is coming?
Always in debate for lifetime management, especially like Dr. Watson said that maybe less time we can consider. Even this time, we also still consider reduced surgery for late aortic valve. But yeah,
it is really, I'm reluctant to do that because the patient is getting older and older.
Dr. Lee, I think this is the last question. After this patient is underwent 5 valve, 2 mitral position, 3 the aortic position. What is your strategy, anti-thrombotic, today procedure? Would you like to use NOAC or DAPT or aspirin alone? What is your strategy?
Anticoagulation, Dr. Lee. Yeah, the connection. In our center, we usually use anticoagulant for 3 to 6 months until the re-endosalization, then switch to single antiplatelet. Yeah, Dr. Ho.
Dr. Yin, I'm from Shanghai Tongji University. The main problem for this patient, I think the movement of the valve is also play an important role in the gradient. So before the procedure, we can see that the patient's aortic valve, the THV is very restrictive. But after the new valve, the movement of the aortic valve is okay. So this may decrease the gradient and also make the patient's long-term results better before procedure. So this is my comments.
Yeah, we hope so.
Okay.
Okay. Anthony, do you have any final comments of this case or showing something?
Yes, we done the sentinel, and you can see a tiny spot over here. And sometimes we can show a lot of the. You can see a black spot over here. It should be the debris over there. So we always found something, especially in valve cases. So that's why we routinely use the sentinel protection device. But the capture particle is not related to clinical symptoms. And we still try to find the best way for the sentinel and hope to find who is indicated and who is not indicated.
Okay, thank you. We have Professor Wang Yan to do some comments on
just
this
the
case.
question already showed me the thrombus debris in the filter. So I just question for this particular case, we always use cerebral protection for valve high risk, and for the de novo valve, what kind of a case you want to use the cerebral protection?
Dr. Lee, would you like to comment?
Yeah, thank you. That's your comment, and this is a good demonstration for lifetime management. in the 10 years ago or 7 years ago, we think that the life expectancy for this patient should be 80. However, the life expectancy for human Lin is more and more, so that we must face him more and more the table. So that's a big issue, and hope the technology and the clinical evidence can help us to solve the problem. And just not long time ago, we just doing the break, and this is the first few cases of the break. And I think that in the future we should do more post-dilation double tap for this kind of patient and improve hemodynamic. Thank you.
Dr. Hong, last question.
Hi, it's really not a question. Hi, Yong Zai, congratulations on a very successful case. So it's not often that we get surgeons and cardiologists sitting in the same room discussing this topic wholeheartedly. So just going to throw a very controversial idea. This is a very good case to demonstrate that if your valve is not fully expanded, your durability is a problem. So the second valve was a problem. So just throwing this controversial idea that maybe the first valve should have been a TAVR. And then you go for explantation. Because the first valve is a TAVR, the durability will be better, right? So your evolute valve would have lasted long. And then you go for explant. Now, explant has been viewed as a high-risk operation, but Shinichi's group in Michigan has recently published. Elective, well-trained team can keep the mortality under 3%. In his hands, it's like 1 or 2%. So if that, you get a surgical valve in at a reasonable age, patient is still low risk, then you have an option of a valve-in-valve as a third valve. Then when they are like near 100 years old, they can have a, what Yong Zai just done. Right? Okay, anyway, just a controversial topic.
I think we should think about the lifetime management. Yeah, thank you. Thank you, Yong Zai, for your excellent case.
Thank you.
Congratulations.
And thank you for the team.
Yeah, we have a good start. Then we move to Shanghai, Fudan Zhongshan.
流动不流动台？喂，等会，喂，各位，大家好。
Yes。
能听到吗？
达西 ，Professor Zhou，I'm Dr. Yin，我伟贤啊。请介绍你的病人，Please introduce your case， yeah。
那么，这里是复旦大学附属中山医院的导管室。
谢谢。
非常荣幸今天呢有机会给大家同道展示我们的一个病例，是纯法律的病例。那在我的右边呢是李明辉教授，还有2位呢是我们的一个同事，我们的技术员呢是陕安，超声是葛振一医生，华电室呢是王慧玲老师。那么下面呢有请我们李明飞教授给大家介绍一下整个病例的一些情况以及我们的方案。明飞。
好，各位线上的各位专家，各位教授，早上好。我们这里 case 呢是一个86岁的女性，是大概 BMI 大概是一个 1.29， 是一个低体重的一个老太太，主诉就是一个反复的胸门屈促5年，加重1年入院的。那么诊断考虑就是个重度的 AR， 既往是一个冠心病，放过支架的，同时呢，它合并有一个慢性的心轮不全，心轮大概3级，另外有高血压、糖尿病，还有也装过起搏器。那么入院呢，我们体格检查，我们看到收缩压是145，舒张压稍微低一点，54个毫米汞柱。那我们的听诊心率大概是78次每分，60期的，其实是个窦性的心率。那么主动脉瓣听张区呢，舒张区可以听到一个3级的一个舒张期的杂音。那入院的实验室检查，我们可以看到它的 NT-BNP 是明显升高的，是2400左右。那么同时呢，血红蛋白偏低一点既往也没有明显的出血病史，同时血小板也是有一个轻度的降低73那么我们 STS 评分呢是一个 7.94， 属于一个外科高危的因为高龄的患者，所以我们的做TAVI的适应症还是明确的。那我们的这个echo 我们的心超就提示一个重度的主反，同时呢合并一个轻度的阿基曼反流。EF 值呢是稍微低一点53， 那舒张墨镜呢，左舒张墨镜是54个毫米，舒张墨镜是39个毫米，左方是稍微大一点，42个毫米。那肺动脉收缩压也是轻度升高的，42个毫米汞柱，那么同时还有一个轻度的3点半反流。那我们术前的冠脉 CT 评估提示啊，我们的前降支近端的支架呢是通畅的，那么右关近端大概合并一个15%到30%左右的狭窄啊。好，下一页。那么入院心电图提示就是它是一个窦性的节律呢，合并有一个 STT 的改变啊，提示心室是有肥厚的。好，下一页。那么入院我们常规的心超，我们可以看到啊，这个人的解剖相对来讲还是没有那么复杂，根部角度大概在45度啊，不是一个特别横的。那我们的这个直观去看半环平面去往上扫，这个人半夜呢还是有一点点增厚的啊。好，下一页。那我们整个这个CT 主动脉结构可以看到，它在瓣上2到8个毫米，基本上大概落在22到24个毫米直径。那么我们的瓣纹测下来 ，CT 大概是在21.7个毫米。那么流出道是直径大概在22个毫米，没有明显的一个像喇叭形的一个扩张啊，瓣环不是很大。那么 STJ 呢，大概在26.4个毫米直径。那么我们的 AO 呢，大概在34.8毫米，那不是很粗啊，不是很宽。那我们的冠脉啊，TAVI 的我们重要的一个评估点就是 TAVI 的这个冠脉高度。那么左冠是9.9个毫米，窦到 commission 的距离呢，我们3个都测下来，基本上都是在31到32个毫米之间，都还可以啊。右冠高度大概16.6个毫米，那么综合评估下来，这个人冠脉风险还是比较小的。那我们 CT 分析，我们的释放角度大概是在右足的位置啊，右前斜35度，大概到夹角34度。好，下一页。那我们的入路评估，基本上我们可以看到整个血管啊，我们考虑用右边，那右侧稍微有点迂曲，但这个血管直径基本上是在这个7.0左右。那22个 French 的鞘应该是可以的啊，翻叉也是比较低的，穿刺都是 OK 的。好，下一页。那么结合之前的这个数据分析呢，我们中心呢就是考虑选的是24或者是27的额头辅助道路型心脏专家可以讨论一下呢。我们是一个纯反流的 case， 用自膜瓣去做。那我们的病史就汇报到这里，下面把主持交给周大兴教授。
好了是吧？好，那么下面我们请我们的超声葛正义医生把这个超声的这个主动脉的解剖特点跟大家汇报一下。
各位专家老师好，我们这个患者他主动脉瓣是呈3叶式的，右无交界处有局部的钙化，瓣膜稍增厚，没有明显的狭窄，峰值流速大概是2.1米每秒，峰值压差是18毫米汞柱，平均压差是8毫米汞柱。彩色多普勒提示重度的主动脉瓣反流，缩流颈宽度是7毫米，瓣环前后径是20毫米，这是术前经胸测量的。那么我们刚刚术中食道超声测量的数据，有夺室流出道的前后径是19毫米，3维测量的夺室流出道宽度是17×22毫米，面积是3.1平方厘米，周长是65毫米，瓣环前后径是22毫米，3维测量的瓣环的距离是18×22毫米，面积是3.6平方厘米，周长是69毫米。主动脉窦部的前后径是30毫米，窦管交界的内径是25毫米，升主动脉近端内径是29毫米。
好，刚才呢，葛正义教授呢，把这个病人的这个特点，就是心超的特点，给大家汇报一下。我呢简单的做一个小结。这个病呢是86岁一个老年女性，从解剖结构上看呢，不论是 CT 和超声，就是瓣膜呢重度的一个反流，这诊断是明确的，有呢做 TAVI 的这个摄影症。那么从这个瓣环来讲呢 ，CT 测出来是66.6，上维超声呢是67.5，这个重合性还是比较好的。那么瓣叶呢稍微有点增厚，我们呢就是准备用一个做狭窄的一个直筒状的质膨胀的这个瓣膜呢来做这个手术。这个瓣膜选择呢，我们上海准备选用上海微创公司的这个瓣膜。我想请在场的专家给一个指导，用多大的瓣膜比较好？我看俊杰教授、方杰教授还有伟贤教授 以及各位同道，各位就是业界的领袖人物，帮我们指导一下，看看用多大的瓣膜比较合适。
I think 张俊杰教授 have more experience than us with the use of VitaFlow. So 张教授 would you like to comment?
OK，达兴主任，这个 case 非常好，是一个重度的阻壁。I think it's a severe aortic regurgitation. According to the CT analysis, the aneurysm, the parameter is 67, and also LVOT also 66, and also the STJ is not so enlarged, and also the normal aortic diameter. So according to CT analysis, I will consider VitaFlow 24 will be suitable for the case. 所以达兴主任，我觉得选择24，我觉得是一个好的选择。
I agree. 24 VitaFlow valve. 方金教授。
我也非常同意这个24可以，我看那个机制啊，它这个应该就是退行性变，这个半夜的这个退行性变，以后我觉得这种病人会越来越多，老年人，因为我们看到它整个结构并不大，这个因为很多病人实际上是那种继发的，那个肾主增宽，这个病人没有增宽，没有那个，它是半夜本身的病变引起的，然后整个结构我觉得很适合，确实很适合做这个应该自盆瓣是适合的，然后24也适合的，非常
根据前面的假弧结构呢，我想这个瓣膜的铆定，一个呢是瓣环，第二个呢就是肾主动脉，还有它本身的肥厚的瓣叶呢，也有一定的铆定作用。所以我们就专门选了24的瓣膜，24的瓣膜呢，它的底部呢是25的就 diameter is 25 millimeter 所以我们准备选这个瓣膜。那么这个投射的角度啊，投射角度。那么从2010年我们开始做这个瓣膜的时候，当时我一直在思考，到底我们用什么投射角度能够最好的展示，然后让我们非常安全的放这个瓣膜。那么经过那个很多次的一些反复的思考，那我认为呢就是无冠窦啊，基本上是最低的，大概在1%左右的病人是右冠窦也会低一点，但是无冠窦基本上最低的。那无冠窦最低呢，我们也应用到这个反流的瓣膜身上。那么经过那么多年的演示下来，做下来以后临床实践下来，认为这个无冠窦作为支点是非常非常的有效的。那么文字教授呢就把它总结为 NCPI。那 NCPI 呢，经过我们全国同道事先的这个临床实践反复证明呢，认为还是可以的，特别是对致膨胀的这个瓣膜。那可能是有定位镜的瓣膜，可能又是另外一种释放方式。今天我们不讨论这个，就主要是讨论这个NCPI 以无冠窦作为支点的这个释放的方式。那么前期呢，我们把这个主路啊已经建好了，主动根部的造影呢给大家放一下，导播，这是个重度的一个主动脉反流的病人，我们就准备放瓣膜了。
This patient has 3 anchoring zones: supraannular, annular, and LVOT. So it can be categorized as the Aurora type. Do you know the Aurora type? Finding the 3 anchoring zone. If the 3 anchoring zone exist, the success rate will be very, very high. So for this patient, I think the success rate should be okay, because the patient can be held all the way from supraannular to
But a lot of AR patients also accompanied with the dilated aortic root.
Yes.
So sometimes you cannot anchor in the
but not this case.
Yeah.
Yeah, according to the publication, they select the patient, at least 2 anchoring zones, and they can only successfully recruit 50-something% of patients. It means that half of the case was mentioned by Dr. Lin. It's not doable with the self-expanding.
I have no experience TAVR in severe aortic patients. I'm curious. So how much this patient has no calcification, almost no calcification.
Minimal.
Yeah. So how much oversizing is appropriate in such cases in the selection of the valve size?
In the original publication is 20%.
So the anchoring is depends on depends on the anatomy of the aortic root. No, the calcium.
All the way from yeah.
There's no calcium.
And fibrotic tissue.
So this is not like the JenaValve or JenaValve. There's a locator to grasp the
different anchoring mechanism.
Actually, for this particular case, the oversight ratio only 12 according to the aneurysm diameter and the valve size.
Yeah, you revised the Aurora criteria to 10%. If the size can be oversized for 10%, more than 10%, it should be okay.
What is the tip and tricks of this valve? Because
往上来一点啊。
推一点。
It seems to be very difficult to deploy it.
准备安全啊，准备抓引啊。
So we need to go a little bit deeper to have a better anchoring.
差不多位置吧。
or
no, they do it very high.
抓引。
Deploy very high. 张教授，你要不要讲一下这个 vital flow 怎么放？是它是一个电动的 mechanical motor。
起搏人准备啊。
Electrical。
这个超轻量多少？超轻量200。啊，200。205
分钟。
我们的起搏是180啊。
This is 24。
我们有个地方它是比较低，看到没有？所以我们着的点是最尾巴最低点啊，往前去一点。 老师稍微拉一点。
By CT measurement, would that be a problem if we use a 27?
超轻量200了吧？啊。
Yeah, I think so.
You want to be bigger?
放，准备起搏，准备抓引，先抓引啊，抓引，可以的啊。起搏180。
Very high.
所以达兴，您现在用的是 NCPI 是吧？在
NCPI yes。
无冠豆对。
好，
这条边。
好，那再放，
差不多了。
再放一点，好，行，起搏停，来，到那个主席前。
所以刚才达兴教授快速起搏线，用 NCPI 的方法快速释放到了。
那个石头往后退一点。 大屏，我夹角，屏幕当心一点。哎，这么多人站在这里，来，他说把屏幕 hold 住嘛，来，准备抓引，打。那个葛正一给我看一下，来看看心超。瓣膜的位置已经放好了，我们现在来看看心超。心超是不是有没有位置在那个？
心放动一下。
心超放一下。 心超放在屏幕上，让大家看。
有没有看到？我们只是觉得会不会太高？
啊，不高。心超，
没有，
我也没看到。
再接一下。
来了。哎，又没了，要稳住一下，稳一下啊！来个人稳一下。来，我们可以看到心超呢，它所有的瓣膜的位置都是在那个，来扫一下，看那个无冠豆，看右冠豆。 好，右冠豆，那个接触一点不太好，都是在那个半下，不在半上，对吧？不在半上，没有在豆里是吧？没有吗？扫一圈，再一。
Is it a bit high on the coronary?
Yes.
To us, yes.
The valve must be higher. Must be high. 来，
我觉得它整个半架是桶状的，应该很稳定。
放。
位置是好的 ，I think the position is good.
对，它半架稳，
倒退一点，
那个桶状的
退一点。
Vital flow very strong radio force.
放。
So
达兴，这个时候你需要快速起搏吗？
不用。
OK，
慢慢放，要慢慢放，让它逐渐释放自己的张力。
需要把注意把导管拿掉吗？ 因为等一下要拿掉，会不会有点？
停，现在拿，现在就拿，现在拿，因为做一把导管，做一个现在他 hold 住它了，没问题，现在可以，有道理。好，慢慢放。那放的时候呢，我要推一点瓣膜，大家拉点导丝，慢慢放，推一点，轻轻的推。放，全部放掉。好，好像还有个头没有放掉，来，来。
那我收一下。
不，来收一点导丝，因为我们的导丝呢，它会摩擦我们的心链膜，有的时候会把心链膜给磨坏了。再收一点。
哦，
好，有没有那个没有释放完的呢？那个地方？
我打点左肩再看一下。
啊，好像有个地方没有释放完。
对，有个地方像是挂在钩上。
挂在那钩上。那我们往前回收一下，把毛让它顶烫一下。
好的。
好。
我轻轻试。
轻。好，感觉全部打开了。
我
回放。有没有地方没有打开的？
来换个角度看一下，应该
角度
换一个角度，
右角度，右线都小，因为这个都是小，
深度小。3个点是多，1个点2个点，还有个点呢？
工程师再帮我看一下，来，好像有个点没放开了啊？
对，
现在看到了2个 paddle，
还有 paddle 没看到啊？
还有一个 paddle 呢？
还是没看到啊？
好，行，就这样，你拉导丝，导丝抽，让我们的那个 chip 到达那个瓣膜的中间，让它变个形，也许就能脱了。好。
没有，我在中间还有那
个。再来一点。
再拉一点点啊。
我感觉没脱啊。
对，我感觉也不像脱。
行，停，等一会儿，再看一下。右线写，这个位置往右打。脱了吗？
不明显。
3个 paddle 吗？看到3个 paddle 了吗？我只看到2个。
我也只看到2个。
就2个对吧？就2个，好的，那没问题。那好，就这样啊，我轻轻往回撤了啊。我不往回撤是不行的啊，一定我看着往回撤，已经离开了，很好。
脱了，
没问题，脱了，没问题。盯导师，
没问题。
好，好 ，very good。
小心，好，非常好。
好，这可以出来了。我不要回收，因为那个 chip 它是一个椭圆形的鼻椎，它没有问题的。我想，就这样反而更好。回收的时候呢，它那个鞘管呢有可能会刮住我们动脉。那么我们现在呢，进换助耳把准备照个影。如果结构合适的质缝了的瓣膜，它这个做这个反流的病人效果也是非常非常好。首先它不会穿到组织啊，因为它位置放的高。第二个呢，反流它完全没有反流，做好以后它完全没有反流。在我们在释放的时候，在回收这个导丝的时候呢，一定很缓慢。有的时候这个导丝可能挂住我们的按键瓣，如果很快的话，它就会扯着按键瓣。慢慢收的时候呢，它可能心脏在收缩的时候就会离开按键瓣。来，这导丝。OK， 我们准备照个影啊，在释放体位照影，不用恢复啊。
我不清，
我的那个主尾巴在上面是吧？
看
到了吗？
是，好快。
要选好。
主要是看起来那个舒张压蛮低的。
舒张压有点低啊。
ART 是69啊。
不是 ，IO 是 IO 改成 LV，
它模式错了，那 IO 改成
LV， 对。
我们的 ART 是
70了，舒张压是70。准备照个影看一下，给大家展示一下这个瓣膜的工作情况以及冠状动脉的情况。下面平了吗？
下面可以。
好的，很好。 好，准备造影，打。好，这是非常好的位置，非常好，
非常好，临位。
临位，临位。
达兴可以再展示一下超声吗？10道超声。
超声，10道超声，再给大家展示一下。现在看超声，这个瓣膜临位的瓣膜呢，它不会往上跑，因为舒张压压住它，它也不会往下跑，因为窦呢就是整个那个瓣环就箍住它，它没有肌肉压迫它。如果靠近下面肌肉压迫它的话，它就会逐渐往下跑。所以呢，这个瓣膜呢，它不会随着心脏的跳动而有改变位置。所以呢，这个就非常的稳固，不会有任何问题。我们超声可以看到，这个在母系部位是临位，在母系部位大概是在1到2个毫米。这个释放一定要非常的精准才行。
达兴教授，请问是不是只有 VitaFlow 可以这样子做，还是你们有没有试过像 Venus 啊或其他的瓣膜
？Venus 也是可以的，也是可以。但是我们医生总是希望用自己最熟悉的这个 device， 所以我对这个 Venus 呢比较熟悉，用来治疗这个反流的瓣膜，所以我今天演示呢就是用 VitaFlow。
因为我们的了解是
Venus A 呢，我也做过一部分的病人。
是我的意思说差异了，是不是2个 radial force 不一样，所以底部的 anchoring 的力道会有差别？
是的，会有差别。但是我的理解啊，不一定正确。就是说一种收腰的瓣膜，包括Venus 或者是佩嘉这个 Taurus， 它有收腰。收腰呢，它这个瓣膜在释放到鞘骨外面的时候，它就有一股向下扯的力。这个力呢，按照这个力学的原理呢，它有向下。如果这个瓣膜如果不是你不能从最高处放的话，它就会跳到主心室，有这种可能性。所以呢，这个我们一定要把这个瓣膜放到从这个零负的开始放，一边放一边往前推，然后这种着落的时候呢，在瓣环上。如果你这个瓣膜呢，贴到靠近肌肉了，特别是舌间隔，那肌肉收缩压迫这个瓣膜，它就会把这瓣膜逐渐在这个舒张压的加持下呢，这个瓣膜呢，它就会往下跑，往右心室，不往主心室跑，它会拖到主心室，有这种可能性。对，但是呢，这个直筒状的瓣膜呢，它镜像支撑力是基本上垂着于它这个锚定点，你比如是这个瓣环，它就垂着于瓣环，所以呢，它在释放的过程中，同时它使用的是那个电机释放的，它步进电机，所以它就比较稳定，不像我们的手放的时候呢，有一种顿挫，它步进电机比较稳定，所以呢，我对这款瓣膜呢，上市前的临床研究也是葛院士PI， 我们中心 PI 单位联合包括俊杰他们一起这个研发了这款瓣膜，所以比较熟悉，比较熟悉。
Yeah, so it seems that two key issue is the first one is the cylindrical shaped inflow portion can provide better anchoring. Otherwise, you will just deep dive or upward. And the second is that it's an electrical control system, so you can very precisely deploy it without any manual motion or excessive motion during the deployment. So this is, I think it's specific for this VitaFlow, yeah.
But most of the aortic regurgitation, we see the aortic root is not so tubular and small to give the support.
Yeah.
So if we were to deploy in the kind of usual cases that we see, it will pop up immediately because the support on the top is not so good. But here it's almost like a tubular, similar size, so sort of helped him in that sense.
And the supraannular portion is not well expanded because of holding by the aorta.
I'm curious about this. You know, sometimes we do abalone valve. It's a large size abalone valve, pure AR. That is, we experience some slippage of the valve. It's low down and up down.
Yes.
And the VitaFlow and much better.
It's cylindrical shape, so it won't move up and down. you put where, and it will fix there.
Maybe if you implant a little bit deeper, that would be moved downward by the pressure.
pressure.
那么我们把这个术后的压差给大家再汇报一下啊。ART 就是桡动脉的血压，是苏张压是60，纵时压是107。再把那个我们补益再加强力补益，那个在那个分主动脉的压差给大家汇报一下。
好，我来测一下 L
压力。然后等会呢，我们再请超声的教授葛医生再把超声的情况、血液动力学瓣膜的工作的情况给大家再汇报一下，好不好？
达兴，我们先进个演讲啊。
好的。
谢谢，
感谢大家，感谢
非常棒的 case，
感谢
excellent， congratulations。
指导，感谢金教授，
谢谢，
好，谢谢大家，谢谢大家，
达兴教授，
好，感谢，
谢谢。Next we will have Professor Lin Mao-Shin from National Taiwan University Hospital to deliver a talk regarding JenaValve Trilogy TAVR for pure aortic regurgitation, NTUH experience, please.
Yeah, thank you, Professor Yin. It's my pleasure to share our first 6-case JenaValve Trilogy to treat the patient with pure AR. I think the AR is quite different to the AS, not pathophysiologically, but also anatomically. Not like the live demonstration case today. I think almost a lot of AR would combine with the dilated the annulus root and the ascending aorta also have no calcification. So that's quite challenging for our current TAVR device because of insufficient anchoring, migration, parabolic, even we have a delayed recurrent parabolic or aortic dissection. So a lot of papers published. So although today's device is very successful, but I think in the real world, still we not before we had not yet a specialized TAVR device. Even we have, but there's a transapical approach. So the Trilogy, the appearance of Trilogy changed everything. So it's transfemoral. I think that's assistant, and get the CE mark in 2021. And then, although they have a single-arm study, published 2 papers in the Lancet to the total population 700, you can appreciate that the 2-year result is quite good for the patient. And guideline tells us that right now is still already have a 2B indication. Is the patient eligible for the surgery and is high and the anatomy is suitable. So right now, there's a randomized study ongoing. I think we should waiting for the result. And another good news is that in this March, JenaValve Trilogy has approved for FDA by the FDA to treat the patient with aortic regurgitation. In Taiwan, we're lucky because we can get the device from special access. So we need to send get it approved by IRB and Taiwan FDA, then do the treatment for the patient. This is our first 6 case done. Mostly they are very elderly. Their average age was 82. And only one is less than 80 because she has ever received the TAVI operation. And all they are symptomatic, and last one has been done in this week. And they have, the average is intermediate risk, and you appreciate that some patient with impaired LV function, all of them have a dilated LV geometry, and high anti-proBNP. So this is our first case. This is 81 years old, a lot of comorbidity, and severe aortic regurgitation with impaired LV function. So another challenge is that the patient is horizontal aorta. The angle is 72. So you can appreciate that from hemodynamic is quite low AR index. So the first one we would do, they have a long, there's a layer future, they have a long sheath all the way from inguinal to the ST junction to protect the locator. And then after that, we retrieve the sheath all the way back to the descending aorta. And then there's a flex system to that more coaxial to the aortic ventricle alignment. And then we put the locator down to the cusp. The next step would be check the locator in each individual cusp from NCC locator, RCC locator, and LCC locator. And then we deploy the valve. In a few seconds, you can see that. And then you can agree that the aortic regurgitation is almost gone. So the hemodynamic, we can see significant improvement. And the second case we've done, this is echo 1 month follow-up. You can see that the LV function improved and the LV size decreased significantly. Then the second one is quite another challenge case because although she is only 71 years old, but she ever received TAVI operation. And the patient, after that, she had a moderate AR and progressed to severe when she come to me. And you can appreciate that this challenging anatomy, AR severe, and more cooperation of LCC and NCC. Okay. Then you can see asymmetric 3 cusp. Then very low coronary cusp, because the coronary is reimplant. So the coronary height is very low, only 6.7 millimeter, and with prolapse LCC. So we do that case by routine. There's severe aortic regurgitation, and confirm the NCC, and then confirm the RCC. But due to the specific anatomy, the patient, you can see that the LCC locator, the first time did not quite easily to go into the LCC cusp. So we retrieve a little bit the valve, and then adjust the flexor that to close to the lesser curvature, and then re-advance the device. You can see the LCC locator will then go into the LCC cusp. Yeah. So we confirm that by the MP catheter. This time we confirm that it's different from the previous one. So the last step was deploy the valve. Yeah. Okay. So you can see that, yeah, the valve flow regurgitation also gone. It's the hemodynamic. So the 1 month follow-up is quite good. Preserve EF and the LV size shrink. So that's from reference. I never heard about the JenaValve Trilogy has been reported to treat the patient with after TAVI operation. So we published a paper in the European Heart Journal CAS report. And we have already followed the patient, and you can see that all the procedure deployed successfully, no pop-up. No one pop out, and the AV block rate is 616. And you know that we are doing the minimalist for any kind of a TAVR. So last 2 cases, I let the patient discharge on the next day without ICU admission. And from the 1 month follow-up, you can appreciate that the LV function average increase, NT-proBNP decrease, and the renal function also improved. So we can see that right now we have 2 cases more than 1 year follow-up. You can see their biomarker change, creatinine in the average they decrease, combined with the NT-proBNP decrease. So it's quite impressive for myself than the treating with the aortic stenosis. And the LV function improved, and most of the patients, almost all the patients, their LV diameter, either systole and diastole diameter decrease. So, but now we still have a lot of challenges, like patient selection, what kind of case can benefit from the device, and high pacemaker rate, and not every anatomy can fit for the suitable for the device, and we still need to waiting for the result of this trial. So I think that in conclusion, aortic regurgitation is quite challenging for us for the current TAVR device. I think the JenaValve Trilogy is game changer for AR treatment. As being a 10-year TAVR operator, I think that the system was quite steady, not complicated, and the clinical improvement was very impressive. But I think that our challenge in the future is to select the optimal patient, and we should waiting for the result of ARTIST. Thank you.
Thank you. Excellent talk. Allow 2 short questions.
So the pacing rate is quite high, about as high as 20%, right?
But from the online AR study, when you're getting more and more patients treated, the pacemaker rate, you learn a lot and how to adjust select the size. The pacemaker we're down to the 15%. But of course, right now for the AS TAVI, it's a little bit high. But I think that's the space we need to improve.
Okay, as I noted, the distal end of the locator is a pointed one.
Yeah.
And the JenaValve is a rounded one.
Yeah.
Is there any issue
Perforation.
regarding the perforation of the cusp?
Right now, we not yet have such condition. But yeah, of course, especially for the horizontal aorta, sometimes the LCC cusp, already we in the bottom of LC cusp, but the NCC is not yet. So we need to push and whether to injure the LCC cusp. I think, but right now I still have not yet seen.
Okay, thank you very much. Okay, and the time is up for this session. We have a wonderful discussion and 2 very great cases. So thank you for your participation, and thank you all for the panelists of this session. Thank you. Thank you.
接着我们的 panelist 来上台，我们接着要下一个节目了哈。Distinguished guests, my dear colleagues and ladies and gentlemen, so please join to this section 2 in this morning. And in this section, we'll talk about the TAVR redo and the valve from feasibility to lifetime strategy. So in this section, it's my great honor to co-moderate with Professor Jian from Canada, and I'm Dr. Yi Zhangxue from Chang'an Memorial Hospital, Taiwan, and as well as the Professor Kentaro Hayashida from Keio University, Japan. Welcome, Dr. Kentaro, and he will join us online. Welcome. So we also invite some experts to be our panelists. The first one is Dr. Atsushi Sugiura from Asahi General Hospital, Japan. Yes, and the second one is Natal Wood, Wang from Thailand. Yes, and we also have Zhongshan from Far Eastern Memorial Hospital and Taiwan. Oh, sorry. And we also have our guest, the Professor Inho Che from Korea. And as well as the Jian Lu Cai from the Kaohsiung Medical University Hospital. Oh, Zhengxin, oh, sorry, Zhengxin. Okay, sorry. And we also have the Qingwei Li. Okay, no? So also Dr. Wang from the Xiamen Heart Center. So at first, I would like to introduce our first speaker, Dr. Kentaro Hayashida from Japan, to talk about the first speech. The title is the current status of the OCEAN-SHD family. As we know, the OCEAN registry is quite large registry in Japan. So I think this title is also, this speech also is very informative. So Dr. Kentaro, please. Thank you.
Yep. So can you hear me?
Yes, we can hear.
Okay, great. Thank you so much for having me. Unfortunately, I cannot attend the meeting on site because I just moved to the another center from this April. And so let me see.
Yeah, we cannot see your slide. Sorry.
Yeah, sure. Does it work?
Yes, we can see it. Thank you.
Great, thank you so much. So today, I'm very much pleased and honored to talk about our OCEAN-SHD family and the current status and future perspectives. And this is my disclosure. So actually, I was privileged to learn TAVI procedure in France from 2009 to 2012 under the instruction of my mentor, Dr. Thierry Lefebvre, who's already retired. And at that time, I stayed in France for 3 years. And the last year, so we had the new Japanese guys. The one is the Dr. Yusuke Watanabe, who's now the professor of the Taipei University Hospital. And the other guy is the Dr. Masa Yamamoto. And he used to be the chief of the structural heart disease in Nagoya Toyohashi Gifu. And now that he joined our Kansai Medical University from this May. So we created some registry using the French data. However, so we really need to publish the data from Japan. That was the beginning of our OCEAN-SHD family. So we started this scheme from 2015, and we had the annual meeting every year in our university as well as the other place. And nowadays we have 30 joining centers so far in 300 members. And the patient number enrolled in this registry was 30,000 in TAVI, and 6,000 in mitral, and 4,000 appendage closure. So therefore, it's quite a sufficient number to do some research on these topics. And we calculated the number of the papers so far. And 1 year follow-up was achieved in 99%, and we already published 190 papers so far, including 138 from TAVI, 40 from mitral, and 12 from appendage closure. And Atsushi Sugiura is one of the main players in this mitral and tricuspid registry, and so he's the chair or panelist in Taipei. And we published some data, not only the regular journal, but also in European Heart Circulation and JACC. And some of the papers are accepted in not only Japanese, but also in American and European registries. And I'd like to introduce some papers, and this paper was on the impact of the frailty on the prognosis of TAVI procedure, and that was conducted by Masa Yamamoto and Dr. Shimura. And that is the paper on process-patient mismatch. And not only the incidence of severe PPM is quite low in Japanese cohort compared to that of the American cohort, presumably due to the less obese patient in Japanese cohort. And leaflet thrombosis is also a very important topic, and we published some data very previously. And Yusuke Watanabe conducted the comparison between DOAC and warfarin in a patient who received the TAVI procedure. And based on our research, the DOAC was better than warfarin. And based on these data, we are the part of the MSH TAVI AF trial, and this was published in New England Journal of Medicine. And my fellow Dr. Yusuke Kobari published some data to compare the clopidogrel and aspirin with or without anticoagulation. Clopidogrel was better to reduce the bleeding event. That is quite similar to that of the PCI. And we also analyzed the impact of the no antithrombotic regimen after TAVI. So usually the TAVI cohort has the quite elderly age and high age and very frail patient. That means we sometimes hesitate to give some antiplatelet therapy. And if you look at the non-antiplatelet therapy, we named it at the NAPT based on the recommendation by Yohei Ono. And the NAPT was associated with the less bleeding event. However, it didn't increase the thrombotic event. So we also need to be careful that we need to avoid the cardiac damage. So our earlier innovation may be beneficial for the patient. And Dr. Saito also published the data that the impact of beta blocker after the mitral tear and upsaturation of beta blocker was associated with the lower mortality. That means if feasible, maybe we can think about the upsaturation of the beta blocker. And Dr. Tokuda also published the data on the impact of the frailty after mitral tear, and not only if the patient has the CFS higher 7, it was associated with a worse outcome as well as the that of the TAVI procedure. That was also very important topics. And Dr. Sajagan published on the impact of hand grip strength as a marker of frailty in patients with M-TEER, really the same thing in TAVI procedure. And Dr. Ono published the data of the impact of worsening LVEF after mitral tear. And sometimes we observed the worsening of LVEF after mitral tear. However, it was not associated with the worse outcome. That means that we just improved the regurgitation that led to the worsening of LVEF. So we don't need to worry about that much. And Dr. Mishaki also published the data on the association of the mitral valve area and outcome after mitral tear. And notably, we treated some patients with the mitral valve area smaller than 3.5. That is quite relevant to our Asian cohort. However, we did however, the result was quite similar to other cohort. That means if we can meticulously screen the patient and if we can optimize the procedure, we can do that. And Dr. Yamaguchi also reported on the mismatch between procedure MR and left atrial pressure, and it predicted the prognosis after mitral tear that was accepted in JAK intervention. And last year, so we did a really good job with the Dr. Kagiyama, who is leading the Review AFMR registry. We had good collaboration with them, and we published that the mitral tear was effective to reduce the mortality, even in a patient with atrial functional MR. And Yohei again published data on the impact of procedure or new onset TR on the worst outcome after mitral tear. And after mitral tear, if the patient developed new onset TR, of course, it was associated with the worst outcome that was also accepted in European Heart. And Dr. Asami also published the data on the initial outcome of the appendage closure in our registry. And the GA bleeding was the most common reason for the appendage closure, especially in a patient with the higher age. They were associated with the higher bleeding risk, so we need to be careful. And based on that, we are now conducting the randomized control trial that is mimicking the TAVI-NAP trial. And after anticoagulation, we randomize the cohort into two groups. One is the aspirin monotherapy, the other one is a no antithrombotic drug group. And we enrolled 300 cases, and now we're finishing our enrollment to the 600. And we are very keen to publish the data in the next 2-3 years. And this year we have the 1,400 participants for PCR Tokyo BAPS. So thank you so much for the joining and helping us to develop the very good meeting. And next year we're going to have the meeting on the 17th, 19th February 2027. So you're most welcome to attend our meeting. So thank you so much for your attention.
So, Dr. Kentaro, thank you very much for your excellent speech regarding the OCEAN-SHD family. So I think this is a very important study involved not just only the TAVI, also mitral clip, tear, and as well the LAA occluder. So any question or comment from our panelists? Thank you.
Hi, Kentaro. Natawut from Bangkok, Thailand. Thanks for your great contribution from the registry and the study from ASIAN. And I see that in your population, you have quite amount of patients who have Redo-TAVI and also have some valve-in-valve case. And we experience from our own that in Asian population, we have smaller anatomy, low coronary height, small STJ. So have you look at the incidence of coronary protection that required when we have to do Redo-TAVI or redo valve-in-valve case? Is have any difference compared to the Western population?
So thank you so much, Natalie, for your fantastic question. Actually, the TAVI procedure was just approved in Japan in 2023. And because we studied TAVI procedure from 2013, we don't have that many patients coming back to the TAVI procedure. And now we're collecting the prospectively, but we only have 20 or 30 TAV cases in our OCEAN TAVI registry. And initially, only SAPIEN was approved in our country, but nowadays, Evolut is also available for the TAV procedure, and therefore, so we're collecting the data for these devices prospectively.
Hello, this is Inoche from South Korea. Nice to meet you. And then congratulations to your OCEAN TAVI registry because it's amazing. The 1-year follow-up rate is more than 99%. Oh, wow, it's amazing data. So I have a question about your small annulus data, because in Korea we do have a lot of patients with small annulus. So in your OCEAN-TAVI registry, S3RU and then Evolut FX comparison study, there's no difference in between the two valves. So you know the SMART 3-year data, there was a benefit in the hemodynamics, but there's no difference in the hard endpoint. So in your OCEAN registry, is there any difference in the hemodynamics? And also, one more question about the Navitor valve. I saw in the Navitor OCEAN registry. So is there any difference in the Navitor and then Evolut and then S3RU and in the small annulus?
Yeah, thank you so much. And so actually, we conducted the comparison between S3UR and Evolut FX. So there was no significant difference in terms of the hemodynamic performance. And numerically, the Evolut was associated with a little bit lower pressure gradient. However, it was not associated with the incidence of severe PPM. That means it doesn't have the clinical impact on the prognosis. And we also compared the Evolut and Navitor, and there was also no significant difference between two devices. That means as far as the patient body size is not that big, so we can use either of the devices. However, if the patient has a really big body, and maybe we can think about a self-expanding device with the lower pressure gradient. And notably, that we cannot choose the sapien for the patient with the AVOT calcification, so that it also should be taken into account to evaluate or to compare these devices.
Okay. Because the time is limited, so I have to close the discussion regarding this speech. Thank you very much again for Dr. Kentaro's very excellent speech. Thank you. So on the next, I would like to invite Professor Jian to moderate the next speech. Thank you.
Okay, thanks. Good morning. I think the next speech, everybody knows Dr. Tang. He's actually a true hybrid surgeon and cardiologist, interventional cardiologist. He has been performed surgery and TAVI in lots of cases. So he's a truly hybrid surgeon. So he's not online. He will present, I think it's recorded, right? Recorded, okay. So we can just start it.
Hello, today my presentation is on Redo-TAVR planning and execution. Here are my disclosures. This lecture's goal is to simplify Redo-TAVR for the audience. We will review the steps for procedural planning, simplify implantation view and fluoroscopy, and standardize procedural technique. I encourage you to download this mobile app developed by Mini Papa and Mio Fukui on how to work up patients for Redo-TAVR. This is the basic workflow, and I will not go into detail since the next speaker will go into a CT analysis. There are also YouTube videos available on my YouTube channel to teach people how to do this. Basically, there are 4 combinations in Redo-TAVR: short and short, short and tall, tall and short, and tall and tall. In reality, really, you need to ask which second TAV are you using? Is it a short valve or a tall valve? The 4 key concepts in planning is to know your device and commissural posts, the neo-skirt plane, meaning if your second TAV is tall, the NSP is in the commissural post of the first TAV. But if the second TAV is tall, then it depends on where your second short is, the second TAV will be landing in the first valve. Concept 3 is the coronary risk plane, which is CRP, which is represent the longest margin of coronary office. And finally, concept 4 is the electric coronary risk zone, with a minimum distance of 4 millimeters clearance, starting at the NSP looking back to the CRP. Here is the concept 1 showing the commissural tab of the SAPIEN 3 valve is actually located on the top of the tabs, not the crowns. And you can see the envelope is up to the middle 6 for 26 to the 34 valve. The second concept is the second TAVR tall. You can see the NSP is right at the top of the commercial holes of the first TAVR, whether it's a tall index valve or short index valve. But if the second valve is short, you can see that you can adjust the NSP by implanting the second valve deeper, as you can see here in the short and short or short and tall combination. The third concept of the CRP basically is where is the CRP relative to NSP. If it's below, you have for both coronaries, you have to assess the risk for both. But you can see on the right side, if the CRP is above the NSP, and you can see that there's no need to worry about coronary obstruction risk. And so in summary, you can basically look at this blue area called the zone, and you can see that here in this case, the minimal diameter would be 2 millimeters or less for high risk of obstruction. And you just measure the minimal distance on either side, depending on the relative distance between the CRP and the NSP. So let's give an example here. If the second TAVR is tall, we do measure the minimal distance of the VTA in the CRC here, and you can see the shaded in blue is what this look like in tall and short, and tall, this is what the distance will measure. But if it's short and short, it really depends on where you will land the second valve. So in the first case, you can see to measure both the right and the left coronary. In the middle picture, you can see only to measure the left because the CRP is above the NSP on this situation. And then in this configuration, where it's really deep, both coronaries above the NSP, you don't have to worry about it. In the short and tall combination, you can see that here, the outline of blue in terms of distances, you need to measure in this area to make sure you don't have sinus sequestration or coronary obstruction. One word of caution is that when you put a short and tall combination, you can see that here, the index tall valve will expand outward. So these distances you measure in CT will be less than you think. So just be aware of that. In terms of sizing, if it's the index valve short, you can see just measure 3 levels. But if it's the index valve is tall, you can measure where you can land the short valve to be able to calculate the sizing. In addition to that, you really want to look at the pre-index TAVR CT to see how much oversized you might be, or whether the index valve is undersized, and then use a frame alignment to guide your implantation. So this is a paper that's under revision with non-jack intervention showing the sizing of the second valve to determine whether you're going to treat in vivo sizing or you can need to make it to a downsize or upsize. So you might need to downsize if the first one is grossly underexpanded and you're concerned about second valve being even more so, or you work on obstruction risk. In short and tall, typically both recommend downsize because of migration risk, and you may need to upsize in terms of short and short if it's PVL, or in the short and tall combination if you work on LV migration risk, not because you're undersized in certain parts of the anatomy. So here's some examples of Redo-TAVR cases in different combinations. And you can see that here in the case of the short and tall combination, even if you try to land it in a certain target, sometimes you can get there just right away, as you see that here. So in terms of technique, we typically would prefer recommend pre-validating the index valve, especially if it's underexpanded, because for the second one, when we get into the cross, we recommend procedure to be done the GHE to minimize unexpected motion. The second time, if it's short, should have a slow two-step inflation and be coaxial. In short and short, you watch for the outflow for shortening in addition to the inflow. In short and tall, you watch for upward or downward movement. And tall and short is more straightforward, but you don't want to have a deep implant. In fact, we recommend both that and both second valves to optimize expansion as we show why. So the step one is identify the frame alignment view. You can see that here that you want to take the parallel cell of the index valve and align all the cells to make counting easier. And you can see that here in this identified positioning where you want the second valve to be by having this frame alignment. Now, in terms of coronary protection, you want to see that if you pre-dilate, you're going to expand the first valve potentially, and that can reduce the distances. When the second valve is short, Redo-TAVR will also expand the index valve. In a short and tall combination, the second valve may move up and risk coronary obstruction. And so you might want to protect the coronary, even though you might be able to do lesion modification, for example. So step 3 is pre-dilating the index valve, and there's the algorithm we're proposing. And the key is that if you need to optimize the frame expansion, then you need to use CT to guide the balloon size. And if you worry about root injury, then you might want to do a smaller balloon. In terms of short and short, you might want to expand the index valve so to avoid underexpansion of the second valve. In terms of short and tall, it's really to facilitate valve crossing or avoid balloon rupture during the second valve. So here's an example of a deep implant sapien, and we want to expand it further because you can see how underexpanded it is. And you can see that quite well in terms of before you put the second valve in. You can see that here you can put also the tall valve. And the reason for doing that is to facilitate valve crossing rather than expanding the index valve unless the mechanism is through the PVL. Step 4 is to position the second valve. You can see the different combinations here in terms of how you position. And that's why it's so important that the framing line might be able to make identification of the target easier. And so in tall and short, it's pretty straightforward. You want to aim for inflow and inflow, and you have to make sure it's coaxial. So here's an example how it looks like. On the left side, you can see it's clearly not coaxial. You can see it very high on one side and relatively deep on the other. And you can see by adjusting it to the more outer curve and making it more symmetric, it's a better positioning in terms of release to avoid any unpredictable movement during release. The short and short combination is relatively straightforward. However, you still want to maintain coaxiality, and if you work on coronary obstruction, you should protect the coronary if lesion modification is not feasible. So you can see, for example, in both cases, with the right and left main, and you can see this is a case of a sapien 20 and a 23. And you can see the next one is the 23 and 23. As well, you can see how you can avoid coronary obstruction by positioning in a more suitable path. The short and tall combination, that's probably the most challenging one. You really want to make sure the short one's coaxial with the tall valve, very slow inflation. You want to make sure you protect the coronary, especially if the valve may move up. So, for example, in this case, you can see it's very coaxial. You want to be able to see that the coronary can be visualized, and you can also see that how the index element can expand further. And this is another example here showing a different combination of the navigator in terms of avoiding obstruction risk and making sure it's coaxial when you're deploying. Step 5 is post-dilatation. We typically post-dilate not because of PVL, but because we really want to avoid frame underexpansion of the second valve. And you can see that here how done that in terms of sizing. If it's the second valve and short valve, typically you double tap or one add. But if that's not sufficient, you might have to do some non-compliant mode, as long as you don't lead to obstruction. So you can see that here this is a 23, 20, and a 23, or 23, and a 23. How we can really optimize the frame expansion of the second valve. And you can see that in the next case, here looking at short combination by post-dilating, you really maximize the frame-to-frame contact here of this particular combination. You can see that here in the next slide, showing now 20 millimeter and 29 combination of 26 and the 29 on the core, really allow the frame expansion of the sapien inside the next 12. So this is a recent paper that we published with that despite optimization pre and post, all the second valve were underexpanded relative to normal dimensions. And so this is a word of caution in terms of optimizing the index valve, and also the second valve to make sure they are all together. In summary, so Redo-TAVR planning can be simplified and standardized. You can see that the app, and also for the concepts of workflow, you really need to look at CT and follow-up, acute complications. So the second tab remain underexpanded despite procedure optimization we saw earlier. So I think we should do that routinely if it's safe. But it can be standardized, and we can see that how we did that. We used this frame of line review of the index tab to help identify the NSP and CRP and identify the target position. We treat that into health crossing and also expand the index valve. We do a slow inflation in the short and tall combination, whereas the tall and short is pretty straightforward, just go inflow and flow, and we post that to optimize the second expansion. And this is a sum figure of our paper for short and tall, Jacket image under revision, showing the step-by-step and best practices. Thank you very much for your attention.
Thanks. Since the speaker is not online, I think we can, what time is it? We still have a few minutes for discussion. So I think, this Redo-TAVI, I think we're getting more and more. I think in the US is really like increased dramatically. The lines, you can see this going up so quickly, more than 45 degrees. So I'm pretty sure in the future will be 90 degrees because the TAVI all implanted in the 50s. So you can expect to have so many Redo-TAVIs. I think, this guidelines is really important for get a successful implantation, but honestly, the valve is so variable with the different type of valves and structures, and the frame is different, so sometimes it's very difficult to standardize. And I just have one thing, like a question, for the redilatation, I think you mentioned the pre-redilatation. I think I need to be a little caution for the valve because the majority is valve, the prosthetic valve calcification different from native valve calcification. They are really easy to break down, cause embolic event. So if you do a frequent pre-dilatation, you may need to protect the brain because the embolic is higher than native aortic valve. So I think should be cautioned. I personally, I usually don't do a pre-dilatation unless you're necessary. Unless necessary, if we're underexpanded or something, need to crash. But otherwise, I will not do the pre-dilatation because it's a risk of stroke issue. If needed, I do post-dilatation. In terms of annulus rupture post-dilatation, I don't think it will be higher than the native aortic. Actually, the cuff is actually protected the annulus in terms of the annulus dilatation. That's just two comments. So I think I will ask the panelists if.
Can I have two comments? Dr. Ye? Sorry. Sorry. I have two comments that I think the coronary risk zone is a good concept, and including we should measure the VTA, including the VTC and VTSTC, but we should not forget the leaflet morphology because sometimes the thickening of the leaflet or the calcium nodule, sometimes it will cause the unexpected coronary obstruction. And the second, I would like to mention that we should use the orthogonal forward view, and also if we have T or if we have the peripheral IVUS pullback from the left ventricle to aorta. These three imaging modalities can make sure the circularity of the stem frame of the second valve. Yeah.
Just want to comment on Dr. G about pre-dilatation. I'm thinking another maybe mode of failures maybe also impact. I mean, if you have AR, I guess you don't need to pre-dilatation. But if you have AS, very critical, and then you put shot in tau that can move, maybe pre-dilatation and put cerebral protection might be better idea, because if once you get in and if you have some movement, and I think that will be greatly impact on the leaflet overhang or coronary obstruction risk. Yeah, but that's my idea.
I have a lecture in the afternoon talking about the cerebral embolic protection device. So the valve-in-valve or Redo-TAVR is the very risk factor for the embolic protection.
Yeah. I would also add some comment, and because now we are unavailable of several protections, would you recommend an platelet dilatation in every single case, just in case of?
No, if the CT analysis show no heavy calcification, I will prefer direct the TAVI procedure just to prevent the embolic protection, to prevent the embolism. Yeah.
Any further question? Give one more question, and then we will start the next speaker.
And also, this is question for myself, and I would ask all of your colleagues. And sometimes I feel some difficulty to adjust the positioning of second valve because of the material already placed in the position. And would you use some kind of stiffer wire, kind of, for example, Landaquist wires or something, compared to the other Safari or Confida wire in case of TAVI and TAV, especially short interval or tall interval?
I think we don't need a more stiff wire in TAV and TAV procedure because it's a kind of strength dynamics inside the Safari valve and then delivery system. So if you control the forward and backward forces, you can control the bidirectional forces. It's enough to make a good location for the TAV and TAVR.
Thank you.
Thanks. I think due to time, I think Professor Shi, you want to introduce next speaker?
Okay, thank you. So on the next, it's my great honor to introduce our next speaker, and Dr. Wang Bin from Xiamen University Hospital, Heart Center. So actually, Dr. Wang will deliver a speech online. So let's again warm welcome to Dr. Wang Bin. Professor Wang, please go ahead your speech. Thank you.
Okay. Thank you. Thank you very much for your kind introduction. And it is my honor to be here to share the experience with the city planning for Redo and valve-in-valve TAVR. And I think the same as the TAVR valve, the TAVR valve degenerates in the years. Actually, in our hospital, we started the TAVR procedure 12 years ago. And I do think more and more TAVR cases with degenerated valve need to redo intervention. And the CT planning is very, very important for the strategy selection, both in the Redo-TAVR or the open heart surgery. I think CT plan can give some information about the characterized index processes, including processes identity, failure mechanism, and the commission and coronary alignment. I think CT can tell us the measurement of the dimension of the index processes, define the coronary risk plan, and anticipate the occurrence risk of coronary obstruction. I think this is the case shows the importance of the CT analysis. You can say this is a 76 years old male patient who accepted the TAVR 3 years ago. And recently had heart failure recurred, and the echo showed the mean gradient elevated to the 47 millimeter mercury. So the patient was transferred from the surgery to the to evaluate the TAVR procedure. But the CT analysis can show us some the mechanism of the degenerative of the valve. You can say some thrombosis, both located in the left lead and in the sinus of the left coronary sinus. So I think the TAVR procedure should be dangerous for these patients. And I think the first things of these patients should be start the anticoagulation therapy, then we'll see what happens. So I think it's very, very important for the implementation of the CT analysis. Of course, if we use if the photon counting CT is available, we can say the more clear of what happened in the TAVR valve. You can say this some example from the from the photon counting CT, you can see very clear the mechanism of the degeneration of the valve, including the calcification of the left leads and calcification of the commissure fusion and the left lead thrombosis and the deformation of the valve. Very important, you can say this kind of the high quality CT analysis can show us the frame fibrosis. I think the frame fibrosis is very important for the strategy selection. And you can say the right figure, and the up one is the incomplete seal of the frame fibrosis, and the up down is the complete seal of the frame fibrosis. I think the location of the frame fibrosis is very important for the coronary reassessment, the risk of the coronary obstruction during the TAVR procedure, and also maybe if the frame are located on the crown, frame fibrosis are located on the crown of the valve, maybe increase the risk of the explant procedures. Another issue is about the initial and the subsequent TAVR type. You say if we choose the self-expanding valve for the subsequent TAVR, and we can achieve a more lower compared with the balloon expanding valve. So the selection of the subsequent and the initial valve matter. And we need to know the concept of the Redo-TAVR for the CT planning. The first thing is the new skirt. There should be the combination of the pinned left leads of the index TAVR and outskirt of the Redo-TAVR. Some situation with the fixed new skirt planing, and some cases with the variable new skirt planing, especially in the short in TOR procedure. Another key issue for the CT analysis is to predict the risk of the coronary obstruction with some definition, including the VTC, VTA, and the VTSTJ, and the position of the coronary risk plane and the new skirt plane. And if the new skirt plane is above the coronary risk plane, maybe the risk of the coronary obstruction, maybe we need to evaluate the risk of coronary obstruction. If the coronary risk plane is higher than the new skirt plane, maybe the risk of the coronary obstruction is extremely lower. And some definition to define the risk of the coronary obstruction. Since I have to think the distance of the VTC, VTA, and the VTJ is matters. If less than 2 millimeter, the risk is extremely higher, and 2 to 4, I think it's moderate risk. Maybe we need to do the protective device. If the distance is more than 4 millimeter, the risk of coronary obstruction should be extremely lower. And this some example for the short in TOR CT planning. You can see the first we need to confirm the index the TAVR, and we make sure the node and the receptor 2 is identified the CPR in relating to the index, and select this step 3 is select the operator, the sequences TAVR device. And step 4 is to define the level of the NSP for the Redo-TAVR procedure. And we can implant a little bit higher and a little bit lower. It should depends the risk of the coronary obstruction and the other issues. And step 5, we need to assess the relationship between the CRP and NSP. If the NSP if the CRP is higher, we need to evaluate the coronary assessment. If the NSP is higher than the CRP, we need to evaluate the coronary obstruction risk. And the step 6 is the second TAVR sizing, and we need to measure the area of the NSP as 3 continuous nodes below, and use the average area to select second TAVR size. And the step 3 is the coronary risky assessments. I think it is according to the green, yellow, and the higher. You can say the different distance indicate the different risk of the coronary obstruction. So a lot of things they need to consider, including the position of the CRP and the NSP and the distance of the VTC, VT-STJ, and the VTC. And we need also to consider the type of valve we selected. Just as the Gilbert Tang had mentioned, if we select the balloon expandable valve to dilate, maybe we change the diameter of the index valve, maybe increase the risk of coronary obstruction. So we only have 4 TAVR cases in our center in more than 1,000 TAVR procedure in the past 12 years, and I show all these cases in these slides. You can see the first case is a CB3 in JenaValve, and this 64-year-old female had accepted the transapical JenaValve implantation 5 years ago in another hospital, and the heart failure recurred with the echo showed moderate to severe PVL with the enlarged LV dimension of 17.1 millimeter and impaired LVEF 34%. And you can see this is a CT analysis. And from this figure, we can show at least maybe the device is implanted a little bit deeper, and the ankle K maybe not located in the LCC sinus, and I think maybe this is due to the mechanism of the PVL. So this slide shows the dimension of the valve, and this slide shows maybe the too deeper implantation should be responsible for the PVL. And this will simulate the SAPIEN-3-29, and we want to implant a little bit higher to seal the PVL. And this is the coronary issue. The distance is enough because we have a very big sinus. And this is the procedure. I can say it's the PVL ranging from the LCC and this SAPIEN-3 across the arch. And we can say this is the rapid pacing, very, very slowly blown up, and we can adjust the position of the valve. You can see we turning the turning tube counterclockwise to implant the SAPIEN-3 a little bit higher. So we got very good results and with the SAPIEN-3. Another case is a 70-year-old female accepted the venous A29 5 years ago, and recently during every follow-up the gradient is okay, but recently the gradient increased suddenly, and the anticoagulation therapy was prescribed for this patient, but the gradient didn't improve. And this is a CKD5 patient with long-term dialysis. And so the echo showed the mean gradient of 15 millimeter mercury. So this is the CT analysis. You can see this patient with the very short VTC, only 2 millimeter, and you can see he is a very good perfect commission alignment. And with maybe the left thrombosis should be the mechanism of the elevated gradients. And you can say the small ID only 20.4 millimeters. So maybe the under expansion of the valve should be the mechanism of the thrombosis of the left lead. So for this patient, you can say for the coronary ratio, you can say maybe for these patients with smaller VTC, smaller VT-STJ, as with longer left leads of the TAVR, left leads maybe beyond the scope of the right and the left coronary level. So for these patients, we selected the self-expanding valve with single current. This type of valve can retrievable after the complete deployment. So we can, after full deployment, we can see what happened. We can evaluate the coronary perfusion. If the coronary perfusion are jailed, maybe we can retrieve the valve. So this is the reason we select this type of valve. And you can say the index valve are implanted a little bit deeper. So I think it's good things for the TAVR procedure. And you can see this is the coronary angle. So this is the 23. We downsized the subsequential valve to 23. And after full deployment, we checked the coronary. You can see the coronary perfusion is okay. So we full deployment, and you can see this is the final result. You can see the gradient decreased dramatically, and with the dependency of the left coronary and right coronary. So another case is 77 years old female with a venous A 4 years ago, and the symptoms recurred. And you can see this the CT analysis. You can say this the slides level of the sinus of the valve, and you can see here some calcification of the leaflets. I think this should be the reason, the mechanism of the elevated gradient. And you can say the interdiameter of the valve is only 16 millimeter accuracy. So I think on the expansion valve should be responsible for the recent increased gradient and the rapid calcification of the leaflets. Of course, from this angle, you can see the septal protrude to the LVVT. Maybe we're wondering maybe some gradient generates at this level. So during the procedure we check the gradient. You can see we use multipurpose here as the inflow of the valve and check the gradient. You can see the gradient across the valve maybe 19 millimeter accuracy. So maybe we don't have any gradient of the LVVT. So we use the 71 downsized sinus count valve and postulate with the 20 valve to full expansion and the second valve. So we achieve a very good result with the gradient of the radial gradient only 6. And the last cases you can see is 18 years old female male with accepted the TAVR procedure. We used the Vita Flow 27 3 years ago, but 1 year ago he had the recurred fever and the tonsillitis was diagnosed in our hospital and accepted antibiotic therapy for 2 months. But heart failure recurred. You can see the echo. Large, massive regurg, and you can see this is the angio, a very, very massive regurg, the aortic regurg. And this the CT analysis is the type 0 bicuspid with very good hemodynamic results after the index the TAVR procedure. So this is the different level of the valve. And you can see it's different. It's the diameter of maybe 23 to 24 millimeter at the different level. So for these cases, we choose the 27 millimeter Vita Flow, and we want to implant a little bit higher to achieve more good hemodynamic results. And because of the endocarditis, we use the sentinel to protect it, to prevent the stroke. So this is the final result after valve-in-valve procedure, and the PVL are much reduced. So this is the pre and the post echo, and can show very good results. So this is the simple summary of these slides. And preoperative CTA enabled the better identification of the potential cause of the TAVR valve failure, evaluate the Redo-TAVR risk, and optimize the procedure strategy. I think the new technology, including the photon counting CT, maybe permit highly accurate the characteristics of the native anatomy and the valve. So this you very much.
So thank you very much for Dr. Wang's excellent speech regarding the CT planning for Redo and valve TAVR. So I think we are behind the schedule a little bit, so we can take just only one comment or question regarding this speech. Any comment? Yes, Professor.
So coronary evaluation is very important for TAVI procedure, especially in the knee scut and the coronary risk plan. So I have a question about the commissural alignment of the index THB. So do you have any concern about the good commissural alignment versus poor commissural alignment in the index THB?
Okay, thank you very much. I do think the commissural alignment in the index procedure is very important for the subsequent TAVR, Redo-TAVR procedure. If for some cases with extremely high risk of the coronary obstruction cases, maybe the left lead modification technique should be helpful. But if you don't achieve a very good commissural alignment, maybe the modification of the left lead doesn't work. So actually, this is the reason for the index procedure. We should try our best to achieve the good commissural alignments for the, maybe it's a very good plan for the next subsequent TAVR procedure.
Okay, Dr. Wang, thanks again for your excellent speech. Thank you very much. Thank you.
Thank you.
So, Professor Ye?
It is my pleasure to introduce last speaker in the session is Dr. Andrei Pop, who's from Alex Brothers Medical Center in Chicago, and he's a director of cath lab and also structural heart valve disease. And he will talk on the lifetime management of aortic stenosis. It's a really important topic. Thanks.
Thank you so much for the kind introduction. I want to thank the organizers for inviting me. Great conference. So lifetime management of aortic stenosis is a subject that's very near and dear to me. I think a lot about this. And it's a subject that's evolving extremely fast. This is my definition, so it's a strategy to limit the number of sternotomies and minimize lifetime procedural risk, at the same time maximizing the patient's quality of life. So where are we in 2026? Well, what do we think about? We think about durability, valve failure. We think about repeatability. You want to avoid the Russian doll phenomenon. We think about quality of life. And then patients get a choice, obviously. So let's start with durability. This is the 7-year data from Partner 3 that showed that basically the SAPIEN S3 platform had equivalent durability to the surgical valves, at least at the 7-year mark. The longer-term data is available from subgroup analysis in Partner 2 S3I and the Partner 2 TAVR intermediate risk comparison. And again, at 10 years, the SAPIEN 3 had equivalent durability with the surgical valves. Now, this is different. The reason that the first slide had such a long title is because the SAPIEN XT Partner 2 outcomes were not as good as the SAPIEN 3 outcomes. So obviously the type of valve matters, and we're all looking for incremental advances in this area. Similarly, this made the news in a big way. Obviously, the Evolut low risk at 6 and 7 years, the curves have separated with the surgical valves having better durability than the transcatheter valves. Surgical valves are coming along nicely as well. This is 10-year data from the COMMENCE trial, which basically looked at the Resilia tissue in surgical prosthesis, and we have excellent durability at 10 years. So this is very exciting data. The field is certainly moving forward. How about repeatability? Repeatability is the ability to basically put another valve in one way or another after the initial valve intervention. People always think that repeatability after TAVR is something that we've kind of figured out and it's not that difficult. But the reality is that even after TAVR repeatability can be complex. All current surgical valves are supraannular, which decreases your coronary height. If you put a really big valve in and you don't think about this sinuses of Valsalva, you can make Redo-TAVR extremely difficult. And just because a valve has failed once doesn't mean that it can't fail again. Also, certain surgical valves are a nightmare. The trifecta is paying for my kids' college education. The stentless valves are hated universally. The cardiologists hate putting TAVR valves in them, and the surgeons hate explanting them. This is a paper from the Vancouver group that shows you the impact of supraannular surgical prosthesis. So basically, if you're putting in a surgical valve, a standard stented surgical valve, your left main height will drop by 6 millimeters. Your RCA height will drop by almost 8 millimeters. If you do a root enlargement, the left main height will drop by 9 millimeters, and the right coronary height will drop by 11 millimeters. So just because you're doing surgery doesn't mean that it's going to be easy to do TAVR afterwards. You have to consider all these aspects. Further information from the same paper, in this case they compared a high implant versus a low implant of a SAPIEN with standard TAVR and TAVR with aortic root enlargement. And actually the low implant of the SAPIEN had the highest potential for redo TAVR. Root enlargement is also not homogeneous. There are different techniques for root enlargement. In this paper, the majority of procedures were Manugian and Nix with some Bo-Yangs as well in there. This paper from Japan shows you that actually when you're comparing a Bo-Yang with a Kono, which is a procedure that I think is a lot more prevalent in Japan than in the United States, repeatability is a lot higher after the Kono than after Bo-Yang enlargement. So we have to think about this. Whether we're surgeons or cardiologists, we have to think about the potential to do Redo-TAVR. Surgical explant traditionally has been tied to poor outcomes. The reason it's been tied to poor outcomes is because the first generation of patients who were explanted had a high proportion of endocarditis, and they were inoperable to start with. Anytime you operate for endocarditis, it's a nightmare. The initially quoted mortality is no longer true. Recently the group from St. Louis with Yoshiko Neko published a paper on best surgical technique for explant. The techniques have improved tremendously. And if you're looking for randomized trial data in the Evolute low-risk trial, the proportion of explants was quite high, but the outcomes were quite good, 4% mortality. This is from Dr. Fukuhara's group at the University of Michigan, and you can see that basically the outcomes of TAVR explant have improved dramatically over the years. This was mentioned earlier, the trends in the US and in Japan and really worldwide are that we're going to see a lot more of this. So we have to think about the second valve when we start putting the first valve in. Repeatability matters regardless of age. The graph on the left is from France TAVI, and it shows you that only 1.7% of the valve implanted have a need for redo down the road. However, if you're looking at when this happens, it turns out that the highest risk period for reintervention after TAVI is actually in the first 3 months after implant. Even more than that, if you're looking at the first year, all TAVI reinterventions in the first year are more than TAVI reinterventions after year 5. So whenever somebody tells me, grandma is 92, she's never going to need another valve, the reality is the moment you put a valve in, there is a risk that you're going to need another valve. The patient in the middle here is a 92-year-old man who has wide open aortic regurgitation after a self-expanding valve implantation. The person who put that valve in said, 92-year-old, they're never going to need another valve. Well, turns out that they did. Quality of life is important. We think of the number of surgeries in a lifetime. We need to think of the total number of procedures in a lifetime, whether they are TAVR or SAVR. We think about the need for long-term anticoagulation, and we think about the need for surveillance and the costs and the hassles involved. The other thing that we think about is length of stay, time out of the hospital, are other kind of, let's say, soft from our perspective, are very important criteria from the patient perspective. Patient preference is obviously very important. That needs to be informed. It's a back and forth with the valve team where we provide the data and we try to direct decision making. However, in the end, patient has the ultimate decision power. Finally, first, do no harm. If there is a complex procedure, avoid it. Go for the easy way. Press the easy button. I have seen cases like this. This was somebody in their 60s where somebody wanted to put a TAVR valve in there. I don't even know where the valve is. It's a big rock of calcium. I think this is a person who, unless there is a very strong reason to go with TAVR, this patient should have surgery. On the other hand, if the patient is highly complex surgically, go with TAVR. So choose the easy button whenever possible. So how do we practice lifetime management in my own center? Everybody gets a CT and everybody goes for a valve team discussion whether they're going to have TAVR or SAVR. We consider Redo-TAVR options and Redo-SAVR options for everybody. And we optimize the first valve implant. If we're going to do TAVR, we ensure full expansion, we balance coronary access versus the risk of pacemaker, and we minimize perivalvular leak. If we're doing SAVR, we avoid PPM, ensure further valve-in-valve is possible, and we avoid valve deformation or tilting. Thank you very much.
Thanks for excellent talk. I think you have more time, so I guess we'll give you a few questions. So I think this is a very important topic, and the lifetime management that we are discussing so many years, but it's honestly, we still don't really know how to make a decision, particularly in young patients. I think I want to once point is heart team is very important. Honestly, for this kind of young patient, complex decision making, which is the first should be surgery or should be TAVI. I think the functional heart team is most important things to make a proper decision for our patient. Comments?
Questions? Very agree, and I think I want to echo Dr. Pop. Great talk. I think the most important is at index first TAVI. And I think you put very nice way. I think not only TAVI, I think surgically, I think you need to plan, and because when you get the first index TAVI and get the plan for the first either TAVI or surgically, when you have to do repeatability, it's much easier. And I think that is I think well planned from the beginning is must do for all the cases.
Yeah, I think the smart surgeons are thinking about the second valve. I think when we started, when root enlargement started, root enlargement was clearly a procedure designated to get you lower gradients and get you a bigger valve. I think the field is moving now to the point where that's great, but we also want to have the potential for Redo-TAVI. And I was talking to Dr. Fukuhara, and he was telling me that whenever he enlarges a root, he actually does a CT scan afterwards to demonstrate to the cardiologists that TAVI can be put in there. So I think that's the kind of thinking that we all have to demonstrate. We have to show that we're leaving options behind. I remember working with somebody who used to tell me, by the time this valve fails, I'll be retired and it's going to be your problem. We definitely do not want that. We want to maintain possibility of future intervention in all patients regardless of age.
Professor Pop, thank you for your excellent talk. And would you want to develop some risk scoring system that can predict if we need to redo TAVR or TAVR explant? Any?
So we published 2 years ago with Isaac George from Columbia. We published a paper on lifetime management, and we proposed a concept of lifetime estimated risk. because the problem is if you're going to have a simple TAVR, there is a calculator that tells you what the risk is. If you're going to have root surgery now, there is data in the STS calculator that tells you that. But there is no calculator for TAVR explant. There is no calculator of risk for basilica. There is no calculator of risk for unicorn. So the problem is, our concept was you should look at the patient's lifetime journey, and if they're going to have TAVR first and then TAVR explant later, versus they're going to have surgical valve first and the TAVR with a basilica later, how do you put all those numbers together and you come up with a lifetime risk? I think the elements for that calculator are coming into place slowly, but they were not there yet.
Thanks. I think for the timing, I think we already significant overtime. It started late, so I think we have to close this session. This is a big topic. We can discuss whole days. Thank you very much for excellent talk. Thanks.
Of the time, we will start this session. I'm Hong from Seoul, Korea, and my co-moderator is Dr. Chang and Dr. Lee, and we have several panelists, Dr. Poon and Chao, and Dr. Wu, and Dr. Lee, and Dr. Chan, and Dr. Chang, and Dr. Ge. We have 3 topics of debate. Before the start the presentation, we would like to vote again for the audience and the panelists about this is a really hot topic for the TAVR. Is the first regardless of the age and the surgical risk. I'd like to suggest some vote for the TAVR regardless of the whole age and regardless of the surgical risk. Somebody said, please raise a hand for the pro. And Tian Ping, please.
是不是有那个 QR code 上面可以扫？维修。This we can scan this.
I complete the board.
结果没有 can show the result.
As you know, TAVR was the currently is already established treatment for the patient. Oh, no, it's a 67, and the yes is a 32. It's a very quite interesting. Okay, we will vote again after the end of the three presentation. Okay, let me introduce the first speaker. Is the position statement of the universal TAVR. Is will be presented. Pro position is Dr. Musami. Please.
Thank you very much indeed. Is this real life? A real life situation? I'm not sure about it, but the debate is a debate. The proposition says TAVI should be preferred treatment for all patients with severe symptomatic aortic stenosis regardless of age or surgical risk. And that's me, and that's my proponent who's going to come after me, and that's the way he leaves his cath lab and operating theater after the destruction he leaves after his procedures. What will I prove? TAVR wins in high risk, TAVR wins in low and intermediate risk, TAVR proves longevity, TAVR has superior hemodynamics, TAVR wins in mortality and morbidity, TAVR in bicuspid, is it going to be a winner? TAVR wins in quality of life and TAVR lifetime management. Why should patients choose surgery, have a stenotomy, stay in the hospital longer, have a bypass circuit which introduces systemic inflammatory response and weeks or months of rehabilitation? So if you look at the evidence base between high risk to intermediate risk to low risk, and as well as durability, we will prove that TAVR has proven its worth. And these are the trials that we have, which have substantial numbers from Partner 3 to UK TAVI. We will not go into the individual trial, but this is the database that you can look into. So it seems to, there is evidence across all risk strata. If you look at high risk like Partner 1 to low risk like Partner 3 or low risk like Evaluate, and you'll see a constant results that you see the superiority or definitely non-inferiority. And if you look at the high-risk group in Partner 1A, if you look at their results in terms of 1-year results in all-cause mortality, or in terms of 5-year results in mean aortic gradient, all-cause mortality in the Partner 1A trial, at 5 years it shows superiority. And it was not inferior, it was indeed superior in Partner 3 low-risk trial. You have a reasonable 1,000 over patients, which shows the primary endpoint at 1 year was superior. 30-day major bleeding clearly is far superior, and the hazard ratio for superiority was proven. And do not underestimate the new onset of atrial fibrillation. Would you like a pacemaker, or would you like an atrial fibrillation? I think atrial fibrillation is more problematic for patients. And the curves diverge early and stay separated for at least in the first year, and persistent superiority at every time point seen in this particular trial between 1 to 7 years, as you can see on the right hand. Now, the patients certainly recover faster by every measure. The TAVR hospital stay is getting lesser than 3 days, sometimes now is a day procedure. Home discharge, new AF, it is absolutely important to see new AF because AF does increase morbidity and mortality. And major bleeding clearly has much lower. And the faster recovery and shorter hospital stay and the quality of life are proven between TAVR and superiority. And if you look at low-risk trial, 5-year results trial, and you can again see in terms of disabling stroke and re-interventions, cardiovascular mortality, disabling stroke, and appears to be a favoring towards results of TAVR. And in the low-risk trial, your non-inferiority is confirmed at 5 years in numerically favored TAVR, no mortality advantage, but certainly confirms Partner 3 trial of non-inferiority. So this non-inferiority still maintained. The curve runs parallel almost, and you can see over the 5-year period. And superior hemodynamic with TAVR was shown, especially with the supraannular valves. Whether that transforms into clinical outcome, that is to be debated. But nevertheless, here you can see the results of a low-risk trial. And the quality of life clearly wins, particularly from baseline to the first year. The quality of life is far superior with TAVR. And the question of durability, and we now have durability results at a decade, and the objection of durability collapses here. And you can see in a large number of patients that has been confirmed that the death, stroke, and MI rate at 10 years seems to be non-inferior, but severe surgical valve deterioration was much higher with certain types of surgical valves. A decade of follow-up in the notion, the Kaplan-Meier 10-year composite clearly shows the curves are identical. And so therefore, that the notion that it will not last is not necessarily true. And the TAVI curve of durability stays flat, but surgery does not. And that is an important point. The TAVR's severe structural valve destruction, deterioration is much higher in certain surgical valves. And the proven 10-year durability seen in the NOTION trial, death, stroke, MI at 10 years is identical. Severe structural valve deterioration is 85% less. And in bioprosthetic valve failure, 30% less, as you can see. So the durability proof is clearly shown here. So 3 trials, 2 different platforms, 1 consistent answer. Superiority in partner 3, non-inferiority in Evolute, and Notion 3 shows equivalent longevity. So where TAVR wins clearly and consistently, major bleeding, 30-day stroke rates, new atrial fibrillation, and obviously the pacemaker rate appears to be slightly higher, but between AF and pacemaker, I would choose a pacemaker any day. So dramatically safer perioperative profile, you can see new onset AF clearly is very high. Acute kidney injuries and cardiogenic shocks and major bleeding are not something to be ignored. So again, the perioperative safety, TAVR wins clearly. You can see in terms of major bleeding, AF, acute kidney injury, and stroke risk are definitely important perioperative findings. So bicuspid is a challenge, but the low-risk bicuspid study shows that they are not necessarily inferior to SAVR. So we'll wait for the Sweetheart registry also shows similar mortality. So we're not necessarily far behind that. And the lifetime management favors a TAVR-first strategy. Well, Redo-TAVR is safe, as we have seen. Coronary access is solvable, improving with the newer devices. And the first valve is the strategy. So mortality advantage, you look at 5,000 over patients in 6 randomized controlled trials, and you can see all-cause mortality, 20% reduction, death or disabling stroke, a 19% reduction, and stroke rate standalone is equivalent and not inferior. So 10 arguments, all data supported. Mortality advantage, TAVR wins. Partner 3, longevity, TAVR wins. Hemodynamics, TAVR wins. 10-year durability, TAVR wins. Perioperative safety, clearly TAVR wins. Recovery, hospital stay, we do not have to argue this, TAVR wins. All risk strata, TAVR wins. Real world scale, TAVR wins. Valve durability, I think TAVR wins. Quality of life, absolutely TAVR wins. So the burden of proof has shifted permanently, I believe. Mortality advantage, durability proven, perioperative superiority, patient experience, do not underestimate this. Scale and trajectory, as you can see the data from states. So, closing statement for me. 3 randomized trials, 2 valve platforms, 10-year follow-up, no survival advantage, no durability advantage for surgery, yet surgery requires sternotomy, bypass, more bleeding, more AF, and longer recovery. The burden of proof, ladies and gentlemen, is no longer rests with TAVR, but it rests with surgery. Thank you.
Excellent presentation. con position at the Dr. Hsin.
Test.
Hello, good morning. Good morning to everyone. I'm Dr. Tay from National Heart Institute, Malaysia. Thank you very much to the opportunity for me to debate the topic here. The TAVR should be the preferred treatment for all patients with a severe AS, regardless of the age and the surgical risk. So the important point is that the age of the surgical risk, and my position is a selective TAVR wins. So let me just go through one paper that I just read recently for a patient who had the TAVR done at the first place, counseled by the surgeon and also the cardiologist, but at the end he need to redo surgery after a few years, and at last he put that he feels he might have been better off if he had initially the surgery done instead of the TAVR at the age of the 55 years old. So we know that the TAVR has started performed in the 2002 by the Alan Cribet, and subsequently it has been FDA approved in the 10 to 15 years from the high inoperable surgical risk to until intermediate and also the low risk categories. No doubt that the expansion of this indication is data-driven and very remarkable. However, if you look at the latest guideline from the United States and the ESC guidelines, it does show that when we push towards the TAVR in a younger age group, does this justify the situations when we have the patients who are going to live beyond 20, 30, and 40 years? So the guideline clearly say no, which I do agree as well. So the TAVR is recommended to be performed in the elderly age group with a life expectancy less than 10 years, no doubt about that. However, when we come to the patient wish and discuss the lifetime management with the patient, everyone will wish for this minimal invasive procedure with a very short surgical, without the surgical scar, quick recovery back to the normal activity as soon as possible. Of course, patient also wish there's no anticoagulation as well. But the question is, does this durability of this structural valve align with this lifetime management or the life expectancy as well of the patients? So the universal TAVR in all severe AS is not recommended, despite all the data that we have just now that Dr. Timon has shown us that there are the 10 years data from the high risk, intermediate, and the low risk for the 10 years of evidence. So look at the data against and the evidence and the guidelines. It recommended that for any patient who are younger, less than 65 years old, surgery is still a better option. So the first cut is always the deepest. So the lifetime management and also the durabilities of these bioprosthetics must always be discussed together when we come to this situation and treated the patient with the severe aortic stenosis. So we all know that the TAVR has this durability of the 6 to 10 years on average. However, when it comes to the Redo-TAVR, this is a feasible procedure that can be done in all the patients. However, there is not, we do not have so much of the long-term data. Perhaps there is a one short-term and also the mid-term data at 1 year, but how about the long-term? If you look at the first live case that was performed today, the patient has about the 3 TAVR procedure in 10 years. But how about if it fails again in the patient who has a very small 20 millimeter valve in the third procedure? Last but not least, a TAVR explant, we also know that this is a very high-risk procedure. So it is not a standard procedure or straightforward procedure like the Redo-TAVR. And also, when you come to the TAVR in the TAVR, what is the anticoagulation status? As we mentioned earlier on, that the patient does not want any anticoagulations, especially the patient who has a TAVR, who has a high chances of this atrial fibrillation. But when you come to this TAVR in TAVR, there's a high risk of the thrombogenicity of this valve. We are not sure that the long-term durability and should we put the patient on the anticoagulation or not. Whereby we have a very good long-term data for the TAVR, which can last for about 12 to 15 years. And the TAVR in TAVR is a very well-established procedure, and it shows a good midterm data as well. So when not all anatomy is a TAVR friendly, it same goes to the not all the clinical factors favors the TAVR. So when the patient is too young who expect to live longer, more than 20, 30, 40 years old, we should suggest the patient to go for the surgery valve, which can have a longer durability. And whereby if there is an infective endocarditis, it is a contraindication to perform the TAVR as well. And last but not least, if the patient is at a too advanced age with the life expectancy less than 1 year, so the TAVR should negate the benefit of these procedures. And apart from that, the bicuspid valve is a very challenging anatomy. Even in the guideline, also recommended that it is may be reasonable to perform the TAVR in this bicuspid valve in an experienced center and the patient have a very high surgery group that go for the surgery. Not only that, there are other anatomical factors, including this horizontal aorta, aortopathy, which require the surgical interventions. And also, if there's a patient have a multiple valvular heart disease, small aortic root, this all can be handled by the surgery. So I would like to expand further is that our surgeon can perform the root enlargement for the patient who have a small annulus. If you put a TAVR in this small group in the small annulus of the patients, you may have no opportunity to perform a TAVR, and the patient may have to go for the TAVR explant in the future or in a short period of time. Not only that, everyone have a different anatomy. There are some patients who have an anomalous artery or even a very low coronary height, as I mentioned here. These patients have very low coronary height, which is quite near to this calcified commissure, which we think that performing a TAVR is considered very high risk, and you have to put a coronary stent to this kind of the anatomy, and thus the patient may require the long-term antiplatelet or dual antiplatelet subsequently, or if there is a coronary failure or the TAVR failure, the patient have to go for another TAVR explant surgery as well. Apart from that, in a patient who have a bicuspid anatomy, we all know that this patient falls in a very young age group and the valve degenerate very early. So if you're putting a TAVR in a very heavily calcified asymmetrical anatomy valve, it will underexpanded and it will reduce this aspect, the durability of the TAVR valve. In fact, our surgeon can perform this decalcification of the procedure, remove all the calcium, putting a new large surgical valve, ensure the full expansion and also good hemodynamic as well as the lifetime, as well as the durability of the valve. And also, with the latest generation of the new surgical valve, it has easily fracturabilities, that the features that allow us to perform the TAVR in the SAVR in the future in a low risk category. So, of course, we all know that even if we put in a TAVR, it will fail in one point of the time. What should be the next? Re-interventions, regardless we are using the self-expandable or the balloon expandable valve. But how should we perform that? It will be only two options, Redo-TAVR or TAVR explant with a surgical valve. But from the registry already showed that the explant TAVR and the explant to Redo-TAVR is not a straightforward procedure. And it carries a higher mortality, longer hospital stay, and also the stroke risk. So the TAVR failure is often harder to fix than the surgical bioprosthesis failure alone. So again, I would like to emphasize that the TAVR is a very good technology to perform in the patient who have a severe aortic stenosis, but we should choose the patient and select the patient carefully. It's not the universal treatment and a solution for all the patients with the severe aortic stenosis. And last but not least, we know that it's not for all the severe AS patients. The lifetime management, heart team evaluation, and also shared decision-making with the patient is very important. It's not the bureaucracy burden. But of course, when we introduce the first procedure to the patient, we must expect that we are going to do the second and third in the near futures. So the first cast is always the deepest, but let's make sure it's being the right one. Thank you.
Thank you. Wang, would you introduce the next speaker?
Thank you. I think this session of the program is really interesting because it has the 3 times of debates between two sides. Now it comes to the second debate. Now this is the rebuttal session. However, we are going to, these debates are going to be delivered by different speakers. Our pro side speaker is Dr. Guo. Dr. Guo, please.
Thanks, Chairman, and thanks all the panelists. Thanks for inviting me for this very tough talk. TAVI should be for all. Yeah, it's really very difficult. So I can only say that according to the randomized control trial, there's only no-shin trial comparing TAVR and SAVR, and the TAVR always looks fine. But should we do TAVR for all? some pitfalls against the SAVR for all. That is the durability, challenging the TAVR's durability and rise, and then leg catch-up phenomenon in TAVR. And then reintervention for TAVR. Sometimes we will talk about the paralytic of TAVR, and pacemaker rate in TAVR, and lifetime management. Actually, the lifetime management is very important, as I agree with Dr. Lee's comment in the last talk. And bicuspid and concomitant condition like bicuspid and with concomitant coronary disease or aortopathy and multivessel disease and trial population. Actually, we should think about the patient as a whole. So I will say state fairly and concede with the kind of the truth. For the first issue, the duration of the TAVR, but according to the Mao-Shin trial, at 10 years follow-up, the duration favors the TAVR is still good. There's a structural valve deterioration in TAVR 1.5 compared with SAVR 10.0. If you say by prosthetic valve failure is maybe about 8 compared with 10. So I think the duration of the TAVR in the Mao-Shin trial, which is the only longest randomized control trial, compare TAVR with SAVR, and it also shows the durability of the TAVR. And the device and device-specific problem, somebody will argue about the absolute low-risk patient show reintervention, but it's due to the aortic regurgitation, not exacerbation of the aortic stenosis. The third crossover, and actually, it's not also, it shows that actually the crossover lives in all devices, confounding the registry, so the leg catch-up phenomenon actually could be corrected by the newer novel design of the TAVR devices. So paralytic also do not matter in the long-term outcome, and the engineering has been improving, so the paralytic can maybe decrease in the future. Also accompanied with novel devices like lithotripsy could overcome the paralytic. And the pacemaker problem, I think, like that the first speaker said that the pacemaker is actually, I think, it's not a big problem. And lifetime management, sometimes it defavors surgery. This is only the very some weak point in TAVR for all patients. After realize all the data, I think there's still some role for SAVR, actually, in my personal opinion, because for some patient who is very young and like bicuspid, some very young and bicuspid, I think maybe SAVR should be better for the patient, to be honest. So, but for the elder age and some very high, actually low to medium risk, actually TAVR may be also good for this kind of patients. And the bicuspid in the bicuspid trial also showed that 1 year compensation point is 4.2 versus and with a large EOA and a low pressure gradient. And this is three-heart registry also show that the equivalent mortality after propensity matching. So I think the short-term outcome of the TAVR also compare with the SAVR is the same in some bicuspid valve. So maybe we should do some very precise evaluation after before the TAVR or SAVR. Okay, and they say the randomized control. Okay, this is okay. No, the elderly, actually, we should not for this discussion. And SAVR for all, actually, I think sometimes we should do some change in our mind that the TAVR may be suitable for some cases, and most of the cases, and dedicate for patient, think about the patient's further condition, and manage a lifelong management may be the better. So I think from who is older than 70, TAVR may be good. Bicuspid, it can also be fine, and lifetime decision is good for patient older than 7. The United States also proved that there's no age limit and low all surgical risk and no age limit in the FDA's statement. So I think if you're regarding about the durability and leg catch-up phenomenon and parabolic pacemaker rate, lifetime and coronary access, bicuspid concomitant disease and the trial population, according to all the issues, I think TAVR may be maybe the choice, and after a thorough considerations about all the patient's condition. Thanks.
Thank you, Dr. Ko, for your talk for routine TAVR. However, our next speaker is a surgeon who is serving at the Cheng Memorial Hospital. He's talking against the routine TAVR procedure. Dr. Cheng, please.
Okay, thanks the moderator. My statement is that TAVI should be the preferred treatment for all patients with a severe AS, regardless of age or surgical risk. My position will be selected TAVR, not all patients. We must embrace that the philosophy. The first cut is the deepest. The initial choice we made determined the patient's clinical trajectory for the next 20 to 30 years. As the data shows, a 60-year-old patient can expect to live another 20 years or longer. Therefore, patient's life expectancy and the bioprocesses durability must be the primary consideration for our lifetime management strategy. Why must we be selective? Because bioprocesses do not last forever. So I'm not going to go into trials. I'm not going to go into partner trials, notion trials, because those trials are only 10 years. And the bioprocesses finally failed. So bioprocesses, they are subject to valve dysfunction, such as structural deterioration, thrombosis, and endocarditis. And they also are subject to valve failure, such as wear and tear and calcification. So for patients aged 55 to 65 years old, we must anticipate the 3 procedures in their lifetimes. Even if those patients up to 75 were likely to require 2 procedures. So those trials, they only talk about first valve. So when you valve fail, we have to face the 2nd and 3rd procedures. So if we choose TAVR as a first step in the young patient, we are risked to have the Matrosca procedure. In this valve-in-valve scenario, each subsequent device make the effective opening smaller and smaller. For example, 23, 23, and 20. So the same thing that we see in the first case in the live demo this morning. Also we must also face that actually the inner diameter of the valve, even the surgical valve, they are 5 to 7 millimeters smaller than the label. So as a 23 millimeter valve, they only provide 15 to 16 millimeter opening. So this leading to the patient prosthetic mismatch. Same for the TAVR valve. The inner diameter of TAVR valve is small too. For example, the 23 Evolut or 23 S-Sapien, the inside is only 15 millimeters. We all know that the long-term survival is based on the valve size. A bigger valve gives you a better survival. So this is what happens if you have heavy calcification, you put in the TAVI valve. The TAVI valve is not fully open and it cannot expand into the fully circle. So the long-term durability and the flow dynamics are compromised. With SAVR, with surgeons, we can remove all the heavy calcifications, put in the proper valve. Furthermore, we must account for the coronary risks. If the valve to coronary is less than 4 millimeter, or the leaflet of the TAVI valve reach the sinus tubular junction, we are facing the high risk of sinus sequestrations or coronary obstructions during the future intervention. So we are not just replacing the valve, we potentially sealing off the patient's coronary access for life. So prevent these complications, surgical aortic valve replacement offer a powerful strategic advantage. So we can do a root enlargement. For example, we can put a valve from 19 to 27 millimeter to eliminate the small PPMs. Also, we enlarge the sinus valsava, so from 25 to 35, so decrease the risk of sinus sequestration. Even more, we can deal with more complicated anatomies. We can perform a bent-top operation with a modified Cabral method. So I relocate the coronary osteans. So in the future, if the bioprosthetic valve fail, or you can do a valve in valve, you can do a toe in toe without coronary obstructions. For example, this case in the middle, I did it last month. I relocated both coronary high in the middle of the ascending aortas. So you can do whatever you want if the valve fail. So you see, I even put a fluoroscope tape around the coronary ostean. So in the future, you want to do a TAVR. In this case, you can locate the ostean of the coronaries. So my final summary would be that safer we can avoid PPMs by doing the root enlargement. We can increase the size of valsava so you avoid sinus sequestrations. And we can do a relocation of coronary artery. So I think in selected case, safer is better than TAVR. Thank you.
Thank you so much, Dr. Yi-Cheng Chen. Before we move on to the third debate, we are going to have about a 15 minutes discussion time. It looks like we have a lot of the panelists here, and almost all of us are the interventional cardiologists rather than the surgeons. So first of all, I would ask one of the course director, Dr. Cao, you're the designer of this program. You are going to set up us. What do you want to say after these debates? Thank you.
Because I think the average number of cardiologists and cardiosurgeon here. Okay. So I think I would prefer universal TAVR because the modern trial has shown the TAVR has an outcome at least comparable to the SAVR, but the TAVR can provide the short hospital stay and less invasiveness and patient preference, and such as is quite important. So I personally prefer the TAVR than universal TAVR. Yeah, thank you.
Thank you. We have other experts next to me, Dr. Kapun. What do you want to say?
I think it's hard to answer a question when you apply to all patients. I think the rebuttals have been pretty pro-TAVI, except it's not all patients. I think there's a few things we can talk about. This durability. Why is it that TAVI is perceived to be less durable than surgical valves? That we have a lot of expert surgeons here. Is it the way we deploy? Is it because we haven't optimized the procedure when we put it in? Have we chosen the wrong patients in bicuspid? We need bicuspid low-risk trial or young patients. That's ongoing now. There's at least 2 trials looking at young patients. So why is it that we should expect it to be less durable? And is durability the main concern here? I do wonder whether now when we do TAVIs, when we optimize it so much more, maybe it will last longer. We're probably changing the trend of deploying the valve as high as possible to avoid pacemaker. So maybe Redo-TAVI will be a bit easier the focus on commercial alignment nowadays. If you look at the balloon expandable platform, all the next generation balloon expandable are geared up to have commercial alignment. So that problem may be solved, or at least make leaflet modification a bit easier. So I think TAVI is favored in a lot of patients, most patients, and maybe one day will be all patients, with data to support that.
Before the other panelists can have the mic, perhaps we can ask our online panelists to express their thinking about it. What about you think, Dr. Hai-Po Chang? Are you still on the line? Because I can see the screen. No. Okay, he's not here. We have another online speaker who is Dr. Hen Ge.
Yeah, I'm
Okay.
Dr. Ge. Yeah.
Please.
Yeah, thank you. I think thank you to both sides for solid arguments on the universal TAVI indication. But I think there's a trap in this design of the topic, because we cannot mix a low-risk patient and a young patient together. But so from my perspective, I would think restricting the routine TAVI mainly for elderly patients rather than expanding to across all age group is very important, because the core concern is in the limited long-term durability of the bioprospective valves used in the TAVI. So these transcatheter valves inevitably develop to structure valve degeneration, I think, over time. Logically, I think after 10 to 20 years after implantation. So for younger patients, if you still have decades of expected survival, so degeneration valve will require Redo-TAVI in TAVI procedure. So there's debaters said there's a low risk to do a Redo-TAVI, but what if you have to do a Redo-TAVI for the second time? So that will increase the risk very much. So I would prefer the TAVI cannot be produced to all age patients. We should restrict to elder patients. Thank you.
It looks like that our interventional cardiology is going to be the loser. So who is going to speak for us? Eric? What do you think about it? Speak for us, please.
Sorry, I was about to play the devil's advocate because I was thinking, well, to be honest, I think that TAVR is not for all patients, and we are forgetting that mechanical aortic valve replacement actually has a bigger, better survival advantage. If you look at the TVT registry data for patients under 65 years old, we're not talking about re-intervention rate, because re-intervention doesn't mean an event. But if we're talking about hard endpoints like survival, mortality, younger patients will do better with mechanical aortic valve replacement in terms of mortality benefit and clinical events compared with a bioprosthetic surgical AVR. And then can I extrapolate that mechanical aortic valve replacement? There are newer generations, maybe lower requirement for mandatory anticoagulation, and we can talk about polymer valves. So I think mechanical aortic valve replacement still play a role, especially in small anatomy. Many people talk about the theoretical advantage of performing an upfront root enlargement plus implanting a larger surgical AVR. But I mean, to be honest, do many surgeons have a lot of experience in that approach? It's just like Ross procedure. Does all surgeons have expertise in doing Ross procedure with a theoretical advantage? But if we do some complex surgery, I mean, if you look at contemporary surgical programs, what are the complication risks of root enlargement? I think it's going to be higher than a mechanical aortic replacement, aortic valve replacement. So we have to factor in, of course, shared decision-making, patient preference. So then in that case, and then TAVR would not be a universal treatment for all patients, but then it's again in a contemporary setting. We have to factor in the surgical expertise, the interventional cardiologist expertise, patient anatomy, et cetera, et cetera.
Thank you. Other doctors?
Thank you. I'm Dr. Ray Chen. I'm from Hualien City Hospital. I'm a surgeon, but I do both. I do TAVI and also surgical valve replacement. So kind of biased to not select every case for TAVI. But I just want to just echo Eric's comment about the mechanical valve. Even though I'm maybe middle-aged surgeon, but still watch and observe those senior surgeons have more experience of doing mechanical valve. Those patients, when we are following those patients, they think they're doing quite well. So, and personally, I also do some mechanical valves for younger age patients. And also nowadays, the newer generation of mechanical valve, you don't need that much anticoagulation. So that takes some advantage. And the other thing is that, like you mentioned previously, I also echoed Dr. Lee's presentation about root enlargement. Because I believe that 10 years ago, even though we're talking about Notion trial, 10 years ago, I don't think most surgeons would appreciate the importance of root enlargement. And that's because the complexity of the different kinds of procedure. And also you mentioned we surgeons are lack of that much experience of doing that. But since last 4 or 5 days, Dr. Boyang developed this reverse wire incision root enlargement. Although some surgeons argue that this is not a real annulus enlargement or LVOT enlargement, but there's still argument, some controversy. But it indeed provides a very good and much easier way to do aortic root enlargement. And also with using his method to do this procedure that can encourage more surgeons to do root enlargement, can have a large valve, can have a lower pressure gradient, and just like Dr. Lee just showed the pictures, that we surgeons are aware of that kind of surgical valve or TAVI valve. Its real diameter is not as large as we thought before. Now we cherish more about the real diameter of the prosthetic valve. So that's 2 comments I have. Number 1, the mechanical valve for the younger patients, and you don't need to do every root enlargement. Number 2 is that if you want to do root enlargement for the prosthetic valve, it's much easier now, and the surgeons were more encouraged. There are 2 comments I have. Thank you.
For the last few seconds, is there anyone in the audience who want to? Okay, Dr. Jeng, please. Speak for us, please.
Simple caution, because we talk about TAVI, but there's a real long-term TAVI. There's only 2 valves, SAPIEN and Evolut. So these data you cannot extrapolate into all the new valve, just like surgical valve. So I want to be cautious, because it would depend on which valve you use it.
Sorry, we have another speaker. Doctor, please.
I completely agree with Jian. So remember that all the pro speakers talking about the low-risk data, partner, the Evolute, you need to know what patient went into these trials, right? These are all low-risk anatomy. The aortic root anatomy is low risk. Number 2, no bicuspid valves in those trial cohort. So bicuspid valve was never put in those cohort. No multiple valve pathology, and they are all old patients. So I think we have to caution against extrapolating those data. And I was particularly intrigued by Eric's comment about mechanical valve. As a surgeon, I feel a lot of pressure to put in the bioprosthetic valve when I get referred from a cardiologist. I get a 58-year-old referral. If this patient ends up coming out of the OT with a mechanical valve, how many cardiologists will be upset with me? Yeah, but anyway, that's just my comment. Thank you.
Thank you. Now I'm going to invite Dr. Zhang Zhongyi, who is the surgical course director of this meeting, to chair the last debate. Dr. Jian, please.
Okay, we will go into the 3rd debate. The first speaker is Dr. Lai from Prince of Wales Hospital, Hong Kong. Please, Dr. Lai.
Hi, good morning, everyone. It's my great honor to be here.
and to represent the TAVI operator and try to debate against a very well-known surgeon, Dr. Lee. Normally I don't debate. Now my other half asks me to do something, I just do it. So it's my challenge here. I'll try my best and summarize in 4 minutes. Now, we know that we have a lot of clear trend worldwide, like TAVI procedure increasing rapidly across all age groups. And this is data from national registries, Hsin clinical data showing this shifts away from traditional SAVR to a TAVR even in young and lower risk patients. And age is just a number. I think anatomy is the key. And many people still focus heavily on age or STS score, but I believe that truly matters is anatomy. If the anatomy is suitable, TAVR can offer excellent outcomes regardless of how old the patient or how high the surgical risk or low risk could be. Now, TAVI is no longer experimental and it's got long-term robust data and 10 years data. And I think a lot of experts already spoke about this, all these data, but I just quickly summarize. PANA 3 tried 5 years and even 7 years. Now, like severe symptomatic absence, there's no significant difference in primary composite outcomes between TAVI and surgery. And even in similar in low-risk AVLA trials and showed comparable rates, and now it's a 6 and 7 years data. And the REAS trial specifically looked at the women and reinforced that TAVI performs very well in this subgroup. And when we pull the REA and PANA 3 data together, the message remains consistent. So I think if you put the REA and PANA 3 data together, and basically it still show that the subgroups is in the female population is showing very good outcomes. And this is the Notion 10-year data outcomes and similar death or like composite outcome between the TAVI and surgery. And the recent dedicated RCT of a TAVI and surgery symptomatic aortic stenosis in low and intermediate risk, SAVR versus TAVI, and you can see that the death incidence in TAVI group is also lower versus SAVI. How about hemodynamics? So in PANA 3 lower 7 years, there's similar valve hemodynamics, including mean gradient and AVA between the TAVI and surgical valve. And at the 5 years, actually, you can see the from the evidence showing the mean aortic valve gradient is significantly lower after TAVI and surgery as well. And also more superior hemodynamics in 10-year Notion trial as well. When you look about the PVL rates, despite its high amount of PVL rates with TAVI, but there's no difference in moderate or severe PVL in TAVI versus SAVI group. Now, another one is the mild PVL and survival, also in PANA 3 low-risk trial, showing there's a comparable outcomes, and there's no significant impact at 7 years. How about quality of life? So the 7-year outcomes, they're showing that in PANA 3, there's no difference in the NYHA or KCCQ score. And even in lower risk, in absolute low-risk trial, also sustained improvement over 5 years. Durability, there's no difference in prosthetic valve failure at 7 years, also in the PANA 3 trial. In the Notion 10 years also, as well as less prosthetic valve dysfunction with core valve, there's no difference in valve failure rates. And when you talk about lifetime management, TAVI is the first approach, so what do we think? Now, when we do TAVI and SAF, the mortality at 30 days, they are actually comparable. Mortality was 12 and a 10 in TAVI and SAF. And for TAVI and TAV versus TAVI and SAF, procedure success is also quite high in TAVI and SAF, and the procedure safety is also good in Redo-TAVR as well. Now, when we look at these data here, like I think a lot of people would agree with me that we don't want a lot of open heart surgeries. We want to minimize open heart as much as possible. So if we think about, if we do a TAVI first, we probably just need one open heart maybe in the future, or we can do Redo-TAVR or TAV. So, or TAV. We don't know. We probably have to plan in the anatomy. So if TAVI first, in-depth TAVI is very important, and determinants is based on the choice of the device, how deep you implant, and what's the optimal coronary alignment, and what's the ideal device expansion. So here is one of the data showing that surgical explant that you can see the surgical mortality explant is actually pretty high. And again, this is a single center retrospective study here showing that the underwent aortic valve reintervention rate prior to TAVI, so the 30 days and 1 year MACE was significantly higher with explant. And so we have to think about what kind of complex procedure these patients are going to be undergo. So Redo-TAVR is feasible, you just need to plan it very well. So you need to analyze the CT very well and you need a heart team this approach. And I think previous speakers, Dr. Tsai and Dolly, they all talk about different new surgical techniques like the wire procedures, which I think is sometimes a lot of interventional cardiologists may not know what kind of your technique is this. So I think it's a collaboration is important and see which procedure is the best for the patient. But Redo-TAVR is feasible if we plan it well. So how about coronary access? So coronary access is feasible if it is with a suitable anatomy. So again, CT analysis is important. So we can plan how we should do it. And you should know your valve well. And even this in the navitral valve, you could still plan it, although we don't have long-term data, but it's feasible when you do, even if a challenging access, you could put a note 2 and you don't have any problem with coronary access. So you have to do it and do it right. So select a patient with feasible anatomy. As I mentioned, full circular device expansion. We now talk about double tap and implant depth and estimated function neoscleral coronary anatomy and take into account for the leaflet overhang or the mode of valve failure and including commissural alignment. There are more and more new TAVR technologies and open cell, even balloon expandable with a supra-annular design and lots of new leaflet modification techniques, including shortcut or the telltale system in St. Francis. Also, I think now we do a lot of leaflet modification technique, and Dr. Cheng with the Unicon technique and Dr. Poon with the Y anchor basilica. These techniques is going to be useful for this kind of anatomy, and we can do it, and we can do it more regularly. So despite a lot of cases that we talk about TAVI, I mean, Dr. Hong already explained this very well. A lot of these data are only low-risk anatomy. So how about high-risk anatomy? So I think, again, some high-risk anatomy, we have to be cautious. And again, heart team approach is important because we have to identify who we should not perform TAVI. But again, most of the cases, I think, is a TAVI candidate. So we should be based on anatomy and not just to say this is age or SS. I think the lifetime management is important and shared decision is important. So thank you very much.
Thank you, Dr. Lai. And the next speaker, the Kong side, is Dr. Li Yongzai from Zhongshan General Hospital. Dr. Li, please.
Before I start, I will talk about there are two priorities before this talk. The first one is human being become longer life, because before it's 70. Now after 20 years, it's almost 90. So we talk about the old age group. Maybe in the future, 100 is no longer a dream, because Putin and the president, she just talk about implant a heart or something. So the age will become older in the future. So now the 70 should be young, and the 80 in the future maybe is still okay for the surgical aortic valve replacement. The second thing is the surgical aortic valve or any other or the TAVR device should be at the same durability, because the primary evidence that 8 years is almost the same. So it depends on definition of device failure, so that we should have more evidence to talk about this topic. And before this, I have 3 very important issues should be addressed in doing the TAVR for all patients. This is a very old paper. They talk about Paramount valve in aortic position. We can see here that there was a valve durability. They separate in different age. The younger age with bioprosthesis with more burial rate. So if a patient implant even the surgical heart valve or the THV valve, the durability should be shorter. And there would report that a patient received the perimount valve when they are 20 or 30, the failure rate becomes sooner, maybe even less than 10 years or 8 years. So this is a very important issue. If patient become younger and the TAVR for all, it become a very important issue. The tissue technology is not good enough for all patients. And the second thing is called the neo-sinus and the sinus flow. If we do the TAVR procedure, sometimes the sinus flow is not preserved. So there's a calcium and a lot of things will disturbance flow over there. So when you use the surgical heart valve, the sinus flow flush is better, such as you can see the Magna is. The sinus flow is better. When you doing the valve or THV in THV, the sinus flow and the flush will disappear. So it is very important. THV behavior different from the SAV because it deny even the supraannular valve. And the third is more important thing is the performance of THV is contingent upon the valve size and the design. So there's from the low risk of the ever root, the larger size become deteriorate rapidly. But from the other registry or trial, we found the deterioration of small valve in balloon expandable valve is rapidly. So all design of valve is different, just as the Professor Ye addressed the problem. So we should think about the surgical heart valve. The performance between the small and the larger one is very consistent. If maybe there's a mean 50 deterioration is around 15 years. So that's for the TAVR valve, we still have no data. But larger valve, maybe in the self-expanding one will deteriorate rapidly, and for balloon expandable one, the smaller one is deteriorated rapidly. So this is my debate. So the TAVR should not be left for all age group, and it should be left in limited patient. Thank you.
Thank you, Dr. Lee. After third round of the debate, do you change your mind? Or we were revolting? Please show the code.可不可以把那投票的那个再来一次？Oh, you can see a little bit difference, huh? Okay, thank you, everybody. Huh?
Attendees, lunch is now available for collection outside. You are more than welcome to bring your meals back into the menu and enjoy them as we continue the meeting. Thank you. Now shift our focus across the heart from the aortic to the mitral valve. This session covers the current landscape of anterior transcatheter mitral valve replacement and practical strategies for tackling complex mitral anatomy. Please welcome our moderators, Dr. Wei-Xian Ying and Dr. Shixian Song and Dr. Da-Xin Zhou, and other panelists.
A little behind the schedule, so let's get started. This session is talk about transcatheter mitral valve intervention. So first of all, I would like to introduce my co-chair, Professor Zhongshan, and Da-Xin should be on the air. And the Masa is on the air. Thank you. Good to see you. So we also have Pan Wenzi. Pan Wenzi is 在吃饭的. And Dr. Huang Muxiang and Dr. Chen Bo-song, Dr. Deng Bin-qing and Dr. Ye Xiaofeng. The first talk will be delivered by Dr. Masanori Yamamoto. The current status and the future perspective of MTR, insight from OCEAN Mitral Registry. Please.
Okay, thank you very much for inviting me. So can you see my slide? Okay.
Yes.
Can you hear me?
Yes.
Okay. Thank
Please.
you. Thank you. Unfortunately, I can't join in person. Sorry. And next year I will be. Okay. Here is my disclosure. And I want to talk about the current status and OCEAN registry data. So OCEAN registry concept is now is expanding our family members and with increasing centers. And the philosophy is non-political and physician-derived registry data. Okay. And the annual case of the OCEAN MTR cases are gradually increasing. And last year, approximately more than 6,000 of patients received the MTR in our cohort. And what about the initial results of the MTR in Japan and OCEAN registry data? Here is presented by Mike Saji in JAC Asia in 2023. Approximately 2,000 patients. Mean age is 80. Is probably, I think, very similar to the other Asian populations. And the female is 14%. 40% of patients are female. And the distribution of the MR etiology, the primary is 25, and the secondary is 75, including the atrial functional MR patients as 26% of patients. And mainly the first introduction of our MTR device is G2. The percentage of the G2 is 70%. Okay, this is the result of our initial cohort data. The 30-day mortality is 1.4%, and the acute procedure success is 94.7%. It's quite comparable with other registry data or RCT data. Let's move on the one-year results after MTR in Japan. Comparing with the other Western cohort, our one-year mortality is relatively lower in the calculating the 12, but according to the etiology differences, the secondary MR, the rate of the all-cause death is a little bit higher comparing the primary MR, and in similar to the all-cause death, rates of the heart failure rehospitalization is higher in secondary MR comparing the primary MR. So let's move on the rates of the acute procedure success. The overall rate is quite comparable with Western data or other registry data, but we need to focus on the MR etiology. So we see the relatively challenging space in patients with atrial functional MR. That means 10% of patients did not achieve the acute procedure success in our registry cohort. So now the guideline recommends atrial functional MR predominantly affects elderly patients with AF and preserved ejection fraction heart failure patients. So guideline rates the surgically class 2A and MTR class 2B in AFMR. So we need to consider the decision making who need to treat. But it's very interesting paper and very interesting registry data presented in 2024 late-breaking clinical trial, EuroPCR, two large registry data. One is our data, OCEAN Mitral Registry. The other one is a traditional heart failure registry data in Japan, and we combined both and analyzed the results of the all-cause death or heart failure hospitalization and propensity matching analysis to compare the results. Here is the data published in European Heart Journal this year. It is very interesting. So patient receives the MTR is significantly lower mortality rates comparing the medically treated even after propensity matching analysis. And second point is very important. Patient received only benefit from the residual MR moderate, less than moderate, equal or less than moderate. So we need to pay attention for that. Patient failed the mitral clip procedure, the survival rate is completely same in the medical cohort. So that if we want to do the patient, the atrial FR patients, we need to confirm the procedure success as much as possible in patient undergoing MTR. So let's move on to how to consider the optimal results after MTR. So here is a one-year result of the our OCEAN registry internal cohort. So it's very interesting and very important point. You know, patient achieving the moderate MR is not so good outcome. So especially patients primary MR, the moderate MR is the worst outcomes. And secondary MR also, there is significant differences between the patient after mitral clip and patient with mild and moderate. And residual MR is moderate comparing with a mild is associated with a significant increase of the mortality after MTR, so that even now the current concept of the acute procedure success is defined keeping the moderate or less than moderate. If acute procedure success is defined, but I think it's better to keep mild MR after MTR. What about the beyond 1 year? So this paper is also interesting. What is the clinical impact keeping the mild MR beyond 1 year? Okay, among survivors, we stratified patient with keeping mild MR and patient worsened mild to moderate MR. So clearly beyond the 1 year at the landmark analysis showing the significant worse outcome in patient with worsening MR comparing the stable MR. And patient groups with worsening MR is very low rates of the LA and LV reverse remodeling comparing the keeping stable MR patients. And so the right hand side, the absolute value of the trans TRPG is significantly lower in the stable group, and TR grade improvement is significantly higher in the stable MR group. So that in this context, so better to keep MR beyond 1 year after MTR. That is the second message. So we talk about the risk-benefit balance between the mean pressure gradient and residual MR. So in patient with a DMR, the TVT very large biggest data clearly showing the stepwise incremental risk of the MR and TMPG differences. So that means MR less than mild and mean pressure gradient less than 5 is the best outcome. And this paper didn't allow the patient with MR mild, but transmitral gradient more than 5 is not so good. But in patients with FMR, many papers disagreed in the literature. So FMR data, including the RCT, established RCT co-opt sub-analysis, there is no relation to the prognosis regarding the mitral gradient after MTR. Mild MR, but mean pressure gradient of more than 5 is acceptable, they mentioned in previous papers. But we reassessed a very large number of patients, including more than 2,000 of patients. You know, even in patients with FMR, patient need to keep mild MR and mean pressure gradient less than 5. And patient keeping the mild MR but mean pressure gradient more than 5 is a little bit higher mortality comparing the moderate and mean pressure gradient less than 5. So it maybe we need to change our theory. Okay. So how to optimize the current outcomes after MTR? So now we have many clip device improvements, not only the mitral clip, but also Pascal or some other devices we can available. And this is OCEAN registry data comparing with previous generation 2 versus current generation 4 devices. And the initial success rate is still high, even using the generation 2, so that there is no significant differences in terms of the APS, but procedure time is significantly lower if we choose the generation 4, and clip number is significantly lower. And of note, the mean pressure gradient, owing to the low number of the clips, the mean pressure gradient is lower in the if we choose a generation 4, and so that it's moved to the predictive factors of patient non-MR mild and mean pressure gradient more than 5. That means a non-optimal result. The predictive risk factors, independent predictive factors is G2, comparing G4 use. So the odds ratio is 1.207. So that the device improvements is obviously benefit for in our daily practice. And especially in patients with G4 devices, which is a lower heart failure hospitalization comparing the G2 generations. So that, unfortunately, there is no significant difference in terms of the all-cause mortality, but device improvements will provide our clinical benefit in our cohort. And new devices, we can use the other Pascal MTR devices. Of course, the MR reduction is completely same and a little bit lower rate of the moderate MR achievement in mitral clip comparing the Pascal. So it's a very good news. And there is no significant difference between the Pascal and mitral clip devices in terms of the mean pressure gradient. And of note, there is no SLDA cases in our cohort in the Pascal devices. So that is very good point. So device improvement is also very beneficial in our practice. But most important thing is the risk stratification. So that this is Atsushi Sugiura presented previously, even after the mitral clip device or the MTR advanced cardiac stage is associated with worse outcomes. So that the patient well risk stratification is mandatory, of course. And even the patient frailty status also is very clearly stratified after the mitral clip devices, not only the mitral clip, after MTR, significant worse outcomes in patients with more advanced frail patient. But this is the right side of the panel and the lower side of the panel. But even in the very advanced frail patients, we need to keep acute procedure success because the patient, if we fail the achieving to the moderate or less than moderate, the worst outcomes is observed. So that if we try to do such kind of very frail patient, we need to keep success. Okay. And GDMT up titration is also very important. After the mitral clip, it's not a final goal. It's to keep the optimal outcomes as much as possible. And even after the mitral clip procedure, in-hospital up titration with the GDMT is significantly associated with better outcomes. So that as much as possible to the up titration of the GDMT during in-hospital index. Okay. This is my last message. Thank you for your kind attention.
Thank you. Excellent talk. Maybe we can have a short comment from Dr. Matsumoto.
So thank you very much for a very successful registry and a very educational presentation. So what should I ask? It's very difficult. Why you showed gradient after procedure? It's related to worse clinical outcome. It's different from previous report. So what is the main reason? Of course, the number is big, but do you have some other factor that's related to the different result compared with the previous study?
Yeah, thank you very much for a very insightful question. And first of all, it's obviously the number of the patients, because the mean pressure gradient more than 5 is not so large in our daily practice. So that if we need to observe the differences, we need a more sample size. Of course, the previous registry or even the cohort trials, the number is not so small, number is not so large. So that is the first question. And I know the in similar reports from TVT registry, of course the registry data that in patient focusing on the DMR is still similar debate in the literature, but their data is more than 10,000. So that is clearly revealing the differences. That is a simple reason, I think. Because it is a very, how can I say, it's a common sense in the surgical field, so that the answer is very clear in even in the mitral clip or MTR procedures. Thank you.
Thank you. Okay. Thank you very much.
Masa, thank you for your talk because of time. Thank you. So we are going to have our next speaker, Professor Maurizio Taramasso, he is the well-known interventionist, and he will present us the transcatheter mitral valve replacement.
Good evening, everyone. My name is Maurizio Taramasso. Thanks for having me, even if only virtually, with you in Taipei. And I'm gonna share with you in the next few minutes some insight regarding mitral valve intervention. And I think it's a really good moment to talk about mitral valve intervention because we got some new recommendation in a guideline that has been published a few months ago to support what we do with the treatment of mitral valve regurgitation. Mitral valve is a complex structure with complex anatomy and complex pathology. Therefore, we really need to master different technique. We need more of the one approach to address all the procedure, and sometimes we have even to combine to address the complexity. Let's start from device therapy, leaflet device therapy, mainly TEER. The mitral Gen 5 is the most used still in Europe and outside Europe. There are 4 different clip sizes, as you know, and we can achieve excellent result in terms of MR reduction if we properly select the patient. The latest generation is the Gen 5. The clip is still the same, but the catheter has been improved in order to have easiness to use. It is more user-friendly. There is a better distribution of the tension, and the procedure is more smooth. I'll show you one typical case of FMR, which has been the most upgraded recommendation in the guideline. We have now a class 1A recommendation to treat those patients if they meet the co-opt criteria. I show you one example of a patient which is still in the co-opt criteria, so not too sick, young patient, very symptomatic, several hospitalization with severe functional MR due to a post-ischemic disease, so previous STEMI, no further option for revascularization, optimally and maximally tolerated medical treatment. This is the echo, so you see severe functional MR due to asymmetric tethering. The ventricle is not too bad, 45% ejection fraction, and the right ventricle is still okay. No indication for resynchronization. And this is the TOE. So anatomy looks favorable, long leaflet, no calcification, annulus is not too small, not too large. So this is a patient that we can treat with prognostic benefit. This is a co-opt-like patient where we can improve survival with a very easy and safe procedure. In this case, we put one single XTW clip, which I think is the best device if the leaflets are long enough, even in FMR cases. And this is how the result that we got after one single grasping with one single clip. So excellent result, only 2 millimeters of mercury of gradient and durable at follow-up. This patient is now asymptomatic. We obviously have also Pascal to perform edge-to-edge repair, which is a slightly different clip device based on nitinol. It has the big advantage of this elongation feature. So if we target a commissural lesion, the risk of getting stuck or entangling cord is much less because we can elongate the device and make it free, so an escape from the entrapment. So it's really appealing if you need to treat a commissural lesion. The results of Pascal are somehow comparable to the one obtained by MitraClip, so we can achieve excellent result with both devices in the majority of the anatomy. So operator preference plays a major role, but I think mastering both devices helps in some complex or specific situation. And this is just my opinion. There are no data to support that. But for example, if you have a really commissural flail, as I showed you before, having a device that you can elongate makes you much more relaxed. So this is a P3 flail that we treated with one single Pascal ACE. There was no need for elongation in this case, but obviously having the possibility to do it made this procedure really relaxed. With one single Pascal, we could achieve very good result. If you have high risk of stenosis due to calcific valve, this is also a really good indication for Pascal, mainly for Pascal P10, because having the big spacer between the pedal reduce less the residual valve area after edge-to-edge repair. So with one single Pascal ACE in the middle of the valve, we could reduce MR in a very good way without creating stenosis. So the gradient was only 5 at the end of the procedure in this high-risk situation. On the opposite, if you have a lot of tissue, large anatomy, like bileaflet prolapse, I think XTW is the best device to go because you can grab and pull more on the tissue and restore the coaptation of the valve and fix better the problem. So in this case, the regurgitation was central. With one single device, we could achieve a really good result. Or another specific indication where I prefer definitely MitraClip is if you have SEM, so LVOT obstruction and SEM, like in this case, you can grab a lot of tissue with the clip, in this case XTW, and bring it away from the LVOT by restoring the flow in the LVOT and abolishing MR. So I think in this case, MitraClip probably perform better. There is not only leaflet repair, edge-to-edge repair, also chordal repair is coming. There are many companies working on that. There are some first-in-man and early feasibility trial ongoing. I show you one device, which is the Cordar from Cormedic, that allows to repair mitral valve with flail by implanting this pre-measured corda. One corda is implanted, the distal anchor is fixed in the papillary muscle and the proximal one in the flailing leaflet, and we can bring the leaflet down and restore coaptation with a small footprint on the valve. So we still keep open option for further repair or replacement. We don't preclude any further option. So there is really a huge potential with this technique. And this is how it works. The Cormedic, you see one distal anchor which is implanted in the papillary muscle and one proximal one in the flailing leaflet. The first part of the procedure is really similar to a MitraClip, so transeptal access, and then a steerable catheter bring down the catheter. Then there is a grasper. We grasp the flail, and after the grasping of the flail, we puncture the leaflet with a needle, and the needle is directed to the tip of the papillary muscle, which is also punctured with the same needle. And then through this needle, we deploy first the distal anchor, you see, by retrieving the tube, and then the corda and the proximal anchor. So the proximal anchor is deployed, then grasper is open, and the catheter is removed, and now the flail is brought down with restoration of the coaptation with a corda that is in the anatomical position. This is just one of the cases that has been enrolled in the first-in-man trial. You see there is a P2 flail, and this is the comparison between before and after the implantation. You see there is a restoration of the coaptation with really good MR reduction, and I think there is a lot of potential with this approach, and this is the follow-up. Annuloplasty is also really appealing. At the moment, we don't have a lot of option. The only one approved in Europe is the Carillon, which is a coronary sinus annuloplasty device that allows us to reduce the anteroposterior diameter of the mitral valve, so improving then the coaptation of the leaflet by implanting this device in the coronary sinus and then cinching the coronary sinus. It has a role also as combined procedure. I think combining leaflet procedure with annuloplasty has actually a big potential for the future. There is not only repair, some valves cannot be repaired, so we need to replace them. And in this case, we have a lot of challenges to overcome because the mitral valve is not like the aortic, so implant a valve in mitral position, which is a dynamic environment with high pressure, is challenging. Sealing is an issue, fixation as well. Delivery could be an issue because the catheter are really big in order to come from the septum. Imaging is challenging, and then also risk of thrombosis, infection, and durability of the prosthesis could be an issue. We have 3 approved devices in Europe which are commercially available. The first one was the Tendyne, which has been delivered through the transapical access. It is a straightforward procedure. It has the potential to abolish MR, but it is transapical, so it's slightly more invasive, or much more invasive than a transeptal procedure. That's why we have now, luckily, also transeptally delivered device like the M3 Sapien from Edwards, which is a 2-step procedure that allows us to replace the mitral valve from the septum. And now we have also the High Life that got CE mark approval recently and will be soon commercially available. So we have more options in order to address this complex situation. In my opinion, if you can repair the valve with good result, this will always be better than a replacement. But of course, a good replacement is better than a bad repair. So if you cannot achieve a good repair, then replacement is the way to go. If you can achieve a good repair, this is better than a replacement. That's why it's extremely important to select the proper patient and the proper anatomy to achieve good repair. So if we can predict a good and durable repair, then repair first is the strategy to go. And then we can discuss whether device or whether approach is the best one fitting that pathology. Edge-to-edge, annuloplasty, corneal repair in the future. If you cannot predict a good and durable repair, then we should consider replacement. We should perform a CT scan. We should assess anatomical suitability, risk of LVOT obstruction. And if anatomy is good for replacement, then we should replace that valve. If this is not the case, we have to consider eventually a suboptimal repair or high-risk surgery, or in some case, just conservative treatment, of course. But patient selection will be more and more important when we will have more devices available. And in conclusion, I think we must be really happy and grateful that the last guidelines gave us more support to treat our patients with transcatheter-based mitral therapies. Our team behind the procedure is the keys to achieve good result in order to ensure that each patient get the best approach suitable for him. And those therapy has to be probably centralized. So this procedure has to be done in center with high volume and high experience in mitral treatment. And then last but not least, the procedure is just one piece of the whole patient journey. The journey of the patient starts before the procedure and continues after. So following up those patients after the procedure, ensuring proper medical treatment and proper follow-up is as important as the procedure. And with this one, I would like to thank you for the attention and wish you a good continuation of the Congress in Taipei. Hopefully next year I will be able to join in person. Thank you again for the attention.
I think given that it's a recorded presentation encompasses all the transcatheter therapy for the mitral valve, Professor Taramaso is not available, but we have Dr. Cheng. She has stayed with him for a long time. So just wonder, how do you define the boundary between the repair, transcatheter repair, and also versus the replacement?
Yeah, I think this is a really good question. But you know, for a long time, we don't have so many choices. Like in Europe, and we had the 10-9 for a long time, but the Abbott is quite conservative for their treatment. Like he only approved in the center has the 15 cases a year and really strict screening. So if we can do the repair, usually we need to do the repair until now. And also SAPIEN M3 is not so widely used. But I can tell you our experience, we implant the first compassionate use SAPIEN M3 in Europe. And what we understand, first, the screening is so strict, like all the replacements, maybe 70% has been ruled out. And our patient, we did an amazing case. It's so complicated, you know, M3, but we only spend more than 1 hour, 1.5. And the patient and the mild probable leak, then we submit to European Heart Journal, accepting 5 days. However, and in 1 month, the patient suffered from the COVID. And he had the probable leak become bigger and bigger. What we realized, it has maybe the cord ruptured, so the valve starts shaking. And then we return from the CT, we know the LV dimension between the 35 to 45, and the patient is exactly 45, so it's in the upper border. This is the reason when the patient has another really small problem, it's caused a big problem, and unfortunately the patient died. So we need to recheck our paper from the European Heart Journal. And so this is, I think it's still the older devices problem for the replacement. We have the screening outpatient, and we usually still try to go for the repair, and we also challenge more and more the gray zone anatomy for them.
Yeah, I think that is also a very challenging, especially a very short question. For those excluded 70% refer for the replacement. Do you think that, because we know that majority is due to the LVOT and some would due to the annular dilatation, but for those with LVOT obstruction, do you think that the modern leaflet modification can be further expand anatomy feasibility?
Yeah, this is a really good question. I know especially for the Asian patients, maybe this is more severe, the problems than the European population. I think it could be benefited a lot, but we know sometimes there's some new technology like Batman. Compared also, we developed lampoon from the tip to base, much more easier. And I don't know what's your experience. Sometimes it's not so predictable. Like we have some, well, in Ring case, is a really perfect Batman. And the gradient is low in intro procedure, but in 6 months or 1 year, then the gradient return, and we need to do the reduced surgery. And also, this is one point. Another point I think maybe comes from the device design. We know there's the aortic valve is from the totally HN physician. They say they only have the 17% of the anatomy exemption. So, but they also cause lots of the new problem, like how do we redo if they failed? We don't have any new access for it. I think from the anatomy side, we have more solution. One from the anatomy solution, like lampoon, Batman. Another one I think still comes from the device design.
Thank you. Because of time we need over. So thank you. So our next speaker is Professor Krista Munghomo. He will present us the mitral TAVR, the practical strategy for optimal result.
Okay. Good afternoon, and thank you, Dr. Sung, for kind introduction. Today's topic is the mitral TAVR practical strategy for optimal result. So today I will focus on the practical and reproducible strategy to achieve MR1 plus or less and durable result of the MTAVR. So this is my disclosure. If we look back at the day we start the MTAVR, so on that day we only have the first generation mitral clip. I think some of you guys still remember that day. So that allowed us to treat only A2P2 and just need to have the preserve a coaptation segment and smaller fail and just narrow fail width. So, but nowadays in Asia, we have only G4 mitral clip, so that provide us the 4 sizes of the clip and also feature with an independent leaflet grasping for easier and more precise capture of the leaflet, and also we can continue measure the left atrial pressure to the guide catheter during the procedure. So when we look at the result of the expand G4 rigidity, you can see the acute postural success is very high, up to 96%. That is much higher compared to the first generation, or even when we look at the average study. And also when back, I think Takashi remember that when we scrap in with the first general device, the mitral clip procedure, it took like 6 hours, so no fellow want to scrap into the procedure. But for the G4, you can see the device time now is just 35 minutes in average, and the procedure time is just a little bit more than 1 hour. This is Masa show this study already. I have an opportunity to write the editorial comment for this paper. So you can see when they compare the second generation mitral clip with the fourth generation mitral clip, you can see with the new generation device, the procedure time is shorter and less mechanical complication, number of clip, and also the mitral pressure gradient is lower compared to the previous generation. And also it's improved outcome. You can see the heart rate stabilization improved in the new generation device. This is the consensus from the APSC group. I think you guys see this before. So now we can treat more and more complex disease, like a smaller valve area, non-central lesion, and the short posterior leaflet length and barlow disease, crepe or MAC, etc. So I think when we look back compared to the average study, now we treat more and more complex disease. But I think the TAVR success is not just the device as one main, it's a strategy. I think 3 determinants of the success, including the patient selection, like Thomas show as we have more and more knows better about the patient selection, and also we have the advancement of the imaging and the planning and also strategy. I think the imaging is everything. Has anyone seen something here? So the early TAVR procedure, it looked like this. Try to find the polar bear on the snow field. It looked like this. This is the imaging from, I got it from my boss, Dr. Carr, very early, the mitral clip case. So when you try to perpendicular, the clip with the cavitation line, you have to go into the transcatheter view and coming back and use a single view grasping. We cannot see actual the trajectory because we don't have the biplane. And also after clipping, we have to go down again to see the bow tie like this. But now just one click, you can see very nice 3D imaging and use a few seconds to make the clip align with the cavitation line. And also the clipping, we can do the biplane clipping. We can understand the trajectory, especially when we treat the non-central lesion. And also after clipping, we can look at the 3D much more easy and look at the double orifice valve. So I think we need to mastering the imaging because the TE is the eye of the procedure. So we use it a lot, like planning the procedure, guiding the transeptal, the guiding the clipping, and also the assessment, the post deployment. So I think one of the mistakes of the procedure is spend not enough time for the transeptal, because if we don't get a good transeptal point, the procedure would be very difficult. So I would spend very carefully for the good transeptal point. So if we get the good transeptal point, the procedure would be much more easy. I think everyone want to refine the procedure. I would recommend to read this guideline that actually published 3 days ago in the JSE journal with the guideline with the intraprocedural MTF procedure. They illustrate to use the TE like a baseline evaluation until the end of the procedure to identify the result and septal shunt. So I think the clip steering and the implant technique is much more advanced now. So I think in the past, if we look at this patient, is a very elderly female, thin and small body build in Thai patient with the frail of the P1, and you can see the jet, the major jet here. You can see another functional jet here. This might be excluded from the trial 10 years back, but now we can treat with the non-central lesion. If we look at the literature before the Everest study, you can see the proportion of patients we treat with non-central lesion is quite small, like a 10%, 20%. But after Everest study, we have more experience. We treat more and more the non-central lesion, like almost half of the patient right now I treat is a non-central lesion. In this case, we just put the one NTUH here at the A1P1. So this is the result after one clip. This is just small MR with a gradient of 2. This is a follow-up echo. You can see the durability of the result. And this is another thing is how many clips should we put on. So this is, we should think ahead the procedure. So for the first clip, I think this is the most important. If we treat the functional, we just go, I go for the mid segment. And if we treat DMR, I would go to the fail segment. So I think the first clip is the most important. We need to put the second clip or add clip if the patient still have the lesser MR more than 2 pass or multiple jets or a very big venous contactor. But Masa showed that if the patient has a gradient more than 5, that related to the worst outcome. So we need to balance the regurgitation and stenosis. So I think this case, before that, we want treat, because when you look at the echo, you can see the entire, the P2, P3 fail right here. The patient admitted to another hospital for a month, cannot be activated, so refer to our hospital. You can see the echo is very big there. So I think this is the first XTR cases in Thailand. So we put 3 XTR, and this is the final result. It's good, gradient just 2. I think for the assessment, we need to balance between efficacy. We need to confirm the tissue breath and the MR reaction should be 1+ or less, or if we cannot, we should accept 2+. And if we look at the echo, we should see the improvement of the prevent reversal. And also we need to be careful to put too many clips with the increase the gradient more than 5. So we need to balance between the regurgitation and stenosis. And another thing, I don't rely on the jet purely. I want to show you the hemodynamic is important also. If you look at this, the patient is before the procedure. You can see the V wave is 64 and mean 38. After one clip is less than half an hour, you can see the mean gradient is just 16. You know that the patient would be improved definitely after the procedure. I would show the case as 2 weeks ago actually. This is a quite young 61-year-old Thai male. He has a dilated cardiomyopathy present with a CVMR with cardiogenic shock. So he cannot put any medication, need intubation. This is the echocardiogram. You can see the this doesn't work. Actually, the jet is coming from everywhere, very wide jet. Okay, it's work now. Okay, you can see the jet is a functional MR, but the patient is low blood pressure and shock. So you can see the jet is coming from medial to lateral commissure. So we try to do this procedure as a bridging for the transplantation. So immediately after we put him on general anesthesia, you can see it's something weird. The right atrial is septal bouncing to the left atrium, and pressure is very high. You can see the systolic pressure is almost 100. So we think the patient has a pre-hypertensive crisis from, I'm not sure, from the general anesthesia, but we discussed with the heart failure team. They want to stabilize the patient first, and we talked with the relative to stop the procedure. But after we put some nitro or something like that, when we back to the echo, we can see it's now the left atrium is very big and right atrium is smaller, and the pressure is lower. So we proceed the MTF procedure. In this case, we put the two, one XTW and one XT here. And you can see the residual jet is still 2 parts. Maybe you can see the 3 parts, but you can see the LV ejection fraction is very low. I would say it's single-digit ejection fraction. So we just stop the procedure here and we put the balloon pump and put the swan and send the patient to the CCU. So this is the end of the procedure. After balloon pump, you can see the PA pressure is lower and the waist pressure is only 13. So this is the clinical course. You can see after the procedure, the patient has a balloon pump and swan and primary core and norepinephrine. And after 2 days, we can discharge everything, remove the balloon pump and inotropic ducts. And this is he was discharged at 7 days after the procedure without any. And after after discharge, we can uptitrate the medication GMT right here. And the MR on the follow-up is just small compared to the immediate after is much more improved. I think this is a Euro SMR. You can see the result from the Euro SMR in the patient with the FMR. After the procedure, around 40% of the patient can be uptitrated the GDMT, and the patient that can have the GMT uptitration related to the improved on the clinical outcome, like all-cause death or heart failure hospitalization. So I think this is a beautiful of the procedure. It's quite safe. Even the patient is very sick, and also after the procedure is the hemodynamic stable, we can put on the GDMT, and patient will get the benefit from the GDMT. For the guideline now, the tier in suitable anatomy is a class 1, but I show the case that we may consider as the bridging or the patient is not suitable for heart transplantation immediately. So this is a 2B indication, but I think it's worth to try. This is you can see this is a class 1 indication for the FMR. So this is my conclusion. I think the good here is planned, it's not improvised. When we look at the result of the expand G4, this very nice result, but I think this is not only from the device. This is they are the robust of the rigorous imaging, precise trajectory, and also the discipline execute of the strategy. Thank you so much.
Thanks, Chris. Comprehensive talk and fantastic case. Just one, any question? Just one, Kevin.
Chris, it's a wonderful presentation. I just wonder why the G4 system nowadays is actually being better than the old versions, having a less pressure gradient. Is it actually due to the design of the clip, or is actually you put in less clip because of the better clip width and that kind of things?
I think this is the good comment. This is my opinion. I think you look at the result in Expand or in the OCEAN Registry, we use require the less number of the clip, and also the MR reaction with the wider clip is much more improved compared to the previous generation. I think this is one of the reason of why the gradient is lower. But I want to know from you guys, like Takashi and Adam, what do you think about the newer devices raise the gradient?
I think number of clip per patient is decreased. So I think gradient after procedure also decreased.
One major reason would be that the experience of the procedure team, which has been largely improvement compared to the G2 generation. So we can use less devices to treat almost similar, etiology or severity. So thank you, thank you, Chris.
Okay, please. Now I will invite our friends. Professor Takashi to give our lecture. His topic is how to solve the complex anatomy of MTR. Please.
Okay, so I'm Takashi Matsumoto from Shonan Kamakura General Hospital. My topic is how to solve the complex anatomy of mitral tear. So mitral tear has now become a standard of care for a selected patient with significant MR. So now technology device is advanced. We can use both G4 system and also Pascal, and our team skill is also improved. So we challenge some complex situations. So for successful procedure, I think we must master both some tips and tricks and basic technique. Then what is complex anatomy? So we just published APSC consensus recommendation for mitral tear and tricuspid tear. I am the one with the chair of this project, and we look at this paper, then the complex anatomy. So small mitral valve area, the non-central pathology jet, and the short mitral posterior leaflet, and barrow disease, and the cleft, and the calcification on leaflet, and prior annuloplasty, surgical annuloplasty, and the rheumatic pathology, and etc. So as unfavorable anatomy, the leaflet perforation, and moderate to severe mitral stenosis, and the left atrial thrombus, and left appendage thrombus, and active IE. So what about our result in such a complex situation, anatomy? Then when we look at expanded trial, this is a pooled analysis of expand G4 and expand trial, included 2,205 patients. So after procedure, mitral clip system achieved MR grade equal or under 2%. It's 94%. So it's very high. So what is a very important point to achieve a high successful procedure? The first of all, of course, complex anatomy is challenging, but procedure complexity is often self-inflicted. So technical precision, so it means complete each step perfectly, is very important to avoid procedure cascade, and a good enough attitude at the start, sometimes it leads to a complex finish. So as Chris showed, mitral TAVR procedure has several steps: access site, the transcatheter puncture, advancement device from groin to LA, and the CDS insertion and manipulation inside the LA and the LV, and the closure of access site. To complete each step and take time is very important and very simple and very important even for our complex anatomy. So there are several complex anatomies, but the time is limited. So let me show two scenarios. One is difficulty in grasping, including a large gap, and the other one is cleft. So when I treat a patient with a large gap or some I think this patient we face difficulty for grasping. I let patient admit a little bit earlier and give diuretics and dobutamine and optimize hemodynamics. And if patient is developed a decompensated heart failure, I consider IABP or some mechanical support. This is one example. This is a patient with non-ischemic cardiomyopathy. Here, before when I see at outpatient clinic, there's a huge gap between anterior leaflet and posterior leaflet. And I let patient a little bit earlier and give just diuretics, and gap a little bit improved from 8 millimeter to 4 millimeter. And this is also interesting case. Here you can see gap between anterior leaflet and the posterior leaflet. And I gave just small amount of medication. And the leaflet started to touch. And it's a little bit strange, very small heart. This is very small heart. This is a 12 years old toy poodle. This is my dog. So when she developed a decompensated heart failure, we can see a very significant MR-jet. But just we started a medication, she recovered, and leaflet started to touch. Even for a small dog, medication is very important. So, and this is one scenario that 75 years old male admitted for acute decompensated heart failure. Clearly, we can see 1 centimeter gap between anterior leaflet and posterior leaflet. So, of course, the key for this patient is this significant MR, but of course, there is a risk of leaflet tear if we do a mitral tear for this patient. So, in this case, I started IAPP, so wedge pressure and PF pressure dropped down dramatically, and the leaflet started to touch. Then I sent this patient to a mitral tear. And what we can do during procedure. So now I don't use so much, but rapid pacing and ATP sometimes works very well. And also for improvement of leaflet coaptation, high PEEP and nitro, it's reduced the venous return to our right side to heart, so and improve leaflet coaptation. And also now we can use independent grasping. So if we face a difficulty of grasping, I use independent grasping. But when we use this technique for functional MR, we needed to take care of our leaflet tear because we needed to pull leaflet and both annulus to the other side. So there's a slight risk of tear. And leaflet technique of leaflet grasping, I usually, most of the doctors use it as slowly pull back clip and adjust to anterior side, posterior side, and grasp leaflet. But I prefer quick grasping. At systolic phase, from center of leaflet, I pull back clip a little bit quickly. So the center that should be clip should be center. The center means if clip is located to center, the both leaflet, anterior leaflet and posterior leaflet touch shaft at the same time. This is movie. So first, the clip is a little bit anterior side. So anterior leaflet touch shaft first. Then I adjusted a little bit of a posterior side and pull back. So let me show. So anterior leaflet touch first, and I adjusted posterior side and pull back at systolic phase quickly. So this technique works very well because at the systolic phase, the leaf rate is very stable because of our systolic pressure. And at that moment, just quickly pull back this clip and place just behind the both leaflet. And most of the case, we can grasp leaflet. Then let me talk about cleft. Cleft is one of the very difficult situation. I think we have 3 techniques. One is a sandwich technique using 2 clips, and the other one, second one is grasping just beside the cleft with 1 clip. The third one is cleft closure with 1 clip. So sandwich technique is very simple. Just deploy clip both sides of cleft. But of course, we need enough space for 2 or 3 clip deployment. Otherwise, we can create significant MS. So the second technique is grasping just beside the cleft. So here you can see a jet from a posterior cleft. The cleft is located in the middle of P2. So in this case, I used the NTW clip and just placed lateral side of cleft and a little bit clockwise. Then grasp both leaflet and MR gone. So this technique is very useful even in a little bit small mitral valve area. But the difficulty of this technique is to find an optimal sweet spot for optimal reduction of MR. Sometimes we need to check lateral side or medial side or just clockwise or just counterclockwise to find the optimal point. And third technique is cleft closure. This is AML cleft, the cleft located between A2 and A3, and deep cleft. So in this case, I use an NTW clip and turned 90 degrees and grasped A2 and A3 here. Then MR gone. This is 3D images from a LA side. The clip is here. It's almost like a normal valve. So this is, of course, technically difficult, but it works very well in AML cleft, AML deep cleft. But if I use this technique to PML cleft, most of the case it doesn't work because this is a cleft in the posterior leaflet, P1 and P2. I placed the NTW clip in the grasp the P1 and P2. Then indentation between P2 and P3 opened, and significant jet started from this point. So I stopped the procedure. I don't remove this clip and stop procedure and send this patient to surgery. So here is my approach to cleft. If cleft is anterior side, and I try cleft closure with 1 clip, but it doesn't work, or cleft is located in posterior side, I try grasping just beside the cleft with 1 clip, and it doesn't work, and there is enough space for 2 clips or 3 clips, I try a sandwich technique. Here is a conclusion slide. Thank you very much.
Thank you for your wonderful lecture. I think your technique is very impressive, especially for how to treat the cleft. I think it's very interesting and impressive. I think the definition of complex is complex. For the non-central case, non-central anelopy, I think for the P1 or P3, I think for most of our the product is no complex case. So I think the definition of complex maybe change over the time. Okay. And any question from our panelists or audience, please?
Thank you, Dr. Matsumoto. And I'm Dr. Wang, and I have 2 questions. The first one is, you're talking about decreasing the gap and using some medications and even diuretics. But if sometimes patients has atrial fibrillation, do you think like cardioversion will also decrease the gap? Is workable for this kind of patient? And my second question is, in your experience for cleft patients, anterior, posterior. Usually, I'm wondering the percentage just by one clip can solve the problem, or in what percentage you need still 2 clips to solve that? Thank you.
So thank you very much. It is a very good question. So first one is, if patient have AFib, we should do a cardioversion 1 knot before procedure, right? So most of case, I do cardioversion if there is chance to return to sinus rhythm. But in most of the case, we can stabilize hemodynamics and improves a gap between leaflet. But it is rare, but I faced 2 or 3 cases. After cardioversion, gap becomes significant and crushed. So my hypothesis is that the most of patient, AFib patient, is tachycardia. In that case, inflow to LV is a little bit small, but once it returns to sinus rhythm and heart rate dropped to 80 to around 60 to 80, then diastolic phase, it's become long, and inflow to mitral LV increase, and it increase the LV size of LV, and coaptation gap become large. Maybe this is just my hypothesis, but it's there. I experienced just 1 or 2 cases. And second question, sorry, what is the second question?
Usually 1 clip or 2 to solve the clip. Yeah.
Personally, most of the case I try to treat with 1 clip, because most of patient is mitral valve area to be very small. So there's no chance for 2 clips, but of course I start with a 1 clip strategy, but it doesn't work, and there is enough space for additional clip, 2 clips. I try a sandwich technique.
Thank you.
Okay, thank you.
Thank you.
Great talk. And the last talk will be by Siwei Yu from Singapore. The role of echo and the CT in transcatheter mitral valve valve, please.
Thank you very much, Professor Yin and Professor Chow, for this very nice invitation. It's really a pleasure. So far, I really enjoy all the talks. My role today is to talk about the role of echo and CT in transcatheter mitral valve, and in this in particular is by mitral prosthesis. I don't have any disclosure apart from the fact that I am a structure imager, so I'll do my best to deliver this talk. I think the important thing about transcatheter mitral valve is that you can see the data from the TVT registry that since in 2017, when it was FDA approved for valve-in-valve, that the numbers has increased. In the past, we used to do this under transapical, but we have now switched very much to transeptal. And then when you talk about transmitral valve implantations, really you're talking about valve in previous prosthetic ring or prosthesis. However, also there is the valve in mat, which is native. And the truth is that the complications with native valve are much more. My focus is really on the first 2, which is the valve in valve as valve in ring. This is the latest TVT registry that looks at transeptal mitral valve-in-valve, and you can see the numbers really skyrocketed. And that's because now, if you have a failed prosthesis in the mitral positions, you can actually put in a valve without an open heart surgery. And the data shows that in 3 years survival after transeptal valve-in-valve is much more favorable in those with low or intermediate SDS score, and those who are urgent case, such as non-elective, or those with high surgical SDS scores also has worse prognosis in the longer term. Why? Because of other comorbidities. What are the issues with mitral valve-in-valve or valve-in-ring? The real question is because you are going to put in a valve inside a prosthesis or a ring, it will push open the native or the prosthesis valve, anterior leaflets, and push towards the septum that increases the risk of LVOT obstructions. And when we plan this case, we really need to look at the projected or what is the simulated valve after you put in, what's the neo LVOT area. And I've divided into 3 main components. One is prosthesis related. If you have a big valve, if you have one that is going to flare, it's going to increase the risk of LVOT obstructions. And in patients with anatomy, such as septal bulge, or in patients with small LV, or sometimes with very huge or long anterior leaflets, for example, in a post-mitral valve repair, has got a caudal that's a long mitral leaflets, it also increases the risk of LVOT obstruction, as well as those with acute mitral aortic angle. And the real question then is that how do you optimize if you have a patient who has a small or increased risk? You might actually want to implant the valve not too deep, as well as one where you reduce too much of flaring. So these are really the three things you have to think about for each individual that's being evaluated for mitral valve in valve. The predictors are here. I have summarized it and talked earlier. Acute aortic mitral angle, septal bulge, elongated anterior leaflets, especially those with mitral valve ring, of course in native MAC, as well as those with small LVOT dimensions or in small LV. So the role of CT really is to understand a few things. Look at what is your patient's bioprosthesis that failed. What is the size? What is the flow marker that you are going to depend on when you do the prosthesis? And the next question on CT is actually to plan the procedure. Is transceptor okay? Look at the septal height. Look at the optimal C angle, as well as the predicted LVOT area. So I'm going to go through a few cases just to illustrate this first case in Singapore that we did, which is a failed St. Jude EPIC mitral valve replacement, which is a 33 millimeter. This is back in 2012. You can see on TE that this is a flail prosthesis leaflet. You can also notice that the LVOT is not abutting, or the valve is not abutting of it. There's room of neo-LVOT, not an issue. We confirmed then that the CT shows an internal diameter of 28.5. And then we use the apps then. What we need to plan for is a valve that is about 2 millimeter that exceed the internal diameter, not to oversize too much because then you have under expansion, but a 28.5 will probably be a 29 quite well. So we then do a CT, confirm that the neo-LVOT is not an issue. This is an EPIC with a flow marker that is really faint, which is the basal ring, which is tiny, and you have to really focus on that. We did this under transesophageal guidance back in 2012. This was in transapical access, quite nicely placing the Sapien XT 29 millimeter then. And then post-procedure, you can see that this is a very nice flaring and conical placement such that it will anchor at the sewing ring, which is barely seen on fluoro, and this on TE guidance. So the issue really that I've spoken about is the risk of LVOT obstruction. When you do CT, they are gated. You can do it at 20, 30, 40. The recommendation is do it at systole. However, it seems that the early systole is much more a better determinant on LVOT obstructions. I tend to do it about 30 or 40 really just to make sure that I go through every phase and what's the risk. Now, what happens in a patient with a failed bioprosthetic post-mitral valve repair with an annular ring or mitral annuloplasty? There are different types of ring. What is most suitable for valve in ring in what is one that is complete and semi-rigid, that once you put in a valve, you open and circularize the prosthesis. And this way you could have a good anchor, at the same time the risk of paravalvular leak. Obviously in the native valve that has got the highest risk because there's not much of a good anchor unless you have a circumferential mitral valve that is totally calcified around the mitral annulus. The second case is one where a previous, again, mitral valve repair. In this case, there is a physio 26 millimeter ring, and then you can see that this has got non-coaptation. It was referred to us to see whether we can do mitral edge-to-edge repair. Too big a gap. We didn't have a technique earlier that is shared by Takashi, but anyway, we thought this is not a good case for us to do an edge-to-edge repair because of a lack of coaptation completely. The valve gradient is pretty okay. We went to and looked at the CT, and CT give you measurements that is really depending on what you want to look at. So usually we size it based on a simulated size. For example, in this case, it's an XT 23 millimeter that kind of fit around the whole ring. We also check the LVOT, neo-LVOT, it's very roomy. We also have the CT to actually plan in terms of the implant angle, how you can do this quickly on the table. And then in this case, we did it using this was done in 2016, so it was a TA approach, and nicely showing that the valve is sitting about 15% into the LA, and then trying to expand it under TEE, you ensure that you have a good expansion. And then post-expansion, you can see there's 2 paravalvular leak, and then it's not surprising because this was a ring. So we actually repeat ballooning to have a good seal, and you can see that very nicely post repeat ballooning, there is very mild paravalvular leak that's at the edge, which is very acceptable, and the patient still survived till now. The other complications we have on mitral valve in valve or valve in ring is that of thrombosis. This is a 76-year-old who went through mitral valve back in 2014. And because of the previous history of spontaneous subdural hemorrhage, she elected not to go for an anticoagulation, but only on double antiplatelets. Just about 3 months after her procedure, we just followed the patient up with transthoracic echo. You can see that the mean gradient came from 7 millimeter to 10. And here we have a pressure half time. For those who are familiar, pressure half time tells you that if it's long, means that it's stenotic or obstructed mitral valve. And in this case, we just do a esophageal echo. We see a non-leaflet movement, only 1 mobile leaflet. After anticoagulations, her warfarin, 3 months, the anticoagulations has worked and the valve has opened up. She's still on follow-up with me and very happy. She hasn't had any hemorrhage with bleeding or elsewhere. She's on long-term anticoagulation, and her gradient remains about 6 to 7 millimeter, just like her previous post-valve in valve baseline. This is the last case I'm going to share, which is the patient with previous mitral valve repair with neocords for a flail anterior mitral valve leaflets. And you can see here that she developed mitral regurgitation, very severe, and the leaflet length is very long for the anterior leaflet here. The anterior leaflet I measured is about 23 to 25, and this was a neocord that has snapped, so a severe aortic mitral regurgitations. Did the CT did not actually predict a neo-LVOT. However, as you know, this is a TAVI, this is a mitral surgery in the past. When we do measure LVOT in the CT, we actually don't measure the leaflet length, what happens to the anterior leaflet post mitral valve. So it's very hard for us to predict. Anyway, we elected to do a lampoon. This is a lampoon procedure because of the long LVOT anterior leaflets. So we did it quite nicely with a flying V with the AV rail. And then I have to make sure that the anterior leaflet is actually lacerated. And this is tip to base. We have a prosthesis mitral valve ring that kind of protect. And you can see that this is nicely in the A2 where you have a split. And then after that, we put in a valve that is quite easily, and her gradient was actually very good. With no LVOT obstructions, with no increase in LVOT gradient. This is my last slide. Really, when you consider a patient with prosthetic mitral valve dysfunctions, you really have to think about what's the anatomy. If the anatomy is one where you are going to have a risk of neo-LVOT obstructions, then perhaps you can do a redo surgery if the risk of the surgery is not high. But in a patient who is high risk for redo surgery openly, then you may have to do leaflet modification technique. You saw a lampoon, how can be done, but now I think we have other procedures such as Batman's, whatsoever, you can do this a little bit more easier. So thank you very much for your attention. I think really the key of imaging is to ensure that we have a safe procedure, and also during procedures, we can kind of understand this very well on transesophageal as well as fluoroscopy. Thank you so much.
Thank you. One short question or comment? No? Kevin, you want to say?
Maybe I ask some questions about the outflow trap obstruction. Seems like the alcohol septal ablation is falling out of favor compared with the lampoon procedure. Is there any reason why ASA is not done very frequently in these circumstances? Is there any evidence to support that?
Yeah, I think the question is whether ASA is something that you will use. You really need to look at the anatomy. If the anatomy doesn't belong to one where it's basal septal hypertrophy, having an ASA is not going to help. So it really needs to tailor to your patients and anatomy. What do you expect to do with the different technique to reduce the risk of LVOT obstruction, whether it's sesame, whether it's alcohol ablation, whether it's Batman, really. Yeah.
Okay, thank you. Well, thank you, Dr. Yu. And we have 5 wonderful talks covering most of the hard topics in transcatheter mitral interventions. I think we all learned a lot, and hopefully this, all these imaging measurement guidance or planning and the procedural tips and tricks can help us improve our daily practice. I thank you all for your participation.
So welcome to this live demonstration, live transmission section. So I'm Hsin from Taiwan, and also co-chair this section with Professor Wang and also Professor Cheng, and also we have online moderator Professor Xi, and we also have a couple of panelists, Chris and Ivan, and Atsushi, and also Professor Shi Zhiyuan, and also online panelist, Professor Feng Yuan, and also Professor Fang Zhenfei. So we have the first demonstration will be a demo from Zhejiang Second Affiliation Hospital of Zhejiang University School of Medicine. So we have Professor Wang.
Hi, good afternoon.
Online.
Good afternoon, Hsin. Can you hear me?
Yes, very clear.
Okay, good afternoon, Hsin, Professor Wang, and dear moderates, our panelists, dear friends, ladies and gentlemen. So welcome you all to join the live demonstration at Taipei Valve 2026. So the case with the TEER procedure for severe transcatheter regurgitation is being transmitted from the Second Affiliate Hospital, Zhejiang University School of Medicine. First, I would like to introduce my colleagues working with me today. So Dr. Liu.
Hi, good afternoon.
Xianbao Liu and Dr. Wang. He's also a junior attending. And also we have two technicians working with us. On my left side, we can see our Dr. Lin for echocardiography recording, guiding. And also we have several nurses here. So welcome to join us. So first, I would like to invite Professor Liu to introduce the case. Welcome you, Professor Liu.
Okay, Professor Wang. Good afternoon, everyone.
Could you show the PPT?
The slides, please.
Slides, please.
Next one.
Can you see the slides?
Yes.
Okay.
Good.
And the patient is a 75 years gentleman. The patient has a recurrent chest discomfort for over 5 years. The patient is actually included in the TTA China, the RCT trial, and the patient have already waited for over 1 year. However, the symptoms still recurrent, and right now, the patient is across to the TTA group right now, and the patient here has a history of the atrial fibrillation and the post left atrium closure, and with the severe tricuspid regurgitation. And the STS score for this patient is about over 10%, and TRI score is about 4. And the patient has already received the optimal medical treatment, including the diuretics and also the ARNI and also the SGLT2 inhibitor. Next one, please. And this is the EKG. The patient had the atrial fibrillation. Next one. And everyone in our TTA China, the patient have to receive the right heart cath evaluation. We can see right here the patient, the pulmonary artery pressure, the mean about 15 millimercury, and the pulmonary artery pressure is not so high in this patient. Next one, please. And from the TE, we can see very severe, the massive TR with dilated right atrium, and the left ejection fraction is good, and TEPS is about 20 millimeter. Next one. And this is the TEE. So the severity of TR about 4+, and leaflet morphology about a type 1. And we can see very clearly from the transcatheter view about 3 leaflets. Yeah, and the ejection, the jet position from the anterior septal and also the central and also the posterior septal. And the clipping strategy for this patient, that we would like to put 1 to 2 clips in anterior septal and 1 for the posterior septal. And the device we will use today, next one. Device, next one, please. And device we will use today is Dragonfly T system. So I think you know quite well of the design of the M-tier device. I think the device is quite similar with that of the mitral tier device of the Dragonfly. We just added one more knob from just to to judge the septal arc, where we can adjust the L and S. Okay, this is my presentation. Thank you so much, Professor Wang.
Hi. Because we are concerned about the transmission time, so we already started the case actually, but the procedure is still going on. So I would like to have your comments on about yours regarding your strategy for this kind of case. So how many dragonflies do you suggest for the patient? Where we place the dragonflies?
Mm-hmm. Yeah, thanks, Professor Wang and Professor Liu. I think this is the patient with massive TI and also although it's type 1 morphology, but I think the procedure is still challenging. We have a couple of panelists here, so I would like to have Ivan. What do you think? Because what they have proposed, the Clover technique. How do you define whether or not we go for bicuspidization or Clover technique to treat the tricuspid valve?
For me, I would always aim for the clips to be placed in the septal anterior commissure first, and always I would reassess whether we should add on the additional clips in the septal posterior. So this is always my strategy. And the interesting thing for this case is I also always use the dragonfly to do the tricuspid valve, but I use the mitral valve version. And it's good to know that they have the new version of the dragonfly that have the additional septolateral features in the guiding.
Yeah. Yes. Zhuzi, you also have numerous experience.
The procedure planning between Clover and also jipping, it's pretty much depends on, from my experience, the size of anterior leaflet. If you have a big enough anterior leaflet, you can just go a jipping technique. But like in this case, because anterior leaflet size is relatively limited, if you look at the anterior posterior commissure, so I would start with, I agree with you, start with anterior septal clipping, but followed by posterior septal.
So, so how many clips are you going to deploy between the anterior septal?
Okay, I saw you have a.
This is the before we deploy.
Yeah.
Deploying, you can see that.
So I think the strategy for this case, tricuspid judge, we're beginning from the septum and anterior, and then posterior septum. So from the, it's a very, very good candidate for TEER case. I think maybe you already put 2 in anterior and septum, and we can put, I guess. So,
okay, actually,
I
yes,
totally
you're
agree
right.
with your strategy. It's a good. Normally we put 1 in anterior septal, and sometimes we put 2. I seldom put 3 in anterior septum. So.
Oh, good idea, maybe.
Yeah.
So, firstly, initially we think about placing 1 dragonfly between anterior and septal. But when we place successfully the first one, we think we need to add a second dragonfly to further closure the anterior and septal. So now we have successfully delivered 2 dragonflies between anterior and septal. Can you see that from the flow side by side? So now we are going to deliver the third one. Still going on. So what is your suggestion where we need to place the third one? Still alive?
This is a live echo now?
Yes. No, this is a live.
This is a live, yes.
This is the live.
Yeah, I think it's a very, very good strategy. I saw the original image showing that the gap between the septal and also the posterior is quite large. But now we see that you already shorten the gap. You mitigate all the gap between the posterior and also the septum. I just wonder what is the plan for the 2 clip on the anterior septal, which can further improve the coaptation between the posterior and septum.
Yeah.
And then would you given up from the image, we saw that the TR might not be that severe. You should, maybe 2+ or less than 2+. Just wonder, would you thinking, how do you decide whether would you go for the third device?
You know, we hope to eliminate the regurgitation. But what is your comments? Maybe we can stop the procedure here, or we add one more?
No, I very agree with you. Given that the patient originally had very large gap between posterior septum, and also I would also agree that you can have the third devices to further remodel the annulus. I think which can improve the long-term durability of TR reduction.
Oh, thank you. That's exactly what we want to do now. So now we are the third clip. Yeah. The third dragonfly is already close to the valve annulus. Can you see that?
Yes.
Okay, but the orientation still some.
Yeah, we will check the orientation. Yes.
Issue with the orientation.
Yes.
差不多吧，下到这里，你再看看吧。
好来，魏迪。
We check the orientation from transcatheter view now.
What's the orientation you prefer for this?
We prefer horizontal orientation.
So that means
3 to 9
o'clock.
Yes.
So maybe we need to clockwise.
Clockwise a little bit. Yes.
你要看清楚啊。你那个要帮我们看清楚。
我下去。
下去就 diving into。你们下。
So Dragonfly, you have 4 sides of device, right? So
yes,
large,
yes.
And this is the large and the wide one, correct?
Oh, okay.
Maybe what do you think the orientation is good enough?
Long and wide.
Yeah, long and wide.
Long and wide.
Yes.
All of 3 are long and wide. Do you think we need to a little bit more clockwise?
差不多了，因为你等会下起来会转。差不多。
Professor
Wang.
Wang.
We need to move backward a little bit.
Yeah, maybe a bit too central, maybe a bit towards the commissure would be better.
I think so. I fully agree. Too central. Maybe we need to pull back a little bit. The whole system.
I think the position is good.
Push forward.
I think it's good.
You think good?
Yes.
I think a little bit.
Yeah. I think it's just at the center of the P1. I think the position is fine.
Yes.
And also,
I think it's good. Yes. 差不多，我觉得。
Now we are diving into the
right
ventricle.
Yes.
Do you agree?
Yes.
We need to close the dragonfly a little bit, or just keep this shape, keep this angle, keep this angle.
Yeah, I think it's okay.
I think keep this angle.
Yes.
Going down.
Yes.
Going down.
它转回来一点。
不。
好 ，OK， 下去。
Too much。
OK。
你这样转嘛，等一下又要转过去了，现在变成这样了，碰不到，这距离 distance， 上面就，
差不多。
We need more clockwise, I think.
Yes, OK， 一点点。
clockwise， 但是
可能还是要往前去一点。
Would you too posterior? Would you go?
前去。
Yeah, I think
我们再松掉一点点，靠进去。
不用。
OK，it's good。拉起来就差不多了。
When
要不要
colors 看不清楚？
要不要拉起来？
别紧，让他，你能不能把两个 arm 显清楚啊？他那个反光 echo， there is。
往上提点就到了。
提起来就看到了。
它有个 echo 在那里。
More。Yes，
它上面一个回光是
有点干扰。
What is going on？
隔板在了。
Yeah, I think you have septal leaflet.
Septal leaflet is on.
Posterior still not.
Yeah,
I think we need to go toward the previous two. We need to go 还是要往这边靠近，反正能抓住。那个上面的。
你觉得位置再靠近一点？
靠近一点。
它这个 P1 中间差不多，我觉得差不多。
或者。
I think this is
这边的后半小
，OK，
往这边的后半就。
会这个 alignment 不行 ，alignment。
We are not able to grasp the posterior leaflet.
Yes.
Sometimes it's
或者我们往后再打
not
一个，
easy
好
to
不好？
grasp posterior
我们往后打一点。
好，现在差不多好一点。
Do you have any tips and tricks?
好 ，OK， 打后。
I don't know, but I like this, maneuver using the transcatheter view to get Because I think mainly because the 40IS is now commonly available, widely available in Taiwan. So I like this maneuver using the transcatheter view to see how the leaflet has been restricted. You got the posterior leaflet. Yeah, you got both. I think it's very delicate and very good maneuver that can show you that you get, including the leaflet insertion and also orientation in a single view. I think that would be the key to, to have procedural success, especially in patients with complex tricuspid anatomy.
Okay, good. Both leaflets on?
Yes.
Maybe.
Yes.
I think toward the.
Would you close it?
No.
Yes. 再看到后半，请你看到后半的那个张度，切到后半。线你的
突发
取样线到隔半，说错了，隔半。
Previous two.
Yes.
Two dragonflies.
张力还可以。Yes. 还行，好 ，OK. Good.
Can we see the flow? Can we see the color is on plate?
Okay.
Can we see the regurgitation? 这什么颜色
？Interference.
Almost disappear, right?
还是有一点后半的。
后半的。我觉得后半
没夹紧。
Did you fully close?
So only go to
half.
No. Only go to half. Tighten more.
要不我们到那个看看，到中再看看，保存一下。
Don't you think in transgastric image sometimes it's not too easy to say how well leaflet are engaged on the device? So
Yes.
we had the leaflet, but we were
Color,
not sure
color.
how much. That's why I also agree to see this trans-esophageal recall.
我觉得可以关紧的看看，还有那个 fully close.
What are your suggestions? Further tighten?
Yes. All the way. All the way. All the way.
To the end.
看看。
是看了。
有一点点，跟原来比已经好多了，还剩了一点点。
第三个夹子好像没有 very helpful。第三个夹子上跟
比原来还少，王老师。
少。
Yeah。下面你再评估一下。
好的。
差不多 to the end。我觉得要往那边看。
There's still a little bit of the regurgitation, so is that acceptable, Professor Wang?
I don't think so.
We're just thinking the fourth device.
你把这里的颜色上看到这个 color 从哪里出来 ？Where's the
So would you suggest the fourth one?
So where's the jet coming? Between
where's the jet coming from?
Between the
more posterior?
The clip with the previous two or 它大部分从这里出来。
它从还是靠后的那个地方。
靠后。
还是靠后，我觉得可以接受了。I think I can accept the result.
哎，师贤 ，What is your idea?
So,
Professor
can
Wang.
we review
Okay,
the
welcome.
previous transgastric view? I think is that any possible to change the orientation?
其实不多了，其实不多了。
The previous transgastric view.
来，找到位底。
Echo 原来的那个。
把原来的那个打出来。原来的位底，术前的。
术前对吧？
术前非常非常多。Massive TR. Yeah, 术前。
Yes, transgastric view. We think so.
Same color, please.
Color is on, please.
Yes.
Color is on.
Yeah, you can see right here.
Guess maybe 2-8 direction may be better than 3-9. Is that possible?
So now you quickly come back to the
septum, posterior, maybe
left. 你回到那个现在的那个 left， so same view, with the same view。回到现在的那个 transcatheter。
王院长建议方向变一变。
对，先宝，你看我们原来，你看看那个原来的，在 2-8 那个方向会不会更好一点？因为
不会，它这个跟它的影像那
2-8。
原来的那个 leaflet posterior 和 septum。
那不会，那它因为它的 alignment， 它的那个 edge to edge， 它所谓 edge to edge 就是要把两个，所以你斜过来把前后加起来了。那这个为什么会 color 是？
有点干扰。interference。
它因为 because of the previous clip， 它其实从这个，其实这个平面是不太适合于看 regurgitation quantify 的 regurgitation 的，这个看起来都比较轻的。如果你这样去比，肯定你后面深一点，前面一点点。
王院长你好， 建安院长，我是何奔啊，这个在现场啊，非常精彩的一个病例啊。
你好，
那个
你好。
也，我想这个你怎么显示这个 grasping， 就是怎么看？刚才我似乎没有看到，就是那个把它抓住的这个角度，能叫超声把它搞得清楚一点。
新兵，我们可以那个 go over step by step， 就是
第三个，
不是最后一个，就是最后这一个。
就怎么还没下夹的时候，你怎么肯定？
对。
对，怎么这个角度还没显示？
我们放大。那个它两个那个从那个 transcatheter view 上看，它两个 leaflet 都是搭在这个 arm 上，你可以指一指，它没有往两边滑过去。如果你没有 hold 住的话，它会这样下来。你 hold 住的话，它是这样的一个感觉。看我两个手，它是这样的感觉。
对，半夜受限制了。
受限制了。如果它是没有 hold 住的话，它会往两边滑。它这样往两边滑。它现在是你看，轻轻的在上面。你看到吗？
看到。
你千万不要被那亮的迷惑了。我以前专门被那个亮的迷惑，后来事前说那是那个 cover， 很薄的一层。你指一下，那个谁啊？新平，你要指了，你没指准。
这个是线索真的。
你手抖了，你没有帕金森嘛？你那抖就抖住在那2层啊，看到吗？
就我们从
是干什么？
那个王院长，我们从这个。胃底这个角度就可以了吗？还是要再回去？
这个最牢靠，再回过头可以在那个 middle transcatheter view 去 confirm 一下，因为你老拉嘛，舌管病人老拉，有经验的就看这个。我呢需要两边看，所以我还经验不够。那个先宝他们的，包括小王他们认为 confirm， 我就比较心比较虚吧，有点神经衰弱，所以要拉到这个中间来再 confirm 一下。你那middle esophageal， 你回到middle esophageal， 就这个位上回到middle esophageal， 我们再 confirm 一下。middle esophageal 呢，有时候也未必，你以为这个平面是最好，其实未必。这个你再看看那个，大家可以看。那个不，你夹在
对
上起来。
这个夹子没有。
他前面是不是没保存啊？
对，
我前面没看。
看你那个新平老师不保存，关键的不保存。
前面没做。
不该要的都保存了。
其实前面你 confirm 了，所以你没回来看。
它两个从这个平面上，这个叫 inflow outflow view。inflow outflow 打得好的话呢，你前半后半都能很看清楚。这个前半后半是很准确的，后半跟隔半和后半，这个是比较准确的。
我们这个夹子是有的。
你两个 arm 上去的时候就拖上去。
他前面没有应该，他就因为我们前面王老师，我们就在胃底上弄了以后就夹闭了，其实没有回到那个。
没有回到那个。
没有那个，
因为他们都很有把握。那像这种，这个是第二个夹子，这你看。
这第二夹子。
看到吗？这第二个也一样嘛，说明原理是这样的，看到吗？这两个都在上面，但其实还是要两个配合起来。
胃底好看。
你要 confirm 一下的话，先在 transcatheter， 再回到这个 middle esophageal。去 confirm 一下就行了。那个何教授，你能看到吗？刚才那个
我看到了，是的，说明王院士您的团队非常有经验。就刚才我说的，就是先保前面在胃底这个角度，我们直接上夹了，但是那个没有回到这个食道。
他回来也看了，当时他可能没录，是不是？
没回来，
其实王老师没来看，其实他都不看了。
没有，我经常希望在 middle esophageal再核实一下。但是确实是那个 transcatheter， 如果你很清楚的看到两个搭在那个上面，它是这样一个关系了，不是一个这样的关系。如果它滑到两边的，那肯定不行。如果它是上下的轻轻摆动的，
因为你这里再看一下，评估一下。
Can you show us the residual TR before and after the third clip? Before and after.
你在同样一个
inflow outflow view，inflow
outflow view 两边比较，
看看那个，
因为 inflow outflow view 最容易显示这个，这是 after 3 clip，after 3 dragon flights。Now we go back to the。
好，再来把之前的打出来。
Go back to the
two clip
previous one
after two clip
two clip
before the third clip。
旋进，别旋转出事情。好，把它扣紧。
After
不要一个夹子，一个夹子以前完全没有夹子。
他说错。
一个个来，一个个来。
完全没放过的时候。
就是说第三个没有太大的 helpful， 这最大的问题就是说，就是跟前两个的结果差不多。这个讲要不要
？We saw that after two clip, it seems that you already have equal or less than 2 or even 1 to 2 plus TR. But after the third clip,
yes, that's a problem.
Yeah, we see the TR even worse a bit. Maybe it's related to the orientation or the tension on the leaf plate. So we don't know why, but I think maybe we can reposition
你把第二个夹子
the
切一下，
third
在第三个
devices.
夹子再切一下，我们两个比一比，到底怎么样？
After second dragonfly,
第二，这是第二个。
regurgitation is reduced further. However, adding the third one doesn't improve the outcome.
来第三个，
doesn't improve the
现在的。
第二个现在是
Yeah, maybe it's a good reason to reposition the third
第三个
device.
So we need to reposition.
OK， 那我们起来。
第二个完了，结果是很不错了，所以第三个好像作用不大。
第三个加上去没有 improve。
对，就
没有
是看看。
improve。
回到位底。
I think the orientation. We need to check the orientation.
复习原来的那个 Transcatheter， 我感觉是28的 orientation 应该更好一点，还是或者是 tension 来的？
横肯定要横过来。
来，先把位底标准的切面打好。
打好了再看。
Maybe
我建议给你调高一点。
还有我们能不能往？我看还是要往这个两个夹子的当中上面去一点。
他现在王老师，他现在从上面 P1 和 P2 之间出来。
他是你看看从上面。
所以王院长的意思呢是，让我们再往这样拉上去以后，相当于把 P1 和 P2 的 gap 缩小一点。所以他就我们这个呢下去以后，稍微转一点上来。 稍微转一点上来以后，这样就把这个下面拉上去 ，gap 拉上去可能会更好一些。那这样我转过来一点点 ，a little bit， 我们可以这样试一试。
把它 hold 起来一点，让它平，至少打平啊。
现在有点。
这边。
王院长，您说的是这个意思吗
？Posterior 没下去 ，posterior 好像没有上去。
Professor Wang，yeah，
是的，两个再靠近一点点的，好像。哎 ，OK， 我觉得这个方向呢？
再靠近一点点 ，OK，
哎，这个方向好像
靠近了。您说的是这个意思吗？
对。
我们可以试一下，这样方向跟原来比不一样了。我们试一试，王老师。
Yes。
我感觉这 orientation 我们需要的 orientation 还是一个 horizontal 的，但是我们可以 toward。
我们可以试一下。
Toward to previous。 你试一下，但是你后半也没上。
对，后半我们往后打一点，
多一点，再打一点。
We have several panelists online, Professor苏
上了。
冯源 and Professor 方正飞，苏西。
应该在。
Any suggestion for this case？
后半在了，隔半在吗？隔半是不是不多？
隔半在，我觉得后半不多。那你到那个没得也少不节，我们再看一下两个半音。
对，
再 confirm 一下。
根据何老师的意见，刚刚我们再到，你看到隔半不多，是吧？隔半不多。
打开一点，然后再把这边往后去。
我可能往隔去一点。好，去点了，再拉起来一点。
差不多。不好说，前半后半也没掉。
那么再到位底再看看。看前面到位底再看看。
王院长，你认为 ？Do you think 的这个 orientation 好吗？
他感觉不在后半。
哎，我觉得后面的 orientation 会好一点点。对，这个应该。
我觉得前后交界。
我觉得是不是太靠交界了？就太近了。
Yeah, the posterior arm is at the anterior.
Yeah, we should move a little bit to.
Yeah, I think
Yeah.
The lateral arm was on the commissure.
有个箭手好像已经飘起来了，小心点。
Basically, in dragonfly, you can go independent grasping.
我觉得是不是那个了
？Yes, we can go independent.
因为它角度一转以后呢，它就转到角落里去了。
Yes.
平的话呢，就是刚好是在后半里面。
I think maybe the 3 to 9 o'clock still fine for.
我觉得我就再转回去一点，否则这样可能很难抓。那这样转回去好一点。
And then you probably need to scan
那
on the
个
lateral
后叶还
arm.
是没上。
那我往后半再打一点。
后叶没上，后叶我这稍微再转一点，我觉得还是要把它平过来。
Simply you can scan on the lateral.
第二是
现在隔板在了，隔板在了，但是
靠斗，主要有个靠斗在那里，
后半不在。
现在很在。
好，王老师。后半不在。
I think one of the issue here that we have is the imaging, because if we look at on the right hand image, we are not on the really parallel to the tricuspid plane, so we don't really see the coaptation line of the posterior septal commissure. That would make it difficult to engage the leaflet. So that's one thing we can collect. The another thing what we can do is 3D MPR if it's available.
再拉起来。
好，你前面那个 arm 总是没看到嘛？
是。
后沿那个 arm 始终没看到嘛？啊？
对，它还不够高，拉的也不够高，给拉起来可能。
高已经很高了，再高上面就出来了。啊。
隔板肯定在。
后也不在啊。
可能还是要到位底的。
兜一点看看。我大一点看，就现在这里先调吧。反正都出了吗？
没有。
没有，
感觉没有，但这里可能不一定准确，我觉得这里可能不一定准确。
我也觉得平面戳开了。
你还是到位底吧。
位。
到这是平面戳，隔板肯定在，隔板可以，隔板肯定在。
监院士，我们这样好不好？因为我们转到安贞那边，等一会儿我们再回来看你的结果。
OK，
可以的 ，Welcome you back。OK，Welcome you back。Yes。
OK， 所以我们现在看看转到安贞医院。光远教授好。
哎，王院长你好啊！看到刚才你在台北啊，以及前面的精彩的 case，那我介绍一下啊，非常高兴参加我们台北瓣膜会啊。We are so honored to join Beijing Valve. This is Dr. Song from Beijing Anzhen Hospital. And I see many friends, Dr. Hsin, and many friends online, and Dr. Feng and Dr. Fang. Let me introduce my team. It's Dr. Jiang Zhengming, is the first assistant. It's Dr. Cheng, and we have the echo cardiologist is Dr. Li Jing and Dr. Zhang Qian, and we have the anesthesiologist Dr. Gu. Okay, I will let Dr. Chang to introduce our case. So this is, I think it's a little bit complex before the procedure, but after, we scrub on, it's kind of difficult. Yeah.
Okay, thank you. I will introduce the patient case. This is a case of severe aorta and mitral regurgitation, and we will do a combined TAVR and TEER procedure. Okay, next. This is a 77-year-old male patient, and this patient had chest tightness and dyspnea for 3 months. The coronary CTA revealed mild plaque in the LAD, and also the laboratory test revealed elevated BNP, and his hepatic and renal function and the hemoglobin remains within the normal limit. Next one. The ECG revealed sinus rhythm and left ventricular hypertrophy. Next one. Okay, so we can see the TEE imaging to see the aortic regurgitation. Next one. Okay, we can see a severe regurgitant jet under the aortic valve, and the quantitative measurement of the aortic regurgitation is VC-wise is 7.7 millimeter. The EROA equals 0.45 square centimeters, and the R volume equals 91 milliliter. The ratio of the jet width to LVOT diameter equals 75%. And also, we can see the patient's left ventricular enlargement. The LV-EDD equals 62 millimeter. The LV-EF, the ejection fraction, equals 43%. So this patient had symptoms of the heart failure and also the enlargement of the left ventricular and also the decrease of the left ventricular ejection fraction. So we think he has the indication for aortic valve replacement. Next one. So we conducted the CT imaging of the aortic annulus. We can see the morphology from the LVOT to the ascending aorta. Next one. Okay, this is the measurement of the annulus. We can see the perimeter equals 96.7 millimeter, with the mean diameter equals 30.8 millimeter. And also the left coronary artery height at 10.9 millimeter. The right coronary artery height at 15.2 millimeter. Okay, next one. The transverse angle is 33 and with no calcification. And also we can see the left ventricular enlargement at the CT imaging. Next one. Okay, this is the multi-plane measurement from LVOT to 10 millimeter above the aortic annular plane. And we conducted this consecutive measurement to provide the multi-plane anchor and the sealing of the prosthesis. Next one. This is the artery imaging of the vascular access. We can see the artery diameter is above 6 millimeter. So the patient is favorable for the interventional procedure. Okay, next one. As the patient has a very large aortic annulus, so we want to use dedicated prosthesis that designed specific for the aortic regurgitation. The valve have 3 positioning lugs that will be deployed in each of the 3 aortic stenosis. And we will have the big size. Yeah. Okay, next one. Also, we can see the severe mitral regurgitation from the TE imaging. Yes, we can see a severe mitral regurgitant jet from P2 and toward the left atrium. Next one. This is the MPR imaging, and we can see the specific location of the prolapse is in the P2, is in the P2 mitral leaflet. Next one. The prolapse range is about 9 millimeter and also with a 4 millimeter gap. Next one. We also measure the leaflet length at a different zone, and we find a cleft at 2.5 zone. The length of the posterior leaflet is only 3.8. So we need to avoid this zone to do in the TEER procedure. Next one. Okay, this is the quantitative data of the TEER procedure. We can see the prolapse range and also the length of the leaflet. Next one. Okay, this is the several points.
So, okay, this is a little bit complex case. 77 years old, was rejected by the surgeons. They don't want to treat this kind of patients. And we can say, what should you do about, with mitral prolapse combined with aortic regurgitation? So, will you go to the surgery? I think we should do the first option to surgery, right?
Yeah, it depends on patient surgical risk.
Yes. Okay. But this patient, he was declined. So what we'll do from the interventional procedures, like should we treat? I think we should treat both, right? Will you do staged or will you do simultaneously?
光远你好，我是丰源。
老冯。
那个首先感谢医院的和曹总邀请。另外，我想向刚元请教一个问题：这个病人我看你是计划是同期做TAVI 和2间半的 TEER， 那么你的房间隔穿刺是在做主瓣之前完成，还是做完主瓣之后完成呢？
对，我觉得冯主任提了一个非常重要的一个问题，就是我刚才也在问大家，我就说我们是一站式的做还是分站式的来做？如果一站式来做呢，反正有几个考量。如果说你要做2间半呢，我觉着相对来说呢就会比较顺一点，因为你要穿完间隔，然后把夹子放完，然后撤出来，我们再重新再做这个主动脉瓣。这样的话呢，你也不担心主动脉瓣那个瓣位啊。放上瓣膜以后，有个金属的尾影在那儿。上一次我们做了一个病人，我说这个很简单，我们先把这个JenaValve就是 Trilogy 这个瓣膜先放了，放完之后我们做偏前交界一点，最后就老是有一个尾影在那干扰，就看不清你的瓣叶。所以呢，我说这个如果说我们先做2间半可能会好一点，但是我们就有一个风险，就是说你做完了之后，因为你主瓣返回来要冲一个血流在这儿。那么你术后做完了2间半的这个夹子会不会晃的会比较厉害一点？我们也可以一会儿再看一下。所以，我是想，如果我们能先做2间半，我们可以先做2间半。所以这个病人，我们就是上一个病人我们先做的主瓣有一个尾影，影响了我们操作。那么这个病人呢，我们想还是先做2间半，然后呢看看究竟有没有太大的一个影响啊。
好的，关于我为什么提这个问题呢？因为我们没有同时做。TEER 和主动脉替换，但是我们同时做过2间半和主动脉替换。我第一次做的时候就搞错了顺序，我是先做的2间半替换半中瓣，然后再做的主瓣的替换。结果呢，就是做主瓣的时候就把2间半上放上去那个瓣膜呢给戳了以后呢，它就有点移动，不得已呢，后来做完主瓣又在2间半那儿补了一个瓣膜，把第一个瓣膜压住才稳定。所以你这个是因为是 TEER 和我们那个半中瓣有点不一样，它要求也不同，所以这样你提供一个很宝贵的经验。
是，谢谢。
光远教授还有一个很重要的问题，就是当你那个 puncture septum 以后 ，what's the pressure of the left atrium? If the left atrium pressure is high, I think TEER for mitral is very good for this case, and maybe we don't do the operation in one stage, and the patients can benefit from the TEER. Because AR, a lot of patients can tolerate the AR for a long time. Because we have the intervention. If a surgeon, of course, both do the operation together. 我就想问一下那个左房的 pressure 怎么样？
刚才术前测的左房的 pressure 多少？
So Chris, what do you think? What would be your sequence? Would you prefer?
他们可能还没来得及测。
Hello, so this is Chris from Thailand. So this is truly complex patient. So because in Thailand we don't have the dedicated device for the AR, so I cannot comment for the AR. But normally when we have the 2 valves, I think this is the beautiful of the Transcatheter procedure. We don't need to do at the same stage. We can do 1 valve first and do another valve after. But if the patient has an MR and the AS, so normally we would fix the stenosis valve first. But this one is an AR and MR, so I don't have a exact answer. But like Dr. Wang said, if we can measure the left atrium and VWAP is really high, so sometimes we fix the mitral valve first, and the patient can tolerate with the AR. And if the patient has the symptom, we can back to fix the AR after. But if in Thailand I would fix the mitral first because I don't have the valve for the AR. So.
Okay. Yeah, I agree with you because Chris, I think if we're facing the multivalvular disease, normally we will treat aortic first, and then mitral, and then tricuspid. For this patient, we can say the it has, a very large left ventricle, and the ejection fraction goes down. Let's measure the 左方压侧。对。So this patient, I think mainly due to the aortic regurgitation. So we can go to the echo. Please, 把之前的那个超声放一下。
Guang, we also have Atsushi.
Thank you. Professor Song, and this is Atsushi Sugiura from Japan. Thank you for having me.
Hey.
And I would, to be honest, go aortic first and followed by mitral if necessary, because we have several cases. We put mitral tier, but we had a recurrent mitral regurgitation because of the volume overload due to aortic regurgitation. So we know the sequence after TAVI in an AR, where patient will get really decreased LV size and the volume will be reduced, and that would facilitate the durability of the mitral tier. So I wouldn't just go alone for mitral tier. I wouldn't leave aortic regurgitation. So that's why I would go first aortic and followed by mitral.
Yes.
I think majority, some of us would also prefer the aortic intervention before the mitral, given that would also have some impact on the LV volume and also the LV pressure, which is very, affect the MR severity. And
Yes.
So,
Wang, but this patient, Hsin, we can see, the patient has a small, like prolapse, maybe flail.
Yes.
And, the aortic regurgitation is huge volume.
Yeah.
So I think main etiology for this patient should be aortic regurgitation.
Yeah.
But, as we don't want to treat the patient twice, so I think we can do the one stage. But, the sequence is to mitral first and aortic first, in the one stage procedure. So, but we tried before. We tried to do the aortic first, and we put the trill valve inside, but we can see, some shadowing when we do the mitral, especially if the prolapse is close to the anterior commissure area, so it should be some shadowing. But for this patient, so we decided to do the mitral first. But for mitral case, now you can see the flail is over here, and we try to grasp. Let's go next.
Yeah, agree with your point that the DMR might not be really improved after the aortic intervention. So can you show us what is your status?
Yeah. So we try to grasp over here. Now go next. Yeah, we close over here, but it looks like we don't have enough posterior. So we try the second time. Next. 这是我们第二次做完了以后那个。So here's the second time. We have enough posterior, but we still have a small jet. 那个有 jet 那个图吗？ Now you can, no, 这是最后的了，前面呢 Now you can see over here. Now we grasp as posterior, as we can, because posterior is very short, right? Now you can see there is a small jet coming, between the clip and the anterior. So I worried about, maybe we have some damage to the anterior. And we checked for many times, but we didn't see any damage. Then we decide, to grasp for the third time. We go a little bit anterior. Now you can see this is the third one. We go a little bit anterior. Next. Now we close it. Only a tiny jet runs. Let's check the status now. 现在的。Okay, I want to you guys to make sure there is it's the right leaflets inside, And the tension is good. The gradient is 2, right? Yeah, gradient is 1. And the pulmonary wing, we check the pulmonary wing. Yeah, it's normal? Yeah. Yeah, okay.
Professor Song, it
Yeah.
looks really beautiful, and also amazed that you use 3D MPR. Is that your routine use or is just a selective case?
Normally I routinely use, for the multi-view, because especially, this patient, let's go to the 2D. We can show them, the patient, have, I think the heart, changed. We cannot find, the good 2D view from this patient. Explain. Now from this view, now you can see it's more close to the P3 area, right? But actually, if we go from the multi-view, we can see it's right in the middle. So now you can see we cannot grasp over here.
Yeah,
What
that
do you think?
explains a lot how 3D MPR is useful to understand the entire anatomy and your orientation in mitral.
Yeah. Yes, yes. Okay, everybody is satisfied. I'm going to release this clip.
Yes,
if
please.
you agree.
Yes, please.
Okay? Yeah, let's go to the multi-view and let's check. Okay.
Professor Hsin, you usually use some MPR for every case or just?
Usually I don't use MPR that often only, but it really can showing you the the image regarding the orientation, leaf lay insertion also, and as well as the trajectory, which is very important. But it also have too much pressure on the images. So I still now would keep 2D image, and also 2D image can show very the resolution. I think comparing to 3D is even better. But sometimes if you have some off-angle, off-axis image, I think always if you can have a good 2D image, you can always have a 3D image for the procedure.
Okay, I'm going to close it off. Okay.
And Kevin? So
I
given
will
that
release some
in Hong
tension.
Kong, you also the 3D, 4D IC is also available. When you have image challenge on the
Okay, what do you
mitral-
think? I'm going to release. You guys agree with this?
Yes.
Okay.
It looks that you have very good grasping. Okay.
Yes, I guess for 4D eyes, mainly used in the tricuspid valve intervention, but not that much in the mitral valve intervention.
Do you think you have a role when you have very poor image quality on mitral or very?
I guess still the role of the eyes is limited in the mitral because most of the time you have to cross the septum and put the eyes in left atrium, but sometimes you have the shadow from the device itself.
看啊 OK， 那我们把这个线先撤掉。OK。So I'm going to release this lock line because we use the G4 system. It's NTW. Okay. 不用，没动吧？没动啊。OK。Now we can see the clip is stable, right? But let's final check the color.
Yeah, the image looks good.
Okay.
Yeah, we don't
Then
see any. We don't see any.
We will go to
registration.
we will go to the. Okay.
It's a good result, very stable. And
would you like to give us a 3D fast image and also with color and a single image alone?
3D， 单纯的 3D。
The bottom right.
OK。就不要 multi-view， 单纯的 3D。OK。切一个薄的。不是你切多一点，你那个框切小了。对，切多薄一点。OK。Good. Good. This is good. Okay. Color.
Good. Good.
Okay.
Yeah, it's very congratulations. It's very success procedure.
Okay. Okay. So we will go for the aortic regurgitation.
Yeah. Also, we are very interested in aortic intervention for using the dedicated.
Because this is also a big analysis. You can see the main diameter is over 30, right?
Yeah, I think it's also another challenge in aortic position. But we have a tricuspid tear demonstrated from the university hospital. So I would move and we'll let you to deal with the aortic regurgitation.
Okay.
Maybe if we have time, we can go back.
I will come back.
Okay. Thank you. Thank you.
See you.
Go back to the Hangzhou.
来，我们换大桥。
Hi, Professor. 先宝教授在吗？
刘院长跟王院士先下台了，这个临时有会议，他们先下台了。我们刚刚第三个，宋教授好，第三个夹子，对我们刚刚尝试了一下，先解开之后，往这个第一跟第二个夹子近的方向去靠，顺便转了一下方向，但往两个夹子去靠呢，这边这个 gap 比较大，尝试了一下之后没法抓不住，后来我们又移回到第一次这个位置。稍微调整了一下方向之后，又把它夹掉了。第三个夹子呢，当时评估了之后，感觉反流还行，跟第二个夹子放完之后的反流量应该差不多，大概1到2级的样子。那院士跟院长评估应该还可以接受，我们就这个夹子放掉之后，就准备这个测系统了。
就是第三个夹子放完以后，就是比第一次放的那个效果要好一些。第三个夹子。
好一点点应该。
对，想问一下你最后的方向是什么？
最后我们应该还是在差不多应该是我想想看啊，应该8点半到2点半的样子吧，就没有完全平。
OK， 这是它的方向啊。2.5 OK，right。好，谢谢啊，非常恭喜啊，祝贺很精彩的一个3间半，那个Triclip 还有这个 Triclip T， 这个 Professor Wang Jian is an inventor of this new device. I think it's performed very well case, not only in the mitral but also the tear. It's very nice. Thank you very much. Congratulations.
Thank you.
Okay, because of time limited, we will close this session, and thank you all the moderators and the panels, and also thanks Professor Wang and Professor Song's team. Thank you very much. Let's close this section.
start the next section. This section is the roundtable discussion, coronary access after TAVI, about involved and the Redo-TAVR. And we have, I'm Tianmin Chao from Zhongshan General Hospital, and we have co-moderators, Dr. Yohei Ono, and Dr. Lianglong Chen, and Dr. Chen Fang Lo, and also distinguished panelists, Dr. Andrei Pop, and Dr. Kapun, and Dr. Liu Lai, and Dr. Shi Junmin, and Dr. Li Wenlin, and Dr. Huang Qihong. So I would like to invite the first speaker, Dr. D.W. Park, for his talk. His talk is sinus sequestration in TAVR, how we expect and handle it. Dr. Park, please.
Okay, thank you. So my topic is one of a catastrophic complication TAVR and the sinus sequestration in TAVR and how we expect and handle it. We're gonna share some important case. This is my disclosure. So, and this diagram is a very well-known diagram published the JEG intervention, Pop. And if you consider different type of valve in valve, we should consider several anatomic factors like a coronary risk plane and the Nail-Scott plane, NSP, and the relationship, also the coronary risk zone in the space around the sinus area is an important key factor to avoid the coronary obstruction or sinus obstruction. So, and this the diagram is introduced nearly 7 years ago in the Rajamaka group and the Resolve registry, and they proposed a very interesting case, sinus sequestration. Is 7 years ago. At the time, we don't know well what is sinus sequestration, and this is a typical example of the sinus sequestration initial valve. This is the initial valve, saphenous valve. We should consider first valve commissural level, and if you implant additional valve, and if first TAVR commissural level is covered in the sinus access, that is absolutely risk of sinus sequestration. So, and in this article published the JEG intervention, they defined what patient is a higher risk of sinus sequestration. They define the first TAVR valve commissural level is overlying SD junction level. After implantation of the second valve, there is one of the key factor, and also distance between TAVR valve and the SD junction VTJ distance less than 2.0 was one of the key factors. This is very practical when we consider valve-in-valve procedure, we consider such a risk for assessment of sinus sequestration. So, and the patient having enough size, today the first live case, even valve-in-valve when the coronary risk is low, but this sinus area proportion is narrow, and the prior valve, the leaflet can block the exit of the sinus. That is absolutely higher risk of the sinus sequestration, and such as the below case. So in this Resolve registry, in the Rajamaka registry, and they compared the CT identified the risk of sinus sequestration in the Redo-TAVR procedure, and the red color is the initial valve, saphenous valve, and the blue color is the initial valve alveolar system. Absolutely, we recognized where the risk of coronary sinus sequestration much substantial with the alveolar system rather than the saphenous system. So we're going to show that we are experience 3 and 4 very typical example of sinus sequestration. This is our first sinus sequestration case, but this at the first time we don't know that is the sinus sequestration. This is already 7 or 8 years ago procedure. This 80-year-old female and 3-vessel PCI, initially 2012 core valve implantation using 26. And this patient during the follow-up developed valve failure. EUA is 0.74, and the mean pressure gradient is 43. Vmax at 4.3, and the main mechanism prior valve degeneration, and we consider in the valve-in-valve procedure. And approximately 2020, we did the second valve implantation. So looking at the CT scanning is very narrow, the sinus proportion. The inner long diameter 22, and the mean diameter is 21. And the sinus valsalva area, as you can see, is very narrow. Area is 621. And this is ST junction. There is absolutely no space for this. Also, this is a sagittal view. This is very the remarkable image. As you can see, coronary height left is 1.1, quite low, and the right coronary is 0.9. Also, sagittal view with you shows there is no enough space. It's very narrow, the sinus proportion. That was a procedure 7 years ago. At this time, we don't know the sinus sequestration concept. Initially, we checked the coronary angiography before implantation of a saphenous valve, and the coronary angiography is a selective coronary angiography, nearly impossible. And the adjacent coronary angiography shows the coronary flow is okay. So, and we try to the coronary protection and the coronary angiography, and then we put the wire, and then we put the balloon for coronary protection. If patient having some coronary obstruction, we initially plan to the balloon the implantation. So initially we do the pre-balloon dilation using GMAD balloon. You can see coronary protection, put the non-compliant balloon is proximity part, and then we try to the cover using the saphenous valve -1 cc on the pill in the core valve 26. This is 7 years before procedure. At this time, is a node 4, node 5, node 6 concept. The absent is we don't know at this time is ejector positioning. So we try to cover the prior failed valve. So and as a result, we put the saphenous 3 at the node 6, and usually node 6 is a higher implantation. I think we're gonna do this case, and right now we are try to the more narrow. But although we are lower position, although we put the low position, this is still very high risk. So higher implantation is make sure better hemodynamics, but the lower pacemaker rate. However, they are very vulnerable to high risk of sinus sequestration. So after the implantation, second valve, saphenous valve is -1 cc on the pill, and we recheck the coronary angiography. So it looks okay. Patient vital sign is okay, and we pull back the previous is a coronary protection NC balloon, and we very smoothly expel the NC balloon, remove, and there is no the resistance. So, and we checked coronary angiography again several times. This is coronary angiography. At this moment, we didn't any idea about the sinus sequestration. Patient vital is okay, and the adjacent coronary the angiography the flow seems okay, and during the hybrid rhythm there is no any event, and we also checked the portable echo. There is no regional wall motion of the malady. So, in the hybrid room, we did 11 a.m. The MAC status not easy to check the new chest pain. ECG is no ischemia. Echo is no regional wall motion of the malady, and 5 hours later, patient developed a new chest pain. ECG, new ST depression, blood pressure is going down. Is borderline SBP is 90, and we did emergency coronary angiography, and the flow to the left coronary system much delayed and slow, and so finally at the night time we decided to the emergency bypass surgery, LIMA to LAD, SVT to the RCA, in the hospital day 7 patients discharged well. This is our first sinus sequestration case. At 7 years ago, we didn't recognize this case. So sinus sequestration can happen in the TAVI subtle case. This is somebody recognized our AP valve live case demo is coronary obstruction, and initially patient underwent CE surgical valve 19, and the very narrow is the valve inner diameter is 16, and the long diameter is 18. Is quite small valve, and the sinus of Valsalva is also narrow SD junction. Is also the ratio is 2.04, and the area is 485. So coronary height is quite low. Is absolutely, this is high risk of the coronary risk case. So, and we put the first the saphenous valve at the insertion of the saphenous valve, but there is a remainder of a residual gradient. So at this case, we try to the valve fracture using the true balloon. Is David Cohen is supported this case, and we did the valve fracture. You can see the recognized some fracturing of the valve, and hemodynamically is good. Is the pressure gradient is disappear, and using the non-compliant balloon. So, but this patient is developed these hemodynamic changes. Blood pressure is going down, and the leaflet of surgical process is absolutely blocked the sinus exit. This is some calcium is blocked sinus exit, and the prior leaflet is blocked the sinus exit. So we do a very urgent procedure. Even one giant stent implantation, there are still remain the narrowing portion. We decide to additional 2 giant stent, and the final result is flow good. Patient hemodynamics is much improved, but it's the few days later CT scan still some not the circumferential expansion of the valve. So and I look back the PubMed is what is a systematic reporting the sinus sequestration. There is no report. It's all case like some case report, and very diverse scenario. In some case TAVR in SAVR, and some case late sinus sequestration, and this is very interesting. During the follow-up in the heart valve endothelial irrigation can cause sinus sequestration. Some case even 3 months after, 6 months after, sometimes 1 year after, and the late sinus sequestration can happen. This is very interesting paper. So, and the patient developed a new chest pain any symptom, any ischemia, and you consider is a late occurred sinus sequestration. So, and this is my final the summary slide. The sinus sequestration after TAVR procedure. This is particular matter in the valve-in-valve procedure. 2 valve frame following the valve-in-valve procedure introduce a specific recognition sinus sequestration, and the CT imaging and planning is essential to confirm the relationship stent frame, coronary ostium, sinus tubular junction, how to handle it, sinus sequestration in the valve-in-valve procedure. And the lower implantation is better to prevent the sinus sequestration, but we should balance and the leaflet overhang and the hemodynamics against the sinus flow. This is a trade-off. And also for such high-risk cases, we active prevention method considers like a differential leaflet modification approach, and like a Basilica and the Unicorn and the Shortcut we should consider. And also an AI-powered simulation software like a DASI simulation can facilitate the earlier expectation, and we are prepared some coronary rescue the technology, and the sinus sequestration is much well recognized nowadays because our experience is accumulated, and absolutely, especially in the valve-in-valve procedure, we should do sinus sequestration. This is a very typical symptom is late occurred in the 1 day, 2 days, sometimes a couple of months later, but we should recognize the concept and the rescue technology of a sinus sequestration, the event. Thank you for your attention.
Thank you, Dr. Park, for your excellent talk. So we have a few minutes for discussion. So sinus sequestration is during the TAVR procedure. I think it's a very dangerous phenomenon. And so how to prevent and how to recognize and how to manage, I think it's very important. So any comment or question from our experts?
Yes, thanks, Dr. Park, and a very excellent talk. And about the case one, you that very high risk sinus sequestration, and you have prepared well, but no more flow just post TAVI. So according to the outcome, do you review that maybe put the stent chimney post TAVI? Like the case one, and even the blood flow is
yeah. Sometimes in our hybrid room we have some very complex thinking such case, and if I met this case nowadays, we try to put the very active stenting. But there was a first case 7 years ago. We don't know. It's a concept sinus sequestration is absent. So at that moment, and I experienced such case. And the patient, during the procedure, patient vital status is okay. Transthoracic echo, there is no regional wall motion abnormality, and the patient's symptom occurred in the 5 and 6 hours later, and we do nighttime the emergency bypass surgery. At that case, I presented another the Korean interventional meetings. Nobody have a concept such like that. So but nowadays many experience such. One of the key findings is sinus sequestration is a very selective coronary angiography, sometimes very difficult, but we do very forceful angiography. Angiographic looks okay, but we don't know, we cannot exactly differentiate the death flow is physiologic okay, physiologic not okay. So if I do nowadays, we do very much active procedure using IBUS, sometimes FFR, and sometimes a more active procedure, and some suspicious coronary sinus sequestration, I will do much aggressive, chimney technique and another procedure.
So, Dr. Pop, what is the best predictor of sinus sequestration before the procedure on the CT scan?
Yeah.
STJ width or height or coronary height?
As shown in my first case, in the VT ST junction area less than 2, a very narrow sinus, and the valve-in-valve case. Also, and prior, the leaflet can cover the sinus axis. That is a most key point is anatomical expectation of a sinus sequestration.
One quick question. Excellent presentation indeed. Thank you so much. In case of you have not decided to place a stent, would you consider a little bit aggressive antithrombotic regimen? Because I've noticed some cases, because of the flow dynamic change, late thrombus formation played a role. So I don't have an answer, but you're an expert in antithrombotics.
Yeah, so it's one of the very interesting report is the first, and that was published in the European Heart Journal. Patient is during hospitalization, patient is okay, but they proposed the key mechanism of sinus sequestration, heart valve endocellularization. That was caused the sinus sequestration 6 months later. So they proposed some much aggressive antithrombotic like OSC or DAPT, but we have very limited data. But in such case, we do try to do much potent antiplatelet DAPT or OSC, but we have no large data. It's just that I think it is the ideal concept. Yeah.
Okay, thank you, Dr. Park, for your excellent talk. We have a question.
One last question. Have you ever seen several hours after a valve-in-valve, where there is coronary flow going down due to damage to the sinus valsalva itself, like a small dissection? The reason I'm asking is I did a valve-in-valve a couple of months ago, a short valve in a original long valve. It was a very good result, but 4.5 hours later, he had severe chest pain. When I took him back into the cath lab, the left main was absolutely being blocked off because of a small dissection arising from the bottom end. But luckily, because of the valve, it sort of stopped the dissection extending beyond, but there was intramural hematoma.
Yes.
So I had to put a stent immediately, and then the patient did well, and the subsequent multiple CT scan shows the intramural hematoma reducing. Has anyone seen anything like this?
Yeah, I didn't experience it after this case, but it's if patient having unexplained hemodynamic compromise, absolutely we do something. The imaging, CT, and the coronary angiography, and we absolutely suspicious of such phenomena. Yes.
Okay, thank you, Dr. Pop, for your excellent talk. But now we need to move back to the Zhongshan Hospital and to see the result. Hi, Professor Song.
Okay. Hey,
I'm Dr. Chao. Yeah, you finished the case?
Yes, because we only have 20 minutes, right,
yes.
for the last session. Yeah, and this is a mitral. So the mitral clip we deployed, I think it's good result. Then we go for the aortic. Let's go next. We have a really big sinus, not too big sinus, but we have really big annulus. The main diameter is 30.8 from the annulus level. From the LVOT level is 33. So we try to go through the big chase and, next. And go through the valve, and then adjust it, the locator into the sinus. Next. Okay, and then we double check, we have the left one, we have this a non-cusp one, and we check from the echo, we have the right sinus, and then we deploy. It's only 5 minutes, yeah. Now we finally check the position, and without piecing, we deploy. Next. And we check the final angio. This is the final angio. So there is a trivial leak.
Yeah.
Can we see the echo now?
主瓣的。
就现在所有二尖瓣主瓣的。And we go back to check, if there is like more mitral regurgitation, and we check the aortic regurgitation after the procedure. You can see the valve position is good, and there is no. I think it's only trivial PVL, and also from the mitral, it's also trivial. Let's see the mitral. Okay. Let's check. Now you can see there's only a tiny jet.
Yes.
Inside.
Yeah, very good.
So the blood pressure now is 116, 118, and 55. Before is like 90/28. Yeah. Okay. We finished. Yeah. Thank you.
Congratulations. Very excellent result. One stop for my MR and AR. And it was very good result. Congratulations. So we move back to the meeting. Yeah.
Thank you for the invitation.
Okay, so let's move on to our next speaker. We'd like to invite Professor Min-Ki Hong from Korea, and she will give us a talk about TAV in TAV.
Thank you for the introduction. I'm going to talking about the TAVR and the TAVR, my disclosure. My presentation includes the following content: and the expanding scope of a TAVR, limited durability of TAVR valve, and the clinical value and the challenge for the Redo-TAVR and the Redo-TAVR planning, and finally, my experience. As you know, the scope of the TAVR was expanded. It's well already know that the 7 years, 5 years clinical outcome is the non-inferior in the TAVR and compared to the SAVR patient from the partner 3 trial and the low risk trial. However, in the reality, what is the change? From the data from the TBT registry data, TAVR volume has been steadily increasing, especially in the young and the low risk patient. The TAVR, the guideline was changed 2021 in the European guideline. TAVR was recommended the patient age is more than 75, but the 2025, the guideline was changed, age is more than 70. However, nothing lasts forever. There has been a limited durability of the TAVR valve because bioprosthetic valve inevitably developed the dysfunction over time due to the valve itself or external factor. There are four mechanisms for the bioprosthetic valve dysfunction. Bioprosthetic valve deterioration is mainly wear and tear, and the non-structural valve dysfunction is the PPM and the probable leakage, and another thrombosis and the endocarditis. What is the incidence of the bioprosthetic valve dysfunction? At the 5-year follow-up is around the 5 to the 10%, and the 10-year follow-up in the NOTION trial, it was they reported in the 12 to the 5%. The incidence in the major trial of the incidence of the bioprosthetic valve failure was around 3% at the 5-year follow-up, 2.8% in the PARTNER 2A trial, and 3% in the PARTNER 3 trial, and 9.7% in the NOTION trial in the 10-year follow-up. Specifically, what is the 7-year reintervention rate from the PARTNER 3 trial? Overall, 6.7% in the SAPIEN valve in the 6%. But when you look at the more specifically, less than the 5-year, the reintervention rate was TAVR was 6.6, 2.6, lower than the surgery group. But between 5 to the 7 years, reintervention rate was 4%. It means the higher than the surgery group. The attenuation of the benefit was narrowed. What about the low-risk patient group in the 6 and the 7 years follow-up? Reintervention rate was the surgery 3.3% and in the surgery and 5.5% in evolute. At that time, the statistical significance does not achieved. However, in the 7 years follow-up, the rate of the reintervention was a surgery is 6%, 9.8% in the evolute group. What is the main etiology of the reintervention is mainly aortic regurgitation, not the aortic stenosis. That is data from the randomized clinical trial. What is the reality? It's a low-risk Medicare patient in the United States. Average is 2% at the 5-year follow. When we compare the clinical outcome between a Redo-TAVR and the surgery, surgical TAVR explant, the clinical outcome, the TAVR explant has the higher in-hospital 30-day, and even in the 1-year mortality is the higher compared to the Redo-TAVR group. When we compare the native TAVR versus Redo-TAVR, in this data, the percentage of the Redo-TAVR was the case Redo-TAVR was less than 1% in the anyhow is a small percentage, and the clinical outcome was a similar native valve Redo-TAVR and the native TAVR. What about the coronary compression or obstruction was 0.3% is a very lower. When we plan to the Redo-TAVR, the following key should be considered, and the procedural assessment, indexed TAVR design, planning, and the assessment of the coronary obstruction and the procedural consideration. There are 4 underlying mechanisms of bioprosthetic valve dysfunction: structural valve deterioration or non-structural valve dysfunction is a candidate for the Redo-TAVR. However, thrombosis and the endocarditis, it is not an indication for the Redo-TAVR. In this stage, we considered patient characteristics and the mechanism of the index TAVR failure and what type of the index TAVR valve. Next, we evaluate the index TAVR design, stent frame height, and the valve size, and the relationship with the index TAVR valve and the second valve. It means short in short, short in tall, tall in short, and the tall in tall. There are 4 types of it. Short in tall short is a typical cases for the SAPIEN is more than 26. Taurine short is the SAPIEN is less than 23 cases. And the taurine tall is not recommended in the current practice. And the shorting tall is the mainly in the evolute more than 26. And the planning or first step is to define the coronary risk factor CLP and then identify the NSP, Neo-Scott plane. And then we evaluate the risk of the coronary obstruction between the two factors. When the Neo-Scott plane is below the coronary risk plane, we don't worry about, not much worry about the obstruction of the coronary risk, just go ahead, TAVR procedure. However, Neo-Scott plane is above the coronary risk plane. We think about the risk of the coronary obstruction. Especially, we measure the valve to the aorta or valve to the coronary distance. When the distance is more than 4.0, we do not much worry about the coronary obstruction. However, it's less than 4.0, we worry about the coronary obstruction, especially that distance is less than 2, we worry about the coronary obstruction. Therefore, at that time, at that situation, we have to be the lipid modification and coronary protection or surgery. This is my cases patient is the 89 female patient. Actually, she underwent the self-expandable valve in the 29, 8 years ago, and degenerated the TAVR valve was developed. In the CT analysis, we did the leaflet height and the commissural orientation, especially the valve to the aorta distance and the valve to the coronary distance. It was measured 4.8 and 8.3. So fortunately, this is the risk of the coronary obstruction is quite low. We just go ahead this procedure with the ICE guidance, and the SAPIEN valve was deployed at the node 6. And when we, at the same time, we do the ICE and look at the SAPIEN valve is the circular expansion was observed. Ladies and gentlemen, I'd like to conclude that as the clinical indication for the TAVR has been broadening, especially in the younger and the low-risk patient. So, it is like to outlive the expected TAVR valve. And at the time, Redo-TAVR is an effective treatment option for the index TAVR failure. Finally, this expanding area require more accumulation of the clinical data. Thank you.
Thank you for your excellent talk. We have time for discussion. So I would like to ask Andrei and Carl, since you guys have extensive experience in this TAV and TAV and leaflet modification. So in your daily practice, what is your treatment algorithm for in patients who have significant risk for coronary access or flow after the TAV and TAV? Do you consider Basilica or Unicorn, or in US you have, I think, access to shortcuts. So in what kind of anatomy, what would you prefer?
So the answer is yes. We consider all of that, and I think that TAV in TAV is such a complex procedure with such unpredictable deployment that you have to prepare for every contingency. So we were talking earlier, you can talk all day about putting the valve at node 4 or putting the valve at node 6. You know where you start, you don't know where you're going to end. And so if your valve is going to land at node 6 and is going to occlude the coronaries, you have to be prepared for coronary occlusion. If the valve is going to land at node 4 and is going to embolize in the ventricle, you have to be prepared for ventricular embolization. So in my practice, if I feel that there is a coronary risk, I will do more than one thing to mitigate. So in the case that Dr. Park showed, where there was coronary obstruction with a surgical or in a surgical valve, we will do a Basilica or a Unicorn. but we will also protect the coronary and implant lower. I don't think we have enough data right now to say that Basilica is better or Unicorn is better or Shortcut is better. I think what we're seeing in the US is that Shortcut is extremely fast. So you can do 2 leaflet modification in less than 20 minutes, but it's $15,000. So we definitely are very worried about complications with these cases, and we try in every case to mitigate as much as we can.
Thanks, Andrei. I think you've answered and raised a lot of the points I was going to do, but I think the margin, the safety margin, we have to emphasize that. It's a little bit like doing mitral valve in ring. The anterior leaflet's dynamic, so it's unpredictable. And we've seen so many complications of Redo-TAVI, more than we anticipate in our proctoring and analysis of cases. So if you think it's close, don't take the chance, do leaflet modification. I think Redo-TAVI, we'll talk about it tomorrow, but Redo-TAVI leaflet modification will not work as well as native or surgical valves because you have a frame. The leaflet splay will not be as done as well, Shortcut or Basilica. So maybe there's more of a role for Unicorn, but we still have the ultimate problem if your valve is not commissure aligned. It may have to be explanted.
Great, great. Great discussion. Any other comments or questions? No? From the floor? Do you have any questions? Yeah, sure.
Yeah. So, I'm Young-Ko from Seoul, Korea. I have only limited experience of TAVI procedure, but you told us that it is unpredictable where to land, where the second valve will be, deployed. Actually, I don't understand. Is there a lot of movement because of movement during the deployment, or what is the reason? Could you explain a little bit more?
So the highest risk of embolization is with SAPIEN in Evolute, specifically SAPIEN in 29 and 34 Evolutes, 29, 31, and 34. So we've looked at several hundred cases of SAPIEN in Evolute. The only ventricular embolizations are in 29, 31, and 34 that fail by aortic insufficiency. And the reason for that is twofold. One is aortic insufficiency, you have absolutely no calcium, so there's nothing to anchor to. Second, because these are bigger valves, the coronaries are often at risk, so people try to implant lower. The risk of embolization is really low if you're landing at node 6. But if you're trying to land at node 5 or node 4, the risk of embolization is a lot higher. And that also explains why the risk is so much higher in 29, 31, and 34, because the difference between the inflow and the waste is maximal. So if you have, let's say you have a 34 millimeter valve, the waste on a 34 is 24 millimeters. So you would think that you put a 26 millimeter valve and it's going to anchor at node 6. On the other hand, if that valve moves during deployment and it lands a little bit lower, now all of a sudden you would need a 29 millimeter valve to anchor. So that's why we're seeing the embolization. So these are the cases where you have to be very deliberate about deployment. You have to be very slow about deployment. And the other thing that we've discovered is that actually it's more beneficial to not manipulate the delivery system, but rather to manipulate the wire. Because the moment you push or pull on the delivery system, the angle of the valve of the SAPIEN changes. And then you need a larger valve to anchor. When you push on the wire, the valve kind of rides on the wire. And with that, I also put a plug in. At New York Valves, we're going to release a consensus document on TAV in TAV. And we also have a lunch session that both of us are going to be on.
Just a quick point about the 29, 31, 34. I mean, these leaflets are very high, very supraannular. So as your balloon inflate, almost the entire apparatus is already below the leaflet. If you do node 4, that pushes the valve in. That's why the second operator, or maybe the first operator, inflation and push on the wire. Just push the entire time. Almost always it will go down and almost never goes up.
Thank you very much, Andrei. You said about 34 valve, and our experience has been, we learned from really a bad experience with the self-expanding 34, and we measure the second valve, and it is crucial to get the sizing right because we are worried about coronary occlusion, we are worried about wasting, and on a 34 valve, and sometimes we chose a 26 Sapien thinking that it'll be all right, and we had excellent position, but the moment we wanted to post-dilate it, that balloon went down and the valve was in the left ventricle. So, so one of the challenges is getting the right size too, you know, and how do you do that really?
So I think the challenge with that is that we know from benchtop models, from the work from Vancouver, that if you put a 29 millimeter Sapien in a 34, it will be underexpanded 100% of the time. The benchtop sizing, you know, 23 in 26, 26 in 29, 29 in 34, is guaranteed to yield underexpansion. Even in fresh valves. Once you're talking about degenerated valves, there's the paper from Stephanie Sellers that looked at Sapien in degenerated valves. The underexpansion is even more visible because you have the calcium in there. You don't worry so much about embolization when you have calcium, but you do worry about underexpansion. I think the challenge with the 34 is it depends very much on how it was implanted. Because if it was implanted in a route that's really constrained, then you can even put a 23 and it will stay there. But if it's implanted in an anatomy that's very large and the valve is very well expanded, or if the valve has been implanted very low, then the risk of embolization is a lot higher. And I think, you know, I'm aware of only one case in the literature that has been successfully managed percutaneously, where a Sapien was taken out of the ventricle percutaneously. Every other case, the only patients that survived were the people who were put emergently on ECMO or on cardiopulmonary bypass, and then the surgeons opened the ventricle. So I would say if you are hesitating between two sizes, you're probably better off ending up with an underexpanded valve than with an embolized valve. But again, it's, you know, again, from our work as proctors, it's very hard for us and it's very, you know, stressful because you don't know what the experience of the team is. You know, you have somebody who knows what they're doing, they can probably put a 23 in a 34 and make it stick. You have somebody who has never done it, you're going to end up either with the valve in the aorta or in the ventricle.
Thanks, Andrei. That was excellent, helpful tips and tricks. Okay, we have to move on. Thank you so much for your excellent talk. Now we would like to invite Professor Nathawood from Thailand. He will give us a talk regarding TAVR and complex high-risk CAD.
Thanks. Good afternoon, ladies and gentlemen. Let me get my laptop on. Okay. It's my pleasure to be here to give a talk on the TAVI with the complex high-risk CAD. So, can I have my slide up? Okay. So I think coronary artery disease concomitant with severe aortic stenosis is not that uncommon. I think you can see from here it can be ranged from 30 to 70%. And I think the complexity of the coronary artery disease also have impact on the 5 years of MACE. When you look in the patient with the highest complexity, defined by syntax score more than 22, and I think you can see that the year after TAVI, the MACE is rising up. Coronary have micro and macrovascular, and aortic stenosis will impact this macro and microvascular disease. When you try to use FFR, invasive physiology, I think they become less reliable when you have present of aortic stenosis. I think you can do that PCIs option before, after, or combine with the TAVI. They have some risk and benefit. If you do before, you can have the easier coronary access, but you have less labor of the FFR. But if you do after, you have more reliable, but you may have more challenging for coronary access. When you do combine, you may have use a lot of contrast and maybe make procedure more complexity. Patient anatomy and TAVI strategy will impact on the future access. You can see from here, if the patient anatomy is big, wide open, coronary height is high, I think you can put any valve, you can do whatever you want, and then you can still get access to coronary. But if the coronary is low, if the risk plane is lower than the coronary height, higher than coronary height, and the sinus is small, may have you have increased risk of sinus sequestration, and the device you use will be some impact. If you use balloon or cell expandable, because of the height of the cast will be depend on the device, and the depth of implantation. So I think when you put the valve, you have to think of this before you do, so you can get the future coronary access that possible. The study from re-access, you can see that if the patient anatomy, that TAVI relation to the sinus of valve ratio and implantation depth and type of the valve can be impact on the future access. When you do commercial alignment, you may have better, but it's not always guaranteed that you can have the access. Another interesting study from Caveat registry from Dr. Toratini. He looked at difference of the valve and look at the access, and you can change to look at the selective. You can do selective access. You can non-selective angiogram or unfeasible. And you can see using the short frame valve, you get more selective angiogram compared to tall frame. And between the tall frame, if you use the frame that have the open cell or have the new design, I think you get the more likely that you have the access to the coronary artery. So let's look at the evidence base. If we want to do the PCIs in the TAVI or TAVI in PCIs, which should be done first and what should be done afterward. This is activation trial. I've been look at the PCI before TAVI compared to defer. When you look at the 1 year, in terms of death and rehospitalization, actually is no difference if you defer or you do PCI before. But the price you have to pay, because the patient is ill, or when you put them on DAP and do the TAVI on the DAP, you may have more likely of the bleeding compared to the patient who defer. The Pro-TAVI, just recently published in Lancet this year, also have confirmed the same information. When you look at the primary analysis of the death, myocardial infarction, and major bleeding, it's no difference. But I think in the patient who have done the PCI before, compared to patients who defer for PCI, you have the less likely of bleeding who have the deferred PCI. Notion 3 have been looked at the patient undergoing TAVI and look at the PCIs. But this one actually is more look in the patient who have significant disease. What I mean significant, that is in the previous trials I didn't use the FFR, but this one you use the physiologic guide. If you have more than 50%, you have to prove by physiologic that have functional ischemia. Or if you have more than 90%, you can perform. And this one, you can see the curve is split up after 1 year. So in the patient who have significant disease, they may be okay at the first year, but the year after, you will have more likely to have myocardial infarction, you have more likely to urgent revascularization. So I think all these three study, randomized trial, probably we can say that PCI can be done, but can be waited. But if there's significant disease, you probably need to go back and do it. Let's look a little bit on the patient who have the complex anatomy. And what I combine by complex coronary intervention, you have the by patient demographic, like very old, have the EF is low, CKD, it's very typical for our TAVI patient. If you do the procedural factor like left main, 3-vessel disease, use medical support or use a rotabrator atherectomy. And this is all the complex. And you can see from this complex PCIs with TAVI, is about 3%. And when you look between the concomitant or staged PCIs, it appears that the MACE is maybe a little lower when you do staged PCI. The guideline consensus statement is recommend PCI should be performed only if you have significant left main proximal disease, only one variable disease, or acute coronary syndromes. And the timing should be based on patient presentation, patient anatomical characteristic. And PCIs, if you want to do after TAVI, I think you need to plan ahead with the commercial alignment, the TAVI platform. So I think I put out algorithm. What should I look at in the concomitant AS and complex CAD? When you look, you have to look, is both TAVI and PCI is feasible. If the factor is not feasible, let's say the patient is very young, have bicuspid and dilated aortic root, or maybe after complex of the PCI, maybe you should do bypass with SAVR. But if the coronary risk is higher than AS risk, let's say the patient come in with STEMI, acute coronary syndrome, critical left main, and difficult coronary access, I think PCI should be done first. There's some case example in our institution, very critical left main, and also critical of AS, but in this case, we have to do PCIs and then TAVI afterward. And if in default, I think based on the previous study have been done, I think default strategy in the most of the case, probably TAVI done first and then complex PCI afterward. Especially the patient who have a high AV gradient, high bleeding risk on depth. And I think if you want to do that, pre-procedure CT planning is very important for future coronary access. You need to look at the coronary height versus cast height, risk of sinus sequestration, so you can use appropriate TAVI platform and do commercial alignment if you use self-expandable. If you do perform in chip PCIs, let's say you have left main, you have calcified nodule, CKD, I think lesion preparation is very important. Invasive coronary physiology and imaging is also very important. As I mentioned in the previous slides, that syntax is important, but anatomical syntax is not always tell you. I think when you look anatomy, it may be complex, maybe high syntax, but may not be functional significant. So in our study, we just published about use the functional syntax is more change patient strategy. I think you can change from triple vessel to a 1 or 2 vessel disease, and I think it's better correlation with the patient outcome. Dr. Ribicini also have been published an interesting study using the FFR guide versus angiographic guide in the patient have PCI undergoing TAVI. And you can see from here, using FFR guide, you have less likely to have to do PCI on the patient. And then it's translate in the better outcome compared to angiographic guidance. And you can see in the subgroup who have the FFR borderline, I think you can do a remeasure of the FFR after, and then 32% we have significant FFR. This is 84 years old case who have CA breast, have symptomatic severe aortic stenosis, small annuli, have left main with calcified nodule, significant RCAs. So I think on this case, we because of small annuli, we use a self-expandable, but we do commercial alignment. And you can see that calcium nodule, in this case, we use the orbital atherectomy because we, in intravascular imaging, we found that the patient have calcified nodule. We have some published data before that when you have calcium nodule, if you want to look, use rotabrator, if you have constant eccentric calcium nodule, if the IVAS is sit on the nodule, you can probably abrade with the rotabrator. But if the IVAS is out from the calcium nodule like here, I think when you do put rotabrator alone, I think you might not get enough abrasion. So I think in this case, based on our study, because the IVAS is opposite, we do the orbital atherectomy to make sure. And this is the outcome of the procedures. So I think pre-procedure planning for the TAVI with commissural alignment is very important. This is another case with complex left main. Thanks to Dr. Xiaoling Chen, we developed the decay crush. I think when you use in imaging and physiology, I think you can do put the TAVI with the short frame device and then do the decay crush. And this patient have the low EF CKD, but we able to do this using about 13 cc of the contrast. We published this with Dr. Javier Escane, how to use the low contrast PCIs. I think you probably can learn this in JAK intervention. But basically, we should rely more on the imaging and physiology, not by just inject angiogram in this high-risk patient. My last case, quite interesting, that I give a case live to the TCT-AP, but I think that may be worth to show you what the strategy. This is 71 years old who have symptomatic severe aortic stenosis from syncope, low coronary height, and have significant right coronary artery, and also calcify of the LAD. Severe stenosis. I look at the CT, coronary height is low, about 6.4, but VTC is enough. It's about VTC is about 5.1. If we put this is 23 valve, like 100 to 0, I think you may cause some trouble, but we can put lower. But because of the high risk of sinus sequestration, as Dr. Park had been mentioned, we thought that we have to do basilica. But because of the complexity of the procedure, we have to advise the patient bypass aortic valve replacement, maybe first choice. But the patient strongly want to do a TAVI, and by the time we get finalized that we go for TAVI, not surgical aortic valve replacement, is a such time for life. So we usually when we do basilica, we like to do the PCI before. So I end up do the, because I did the balloon assist basilica to make sure that is enough clear under sinus sequestration. And you can see the leaflet on this case is very flimsy. And we have the balloon assist basilica. You can see we cut the leaflet, the TE guide and fluoroscopic guide. And I put that valve in, and the valve looks okay, but there's, even though we do balloon assist, there's still left main occlusion. We try to rescue, putting the stent, but stent was in left main is okay, it's not challenging, but the LVD have some calcium. So even though we open up the left main, I still have some struggling, cannot get so we have to do the cutting balloon and a little bit struggle, and then use the Geisler to get the stent and after preparation of the vessels of the calcium lesion. Eventually, the coronary is open and patient did well, but I think retrospective, I think in this high-risk case, I think we probably need to do PCI before. Thank you very much. And and I think this is my conclusion, and this is a summarize of the strategy PCI complex TAVI. Thank you very much.
Thank you, Nathan. Excellent talk. I was actually at the venue looking at your live. It was quite challenging. Okay, we're kind of, time's up, but any comments regarding the strategy, patients with severe CAD?
So I was really intrigued by your paper on the functional significance of the stenosis, because I think, we all know that if you have somebody with a mid-RCA 90% stenosis, by 1 year, it makes no difference whether you put a stent in or you medically manage, right? So we're reinventing the wheel in the TAVI space by looking at all patients as the same. And actually, I think last week in CCI, there was a paper from Europe that looked at burden of disease and showed that basically it makes sense to fix the coronaries if the burden of disease is high. So I think we kind of have to change our paradigm. I think a distal left main is something that maybe needs attention before.
Right,
Severe triple vessel disease needs attention before, especially with a bad LV. But an isolated mid RCA probably doesn't.
Yeah, I totally agree. I think there another study, complete study that have been published, completely vascularization or not complete, and actually in the intermediate risk of the STS undergoing TAVI, and it showed no difference. So I think I strongly agree with you. Not all coronary need to be fixed, and I think you need to balance. I think when you have very old patient, very high bleeding risk, put them on DAP, I think you might end up like bleeding and have the poor outcome.
Well, thank you so much, NTUH. We would like to move on.
So the last one is that, is it this one or this one? Dr. Varshan. So it was in Dr. Varshan to give us that TAVI in small sinus and small anatomy.
Thank you very much. Because of time, I'm going to speed through this. So thank you for the organizing committee of the Taipei Valve for inviting me. The small aortic annulus and small anatomy is probably one entity that has been underestimated, undermined in terms of its impact on our daily practice on TAVI. First of all, we don't have a unanimous consensus what defines small annulus. Some use bioprosthetic size, whether it's surgical or THV. Some use diameter by echo, some use perimeter, some use area. But the smaller it is, the more it becomes an issue, I think. And a single cutoff point may not be that useful. Because in the literature, you will see something like this, the smallest of the small. Very small, extra small, and tiny annulus has been all used in the publication, okay? But all of them show the same thing. It's kind of more prevalent in our Asian population, it's also in female. It's about 1/3 of patients who require either surgical AVR or TAVI. And it's associated with higher surgical risk, high clinical risk, lower body surface area, higher comorbidities, and also or it may be associated with small anatomy overall. Kind of everything is small. Narrow SOV, narrow STJ, low coronary height, and small vascular access. Now, and these increase immediate complication, namely cochlear occlusion and rupture, vascular complication, and longer term PPM. Now, in the surgical aortic valve replacement era, it was associated with severe PPM, prosthetic valve failure, and mortality. So what about in our TAVI era? There's a question whether it's increased risk of valve thrombosis, whether it's jeopardize the valve durabilities, and also it may limit the possibilities of Redo-TAVI that we'll see. So PPM and TAVI has been described and looked at from the TVT registry, that if you have severe PPM, your mortality increase. That's happening in about 12% of our TAVI practice. And the predictors for severe PPM is smaller valve size, valve in valve, female, and large body surface area. So all of us know about the SMART trial, so I'll go through it quickly. It used 430 cutoff as an area to enter the trial, randomized between supraannular self-expanding valve, Medtronic Evolut platform, versus balloon expandable valve, Edward Sapien. Now, it's the only TAVI trial that has female proportion of 87%. So most of TAVI RCT, you have 50-50 between female and male. So that's in itself saying that people with small annuli usually female, okay? And the mean diameter of the annulus mean area is 380. The co-primary endpoint has clinical and valve hemodynamic at 1 year. Clinical endpoints are not different, but bioprosthetic valve dysfunction favor self-expandable valve, 10 versus 40. 40 is not small. Now, if you look at the other hemodynamic outcome, whether it's mean gradient, EOA, hemodynamic structural valve dysfunction, which is a proportion of the HVD, and in female in particular, and moderate to severe PPM, they all favor self-expanding valve. And if only look at the severe PPM, it's 3 versus 10. So it's 30% versus 10%. And if you plot between the area and the BVD, the lower the area, especially in the balloon expandable arm, the more incidence of BVD you would see. Whereas in the self-expandable supraannular, the BVD is lower than the balloon expandable across valve area. And balloon expandable is also one predictor for BVD. Now, I will skip 2 years outcome, because now we have 3-year outcome that were presented last month during EuroPCR. Clinical outcome remain no different. Bioprosthetic valve dysfunctions remain different. And the proportion remained about the same, 16.3 versus 54.4. Okay. Now, the other thing that is worth looking at is endocarditis, somehow more common with a balloon expandable. And prosthetic valve thrombosis is also more prevalent in the balloon expandable. So if you look at the PPM, this is the incidence of PPM between the Evolute and the Sapient, 10 versus 33. And you look at the impact of moderate to severe PPM on mortality. The overall cohort, it increased mortality. If you look at the Evolute arm, the mortality difference is not significantly different. If you look at the Sapient arm, the moderate to severe PPM increased mortality significantly, both all-cause and cardiovascular mortality. These two graphs are the reflect of the top demonstration here. And as you can see, you have to wait a little longer to see the difference. And we are all anxious to know what would happen at 3 years, 7 years, or even 10 years, where the patient with small annulus would have a difference if we pick 2 different valve platforms. This is the key findings of the 3 years findings. BVD is half of the Sapient group and 16% in the Evolute group. 6 times more valve thrombosis with Sapient, and then 3 times more moderate and severe PPM in the Sapient group. Now, we also have our Asian version of the SMART trial, so to speak, but it's not a randomized control trial. It's a registry. The difference would be that the doctor select the valve that best fit the anatomy. The finding is kind of along the same line. The bioprosthetic valve dysfunction favor the Evolute group, but not as striking as when you were to randomize the patient without proper selection. Okay? Clinical outcome remain no different. And bioprosthetic valve failure through 5 years also not different. This is a longer term follow-up, but it's a registry. Now, a few weeks ago, this was published in JACC Asia by our Japanese friend from the OCEAN TAVI registry as well. 7 years outcome of the women who underwent TAVI. Now, this is not small annulus, looking at the small annulus, looking at female, but somehow this cohort also has a small annuli. Now, patient who in the balloon expandable group has a larger annulus than the self-expandable group. That makes sense because the doctors probably would choose it that way. If you look at the perimeter, it's drastically different. LVOT calcification also different, but they do the propensity score matching. So when they adjusted it, the differences no longer exist. Okay, so this is much smaller than the SMART trial, very small. And then they end up with truly a small prosthetic size. 20, 23 for the balloon expandable, and 23 and 26 for the balloon for the self-expanding valve. And here's the outcome. And this is a longer-term follow-up, 7 years. PVL, although it's worse with self-expanding initially, it's gradually come down over time. And we kind of see this phenomenon as the nitinol frame somehow may expand a little bit after we implanted it. EOA is larger with self-expanding. Mean gradient is lower with self-expanding. Now, the clinical outcome somehow shows some different in a very small annulus, both all-cause mortality and also stroke, statistically significant, but not for heart failure hospitalization. So we begin to see some difference with a longer-term follow-up and with a very small annulus. So something to think about. So I'll show you some case example. This is a 75-year-old female with rheumatic AS. Her annulus perimeter is 55. Area is 233, 234. This is the smallest one I've encountered. Luckily, her SOV is big enough. Her chore height, although borderline, but not too bad. And she has no calcium because it's rheumatic. And she's small. If you look at the chart here, it's smaller than any recommended size for both Sapien and Evolute. But we just have to use one. She declined surgery. So we put the FX23 in without post-dilatation, good outcome, mean gradient of 6. So this is a straightforward small annulus. Next case, a different issue. 78-year-old female with coronary disease. She was turned down because of her porcelain aorta. She's also a small lady, severe AS. If you look at the annulus, this is slightly bigger than the first patient, 266. Okay, perimeter of 58. So this would fit Evolute 23 according to the IFU, but too small for the Sapien 20 according to the IFU. But if you look at the SOA width, this is kind of scary to put a 23 Evolute. And the STJ is also similar size as the annulus, not any bigger. And it's almost circumferentially calcified. The STJ height, 15 on one side, 13 on the other side, and left coronary height is low. So the STJ width, the SOE width become a problem for the self-expanding. And the STJ height and also size can create a problem if we choose balloon expanding because of the balloon height. And also if you put the valve too high, it can crack the STJ because the valve size would be 20. Anyhow, we pick balloon expanding, underfill it a little bit, and then mount it towards, as you can see, towards the aortic side, and then do a double tap and do coronary protection. And even after the double tap, initially looked fine, then she become hypotensive. So we have to pull back the stent that we left it in the LAD and stent the left main with some protrusion, and then everything went fine. This is transvalvular AR. So sometimes valve selection, it depends on the anatomy, not just the annulus size. Last patient, quickly. This patient, 81 now, at age of 74, 7 years ago, she had an Evolute R number 23 put in for severe aortic stenosis and also a pacemaker. At the end, mean gradient was 6. She was turned out from surgery because of porcelain aorta from previous radiation. And then she lost follow-up for 5 years. No echo was done. And then she showed up at the end of last year with heart failure, and her gradient increased from 6 to 54. Okay, and this is her CT 7 years ago, also small annulus, but large enough SOV. But her STJ is also circumferential calcified and very small, smaller than the annulus. So with the Evolut 23, this is how it looked. It looked quite okay, somewhat constrained in the LAO protection, but on the RAO, even after post-dilatation, it still looked underexpanded. But we didn't want to use bigger than 18 millimeter balloon because the STJ is 18. Okay, mean gradient was good. So now CT now, if you this is through every node, the average in the diameter is 18. Okay, even though we put 23. The valve to Cori and valve to STJ is very, very short. Luckily, her right Cori is non-dominant because the valve to right Cori distance is 0.5 mm. But valve to left Cori is about 2 mm. And then the Cori wrist plane is about node 5. So neo-skirt plane, we aim at node 5. And if you look at this injection, you can see the limitation of CT scan. There's some blooming artifact, and it's very difficult to draw the line where the margin is. But if you look at this, you probably could put a sapien here at this level, which is around node 5. And it looked like you have a clear distance from also the level between from the left main. This is the sapien 20. And as we discussed earlier in the TAV, it has to go very slow because it can move. And one wrong move, you'll end up with the undesirable position as you initially planned. We flared the inflow. Then it looked okay on the LAO, looked not as okay on the RAO again. So we post-dilate with a balloon, but still afraid to use bigger than 18 millimeter balloon because of the small STJ. This is how it looked at the end. No complication, no leak, the gradient down to 7. So small annulus can pose the problem for Redo-TAVI as well, become more difficult to plan and to do, I think. So my conclusion. So small aortic annulus and a small anatomy is more prevalent in our population and in women. It's still the entity that create both post-short-term and potentially long-term adverse outcome. Valve selection between balloon expandable or self-expandable has become one big debatable issue these days. So although supraannular self-expanding valve result in a superior hemodynamic outcome and significant lower BVD when compared with balloon expandable, the difference of heart outcome out up to 3 years in the randomized control trial, naming the SMART trial, still cannot be demonstrated. So not only valve selection, but valve position, deployment strategy based on careful anatomical assessment in patients with small annulus help avoiding inherited complications and potentially harm of the inferior hemodynamic effects on durability, and the difficulty and the result of Redo-TAVI in the future require longer term follow-up. Thank you very much.
Thank you, Dr. Pop. So give us a very nice talk, and because in this very special patient subjects, everything is small, including the aorta loop and a vascular, peripheral vascular, and everything is small. So it's very, for this patient subjects, it's very difficult to make a decision. So just now, Dr. Pop gave us a very nice presentation, and also that a couple case. This is a very typical case. So any comment, because the time is so limited, we don't too much time, so we just have comment or question.
So beautiful cases, and I think that you're right. Small annuli go with small anatomy, small roots, and we do have data that Redo-TAVR in that anatomy is a lot more difficult. So Vinny Bapat published, Kendra Grubb published this, and I think the only technical point that I would make, I don't know if this is available here, but I really like using the 20 millimeter, the Atlas Gold. They make a 2 centimeter long balloon rather than a 4 centimeter long. So that allows you to stay away from the sinotubular junction. So yeah, it's a really nice balloon for post-dilation.
So thank you very much. So we go final. Yeah, Dr. D will give us my most memorial TAVR case.
Thank you. Thank you for the kind invitation again. I come here every year, Dr. Yin. Thank you for the invitation. After all these didactic lectures, I thought I want to share with you one of my memorable cases. Some of you might actually have heard about this, but I still want to tap on your wisdom how I should have managed this patient better. These are my disclosures. So very quickly go to our case, 85 years old female, stage 3 CKD, hypertension, diabetic, and repeatedly admitted for progressive heart failure, and with elevated troponin, BNP, and echo, show a preserved ejection fraction but severe aortic stenosis, mild aortic regurgitation, and minor CAD only. So at that time, we calculated the score, and he was classified as prohibitive risk for surgical AVR because of the age and this frailty score, and we proceed to TAVI. So on CT analysis, you can see the area was 354. And these are the parameters you can see, not particularly too calcified, although still, I would say moderately calcified. Then the coronary height, the left coronary height was 9.8, not particularly short, but if you consider the left cup's leaflet length of 11.9, then we thought that the risk of coronary obstruction actually would be quite high for this particular case. So we discussed among our heart team what we want to do. If we want just to protect with stenting, with a stent, just do a chimney stent at the end, basilica, something else. Remember, this is a native valve, not a bioprosthetic valve. So this is the concept of basilica, I think all of you know. So we actually chose to go for a basilica procedure of the left coronary cups, native cups, and then implant S323 with minus 1 cc. So these are the preparations that we will have for this basilica, and then followed by sapient implantation. And these are the preparations of the basilica procedure. I won't bother you with the details, just that we have to cross with a stato wire, electrified, cut, and then we have to actually have different operators to do different things at the same time, pull, flush, and burn. And under TEE guidance, we can actually see the leaflets being split adequately. You can see the calcium as well. And then, of course, you end up with quite significant aortic regurgitation, and we quickly put in the sapien that we have planned to use, 23 sapien minus 1 cc. Was deployed actually without much difficulty. But this is not the main issue. So the basilica was done, the sapien was implanted, and then the patient suddenly have a significant drop in blood pressure. So I think with good eyes, you can actually notice some contrast here. We immediately do an echo which show significant pericardial effusion with tympani. Of course, we went ahead and do pericardiocentesis, all the other aspiration, and then set up autotransfusion. We reversed the heparin, actually, we can discuss this. And then we notice a very rapid recollection of blood in the pericardial space. What to do now? Of course, we can call our surgeon. We can have other things that we can do. We actually did call our surgeon, 85 years old, remember, turned down by the surgeon. And then this was the reply from our surgeon. 85 years old lady, too frail. We actually have considered this to be an inoperable case, and then we have another surgery going on. Please go ahead, manage yourself, and good luck. So what should we do? Rupture annulus after basilica, and then I think it's not really related to the basilica procedure. It's just the calcified annulus that we are facing with. So we quickly engage the left main, and then with the 6 French AO1 guiding catheter, actually we put this into the left coronary cups. I don't know whether you will agree with us. We start actually putting in coils just to see if we can seal this off. And then we start with the first coil, because we have no option at all at that time. The surgeons refused to operate. I can tell you there's a lot of space there that you need a lot of coils. So we keep putting in coils after coil, coil after coil, and then end up with 9 cook coils and 3 target coils being deployed at the left cups. But at the same time, of course, we have to keep an eye on the left main because it's very close to the left main. Just make sure it's not, so we keep a guiding catheter there so that it would not actually occlude the left main. And we check and check at the end of the procedure. We actually can see from here that we managed to actually seal off the rupture of the annulus with this, I would say altogether 12 coils being deployed here. And then this was the final angiogram. The left main was preserved, but you can see a lot of coils. But actually, this was the TEE. You see coils outside the stent frame of the S3. And then the patient was managed to be transferred back to our CCU with not much strain output. Surprisingly, the post-op TEE still have preserved TTE, still have preserved LV ejection fraction with well functioning of the TAVI device. The patient was managed to wean off the ventilator, and then we actually perform a CT on day 4. Just look at what has happened, and the coils are actually pretty well situated at the left coronary cups, as you can see here. Well, this was our first case, and surprisingly, the patient recovers quite well. So just a brief summary of our case. We can actually do basilica with a low coronary artery and long leaflet to a native valve, especially for those inoperable patients, although the technique, the procedure was developed to cut the bioprosthetic valve. It might be more difficult to navigate towards the cutting edge of the native valves during a basilica for native valves because there's lack of the surgical valve landmark, and often there will be more calcium deposition. So these are the things that we need to bear in mind. And then when I would say maybe it's not really the very frank perforation, but if there's a sinus rupture, a mild sinus rupture, we need to think of the plugs, the coils, and we have to be familiar with coils, and we have to stock some coils in your lab just in case you come across this case. Auto transfusion actually is very useful in this particular case. And when you come to this non-surgical patients, surgically no option patients, then you always need to innovate so that we can save more lives. Thank you for your attention.
Thank you for your case.
Thank you.
very tough and very nightmare.
I don't know whether you have other options available to treat this, Andrew.
So I just first,
sorry.
maybe first question: how do you identify the rupture side? Because it's just put coil inside.
You can see the contrast actually coming out from the left coronary cups when you do the aortogram.
Okay.
I've shown the aortogram before. We just suspect there and then start putting coils in because we have no other options.
Okay.
So two things. I think 2020 hindsight, maybe a 20 millimeter valve would have been better with some additional volume. I did a similar case where we had a perforation of the sinus of Valsalva and we coiled it successfully. The other thing that has been talked a lot about in the US, and I actually tried it on a few cases recently and it worked well, is injecting flow seal in the pericardium. So basically, if the bleeding doesn't stop, you upgrade your sheath, your pericardial drain to a big thoracic drain, what the surgeons use for draining the pleural effusions. So they have a 14 French pigtail, essentially. You put that in the pericardium and then you make a bunch of flow seal or Surgi-Seal, which is basically foam. And you inject 3, 5, 6, how many amps it takes. And surprisingly, the bleeding stops. Some surgeons argue that it shouldn't work, but it seems to work.
But in the long run, it's okay.
Yeah, I mean, it's a flow seal. All there is, it's basically a thrombin matrix. So somehow it works.
I mean, the concern with any thrombin injection is that, you are limiting your options. As you start that process, you have no option, right? If it's still bleeding, so...
Oh, the surgeons can open them up.
Yeah, well, that will be the last option.
Yeah.
But if your surgeon's busy, then it's not an
busy and they are not really interested to do the case.
So, any questions? Any more questions? Okay.
Yes.
Thank you for an excellent case. So if you have a vascular plug AVP4, would you perform the plug first, then do the coiling additionally, if you have?
I don't know. I don't think the plug will actually seal off the perforation. I have not tried the plug. So we actually did a little more cases, several cases more with the coils afterwards when we encountered this mild perforation. But we have never tried the plug. I don't know. Anyone tried the plug? I don't really think it will work. But yeah.
So if you are using the coil, you have to use the guiding case to engage the left coronary first to prevent the coil.
Yes, so we have JL4 at the left main and then AL1 at the left coronary cups to put in the coil. So we just don't want the coil to go into the left main.
I think the AVP4 will be too porous. I mean, unlike an AVP2 where there's fabric, AVP4 is so porous, may not work.
I have some experience with use the plug. I think, but it's like the late fistula in the patient with the bicuspid and calcium score like 10,000. And then I think 4 weeks after have the murmur and then have the sinus to right atrium. But then we know it before and then so it's more like elective case and then we put the AVP plug. It's working very well when it's close the fistula. But for the coil, I think on your case are very nice. And I just wondering that is it possible when you put the coil, it can be interact with the leaflet and how you identify and how you prevent, or if the coil you have to make sure it's
behind
outside
the frame.
behind the frame.
It's behind the frame,
Okay.
and in between.
In between. Okay.
The SOV and the sinus and the frame.
Right. Okay.
But it's a lot of space.
I know.
So you have to put in a lot
Put a
in
lot.
order not to
And then you have
have
to
any
protect
more
left main
perforation.
to make sure it's no obstruction. Okay.
We have experience
Very nice case.
using
Very
the plug
challenging.
for PVL, for fistula, but I don't know whether it will seal off perforation.
Okay.
Yeah.
But I think the other thing is that, obviously you've put a lot of coils in, and I don't think this is the first case where you want to use coils, because one of the images that you had was the coil was deploying and it was going away from the pocket, and you
Yes.
pulled it back. So I think there's a lot of subtlety to using coils, and you're better off learning to do coils somewhere else, not in an emergency situation.
Good tips. Thank you.
Well, I'm Jian from the National Taiwan University. First, congratulations for the major for the challenging cases. We have an opportunity to emergently open the annular for repair the annular rupture. The rupture can be complicated, but maybe between two sinus. When we open it, every cases are different. So certainly, I would say it's very unique to have a single rupture in the left side coronary, but possibly is not can fit every cases, because sometimes if the complete rupture between commissural earth is not probably you cannot repair with that cases.
So this is, I think it's because of one sharp calcium perforating up.
Yeah. You can especially understand the calcium nodule. Where is the calcium nodule?
Would you operate on this?
Yes,
55 years old?
we do. We did. We have opportunity to open a few cases for annular rupture.
Okay.
But yes, yeah,
All
we
right.
do.
Thank you.
Okay, so thank you very much for your cases. So go back to Dr. Chia to give us a close remark.
No, thank you. This is a session for the coronary access during the TAVR and the VIV. I think all the presentations are very unique and give us very important information. And so I think we learned a lot from this section. So we close this section. So I would like to invite the professor in to chair the next section. Thank you. Let's proceed to this session. This session is that there are several keynote speakers are going to give their lectures. The first one will be let me introduce our moderators,
Dr. Jian is a co-moderator, and we have a panelist, including Dr. Yin Weixian, Dr. Hong Miao-Ki, and So Kent, and let me see, Hachinosi, and Dr. Li Wenlin, Dr. Niyang Wang, and Dr. Wang Bin. The first lecture will be given by Dr. Lam Yan Yin, and that will be the online, right? Online presentation. Pre-recorded, yeah. So the topic will be, that's virtual, yeah, lecture. And the topic will be severe tricuspid regurgitation, repair or replacement.
大家好，我是香港林义贤，谢谢大卫的邀请，但是很抱歉这次因为在法兰克福开会，就不能来到台北亲自跟你们见面今天我讲的课题是三尖瓣反流的介入治疗，究竟应该是修复这个技术好，还是说置换瓣膜置换？那要聊这个课题呢，我们就是从香港我现在有的一些器械说起吧。在香港修复的器械总体呢有2款，一款呢就是一个半环缩环的一个技术叫 K-clip， 另外一种呢就是圆对圆的介入治疗包括了以 Tri-clip 为主的一些器械。另外呢，置换来说呢，当然香港地区现在只有 Lux Valve 精井的一款 Lux Valve 的置换 ，Trick Valve 也有，但是我觉得今天的课题可能我们就围绕住 K-clip、Tear， 还有就是一个 Lux Valve 置换我自己使用的一些经验，然后呢给大家做一个初步的结论。那觉得最主要还是我们每个技术的特点说一下，然后最后呢可能给一个小小的结论吧。首先我们就介绍一下 annuloplasty。那我们现在用到了这款，在国内因为它是唯一上市的一款产品呢 K-clip， 它主要呢是精井18 French 去夹半环的一个介入手段。一开始的时候它是模仿外科的 K 在后半呢将这个半环夹起来，但随着临床经验增加，我们觉得其实用这个器械它更像是一个环缩的一个机械，所以我给它改了一个名字，叫 Transcatheter 的 Semi-Devagar， 其实就是像这个图一样的，可能一开始呢我们是在后隔这个地方呢下一个夹子，将它缩环缩小，然后呢如果效果不是很明显呢，我们就在前后这个地方再下另外一个夹子。那一般现在 default strategy大部分的病人呢都是需要起码2个夹子，有时候甚至用到3个夹子。那它的优势就是如果反流是在后隔地区为主的话，那这个治疗效果就会非常好。那这个是他在国内注册研究，你看到了大部分的病人呢去到1年随访的时候呢，80%的病人呢还是相对来说呢这个反流还是中度以下的，所以基本上跟这个 Tri-clip Tear 是差不多。那它主要一个特点，因为环缩是比较接近关脉，所以做这个手术的时候呢是要一个关脉的一个评估透过 CT 的评估，看看呢这个距离如果太近的话，有可能在夹的过程之中会对关脉造成一定的影响。那这个就是我说的 Semi-Devagar 的这个方法了。第一个夹子呢，我一般呢就是放在了后隔的 annulus， 第二个夹子呢就放在前后的 annulus， 这样子呢就会达到一个比较理想的一个结果。那这个是 the best case。你看到这个病人呢本来是 torrential TR 的， 它的环缩呢，从面积197一下子下了2个夹子呢，去到76个平均厘米。然后你也可以看到了，它这个反流呢，从 torrential 去到了 mild moderate。但是它也有它的问题，就像我刚才说的，像这个病人呢，我试了不同的位置，因为这个管脉太接近这个半环，无论你怎么换的位置都好，你没办法去夹后隔这个位置，那只可以将2个夹子呢稍微往前后去挪啊。结果呢，这个病人你看到了啊，他的超声呢，你看到了，他夹完2个之后呢，几乎呢这个反流呢没有明显的改善。为什么？其实你从食道超声来看，你也很清楚看到了，它在后隔的地方有一个很大的缝隙，但是那个地方正好就是关脉所在啊，所以没办法。尽管我们下了2个夹子，那个地方反流还是非常重。那说完这个之后呢，我们就说一下这个 TAVI 技术吧。TAVI 来说呢，它主要的研究是来自于美国这个上市前的研究 Trilogy 350个病人1对1的研究。我们也知道了，它1年的结果呢，大部分87% 的病人呢可以达到中度的这个反流啊，然后呢主要呢就来自于这个症状的改善啊。但是它有这个问题，它虽然说术中很安全，但是这个 SLDA 就是单边脱落发生率还是有7%左右啊。这个呢是我们今年在JenaValve 发表了，包括台湾地区也贡献了一些病人啊，就是早期我们做 TriClip 在3间半的经验，我们发现呢，亚洲人群呢，这个我们做的结果也是差不多，就是80%左右可以达到中度，降到中度的反流。然后呢，我们在亚洲地区，其中一个特色就是比较多 combined procedure， 可能我们大部分病人都是房颤引起的2、3间半反流，所以混合在一起做的特别多啊。然后这个 SLDA 的脱落这个单边夹持还是有4.7% 啊。这里面呢，我们看了一下，比如说我们 TriClip Asia 达到中度以下的反流呢，我们有75%。我们也看了一下这个技术呢，毕竟它是需要有一定的经验，所以呢，你发现如果结果是好的，可以预测它这个结果是可以增加这个手术成功率，降到中度以下呢，发现前1/3跟后1/3是有明显的差别，就是说如果这个术者的经验增加，他后来呢他会手术治疗效果就会非常好。我觉得这个是一个很重要的一个 message， 就是我们去做这个手术的时候呢，如果这个术者呢有经验或者有经验的术者去带教，可能手术的效果呢就会比较好一些。那我们从这个 glide score 呢也会知道了，其实这个3间半的前夹呢，它对解剖结构的要求，这里呢就是一个计分系统，你看到了这一些。除了这个红线它有2个，一个是解剖结构，包括了它这个 gap 是不是大，反流的区域，下面腱索的分布还有就是这个瓣叶是什么形态是不是多瓣这个其实会影响你是不是有可能将这个 TR 降到 Grade 2或以下另外一个呢，我也 highlight 了，就是食道超声的影像质量也会影响你手术的效果。当然这个 glide score里面没有，就是我觉得 glide score 就是这个蓝线里面包含的东西，就是这个瓣叶的形态，食道超声的条件。但是在临床上，我觉得 TT 另外一个很重要需要考量的就是有没有起搏导线干预了这个3间半介入治疗，还有就是一些右心跟肺动脉的环境条件也会影响你术中呢这个最后是否成功或者长远的效果，这些都是必须要考量的。 那这个 TEER 的 default strategy 是这样的，第一就是它第一个夹呢，一般来说呢就是会夹在前格，然后呢，因为大部分的反流是来自于中央区域往前格这个区域延伸的啊，如果呢效果不好呢，你还可以加第二个夹子，有时候呢前格可能要下2、3个夹子啊。在下 cover technique 就是下第二个夹子，如果是后格要夹的话，就要特别留意，不要将前后交界这个缝隙扯开了，这样子呢可能就得不偿失。那但是我必须要说一点，就是在我们亚洲人群当中呢，其实很多都是 HO-FTR， 所以这些病人呢，其实对置换来说，为什么有时候担心？就置换你要长期抗凝，在这个前夹的病人当中，其实你是可以同期的做左线封堵，然后呢，这些病人长远呢就不用吃抗凝药。那最好的 case 呢，其实就是一些我们现在随着经验增加，就是一些病人他这个经胃的食道超声影像非常好，你可以甚至透过这个影像呢做一个 multi-view 的重建，它在这个 view 上面呢，你可以同时的去定位 positioning、orientation 这个夹子的中向、调中向，还有同时可以前夹啊，这个是经胃底最有用的，我觉得非常重要的。一个为什么在三尖瓣前夹当中不可缺的一个图像。然后呢，如果像这个病人夹完一个之后呢，手术效果不是很好的话呢，那你其实是可以用 cover technique 再加一个夹子啊，去让这个反流更好。这也是它对 K 有可能的一个好处，因为 K 主要是处理后格的反流。如果是做 TEER 的话，它其实是可以前格，然后后格都可以下夹子，它可能有这个优势。但是当然也是要看术中食道超声的影像，然后呢也要看它后格下面是否有很多腱索会挡住你去操作。那同时呢，这个病人呢也像我们说的，就是因为是一个老年人家，做完2个夹子反流减少之后呢，我们也可以同时的去做左线封堵。那我们其实在这个左线封堵这个经验呢，我们也那这个呢就是为什么有时候做三尖瓣前夹最痛苦的就是这个 T-TEER 的时候呢，有各种的原因导致呢你没办法食道超声很清楚的看到这些瓣叶。那现在有了 3D-ICE 其实也会帮助我们一些，刚才说到了 T-TEER 的一个痛点就是 SLDA 发生率还是4到7% 嘛，有了 3D-ICE 的辅助之后呢，我们其实呢就可以更 sure 的可以看到瓣叶抓捕的过程啊，像这个病人呢，这个瓣叶夹起来呢，你就可以看得很清楚，瓣叶活动程度下降，然后2个瓣叶都是伸进夹子里面，这确实是一个改进，但是呢价格相对就会昂贵一些，不能常用但是很困难的一些病人下了这个就会简化手术。那我怎么样也说一下 TTVR。 那 TTVR 有几个情况呢，大家都公认了，就是像这个病人啊，他的 gap 超大，然后呢他的瓣叶栓隙也非常大，几乎你去做前夹是没有什么希望的，那 TTVR 呢就是一个选择。那我们在香港地区的 TTVR 呢，有的就是这个 Luxvalve 现在来说呢，它的 CE 研究已经做完了，我们就等CE 获批。那估计 CE 获批之后呢，在亚太地区就可以广泛的使用哈。它是一个34 French 的桥然后它一个好处比 Evoke 我觉得就是在我们来说，有些病人呢 来看我们的时候已经很晚期，这个瓣环扩得非常大。如果是55毫米以上的，现在 Evoke 呢是很难去治理的哈，所以呢 Lux 呢是可以去到60几的瓣环哈，我们还是可以用去做这个系统呢本身操作来说呢，相对来说还是比较简单的，虽然它有一些学习曲线，但是它的学习曲线相对 TEER 来说呢就会少很多。它对10道超声的依赖呢也相对会少一些这个就是这个瓣膜在释放的过程之中还可以进行一些微调让你呢减少这个瓣中漏。那这个呢就是刚才那个病人呢做完手术放了一个 Lux valve 的时候呢，你看到了这个反流几乎就是完全没有了。另外一个情况，我们觉得可能 TTVR 会比较合适，就像这个病人是一个老年的女性，她是一个 CIED causative TR， 就是一个起搏导线，有时候起搏导线它是粘在这个瓣叶，甚至干扰了瓣下的那些 Cody， 你是很难呢去做 TEER 达到很好的一个效果那做 Lux 就非常好。我们呢也在这个 Global 的 Compassionate Registry 也看了一下，就是做有起搏导线跟没起搏导线的病人比较了一下，其实它的治疗效果去到30天其实是一样的。但起搏导线如果你放一个 TTVR， 它还是有一些问题，就是它可能导致这个导线的 performance 稍微差了一点点，虽然说不用立马去换这个电线，但是它的寿命长远来说肯定是有一些影响。然后也有一些病人像这个 registry 里面所提到的，如果他的这个电线呢刚好呢就是像这个病人呢就是这个电线刚好就是阻止了这个瓣叶框架贴靠这个瓣环，导致瓣周漏。但是你也可以放一个封堵器像血管塞也可以解决这个问题。那有第3个病人，我觉得 TTVR 有特别的好处，它是可以救台的。像这个 case Cancel 做的一个 case， 就是他是之前做过 TEER， 前格呢就是 SLDA， 你不允许呢再有空间去加第2、第3个夹子，那你是可以呢透过这个 TTVR 去解决这个问题。你看到这个病人本来这个夹子是跳得很厉害的，到最后呢就很成功的就放了一个 Lux valve， 很成功的就是将反流完全干掉。但是呢三尖瓣置换最大的一个问题就是它相对来说呢跟 TEER 来说，为什么人家觉得相对来说可能术中不良事件就是为术期的这个不良事件相对高一些，就是因为我们知道三尖瓣反流如果解决了之后，所有的血流往前走，如果你的肺动脉高压或者右心功能不好，那如果你三尖瓣前夹之后留着一些反流，它还有一个机会排气，但是你将反流完全干掉，它可能这个右心就一下子就受不了了。我们看了一下你看这个 Trilumin 的研究跟 Trisend 研究，你看到特别是 procedural mortality 30天有 3.4% 在 Transcend 这个置换 Evoke 这个三尖瓣系统当中是发现的。那最近呢我们自己看了一下 Lux valve Plus 的全球的 Global Registry， 这个 inpatient death 还是有 5.3%。那最近呢在 JACC Intervention 呢也发表了一个，因为越来越多人看一下这个叫 Acute Hemodynamic Instability AHI， 就是放完这个瓣膜之后这个病人呢发生这个心源性休克的情况不说在这个调查当中呢有去到 8.5%， 还是相对不低100% 就是术后24小时造成的。然后呢 inpatient mortality 可以去到35%。那他看了一下预测的因子，包括了肾功能不全、左心功能不好，还有呢就是右心后负荷这个 TAVI 跟肺动脉高压这个uncoupling， 这个呢都是一些预测因子。我觉得可能有一些病人可能左心功能不好，然后突然这个容积增加了，他受不了；也有些人就是肺动脉高压右心功能不好，他也有受不了。然后如果肾功能不全，他可能对调节水分相对差一些，这些可能都会引起问题。我觉得这个问题将来随着数据越来越多，肯定会越多人呢去关注这个点。那怎么选择呢？说完这3个，我经常的用这个4个 A 去看这个问题啊。比如说你的中心没有这个 availability 没有，那当然是 tier 的做的中心相对多一些。然后另外一个 anatomy 就是刚才说的，像这个 CRED 啊，或者这个 gap 比较大啊 ，SLDA post tier 这个可能倾向于 replacement。但是呢，现在来说你也要想它的 anticoagulation 或者 afterload 这些问题，可能你又偏向于 repair。所以还是可能要针对不同的病人选不同的器械。那具体来说呢，其实我们看一下真实世界的数据吧，因为真实世界数据也不多。第一个 Asia Pacific non-randomized comparative study 呢，就是有 Cheng 就是威尔士亲王医院，然后我也参与当中啊。我们这里面呢有136个病人做了 T-tier。38个做了置换，那我们比较了一下，你就会发现做 T-tier 的病人呢，其实呢这个反流减少，当然没有 TT 就置换那么好，但是你发现我们自己已经选了，如果这个病人的 TL 严重程度很多，这个 gap 很大 ，ELOA 特别大，那几乎就是选择了 TTVR， 但是也证实你看到了30天的inpatient MACE。TTVR 可以去到15.8%，所以这个就是选择病人，然后你要估计用了这个策略之后，那长远来说是怎么样呢？这个其实我们也有一部分参与的，这个是第一个 International Multicenter Propensity Match Analysis， 它这个数据呢已经进行了投稿了。它是来自于3个 registry， 就是 Euro-TR registry、Travel to registry， 还有 Compassionate Use 的 LOX-valve。那它最后呢就是经过 PSM matching 之后呢，94个 T-tier 的病人，94个置换的病人。最后我们看一下那个结果，1年的死亡率、再住院率、心衰，你会发现呢，在这个里面呢，长远来说好像置换好一些，但是再仔细看了一下。如果你是 T-tier 手术做得非常好，就是将这个 TL grade 降到1个 grade 以下，其实2个是相差不大的。当然呢，安全性呢 TTVR 相对会就是差一些。所以我又回到了原本这个问题的根本，就是可能我们今天说的这个是一个伪命题。其实无论你用哪一个手段好，你只要将这个 TL grade 减少然后病人呢安全度过回手术期，这个就是赢了。所以要达到这个呢，还是要根据不同的情况去做选择。最后我知道时间超了一点，那我们也遇到一些病人，确实可能右心负荷不是太好然后呢解剖结构呢修复又是很难，像这个病人5个月，然后呢这个缝隙非常大那我们就想到了是不是可以 combine， 因为在外科医生他也经常做这种 combine 修复手术。那我们首先呢帮他做了 K， 放了3个 K， 这个在 ICE 的指导下，你看到了这个第1个 K， 第2个 K， 然后呢第3个 K， 放完之后呢，你看到已经放了用 ICE 加食道超声指导放了3个 clip。放了3个 clip 之后呢，很明显的你看到这个中间这个缝隙这个是 baseline， 中间这个缝隙就减少了。那我们就在这个基础上，为了这个反流减得更少，那我们呢就是再下了2个tier，这样子呢就最终将这个 TR 的 grade 从 massive torrential 变成了 grade 1到2啊。这个就是手术之后。所以有很多可能性。那我总结一下嘛，我们就知道现在来说呢，几个重要的 message，3阶脉介入治疗都是很安全的。那每一个介入手段，包括了 TAV、TTVR， 它有自己的 limitation。我们现在最大的有效数据还是来自于 TTR 跟 TTVR， 但是问题来了，就是我们的病人呢来呢，他是解剖结构每个人都不同，然后有一些是很晚期来的，所以呢，我觉得现在这个 toolbox 还是有必要的，就是它其实是进行一个互补。那最后怎么选？我觉得随着越来越多的临床数据，特别是这种 head-to-head comparison 的 data 出来，有可能会告诉我们哪一些病人适合哪一个治疗。希望呢有机会呢。明年再跟大家分享啊，谢谢大家。
谢谢 Dr. Lin。这个我想在座几位有没有什么 comment 或者是 audience？ 那个我想先请叶教授 comment 一下。
Great the presentation, thanks, Dr. Lin. So I guess the combination, I think the combination probably is a good idea with the annular plication and the tear. So I think to me, if a patient have RV dysfunction later stage, I think that's generally speaking, I believe is a repair rather than replacement. So I thought that this probably will be a good combination for the tricuspid valve. What do you think if you do this all the combination with the tear and the annular plication, you think the most patient will be feasible? Because the most time is for the tear patient, because the gap is so big and the tear is actually not feasible. But if you can reduce the annular size first, and then the tear probably will be more feasible in most patient. Do you think that this will be a better future? Sorry.
What do you think? Yeah, I personally think that combination is the way to go. But I just worry about cost. Two systems might be too expensive for most of the patient. Okay.
Any other comments from our panelists?
Maybe I can just supplement a bit about the combination therapy. So the combination therapy, especially if it's a repair, so an annuloplasty together with edge-to-edge repair is very attractive, as you said. But I would say the current technology, we don't have sufficient knowledge to adjust this because the K-cup procedure, it mainly helps to address a leak or a gap at the post-receptor region. Whereas the edge-to-edge repair works the best in enteroceptal. So whether this combination is effective or not is yet to prove. Many people are trying to demonstrate it's feasible, but I personally haven't got a success because we do have some patients that we try to do the K-cup, but end up the gap is not sufficiently reduced, especially for the enteroceptal side. So we have to learn more about that.
I think the holy grail is to find a device that can do a true annuloplasty, like a surgical annuloplasty. And that's what most surgeons do, right, for a lot of dysfunctional tricuspid regurgitation. If you can get a good annuloplasty, maybe that's the one device for it, yeah, rather than having multiple devices that increases the cost, like what was mentioned, yeah.
Maybe we can use some cinching device, yeah.
So I'd like to ask Kento. So in daily practice, you usually go first TTR if patient anatomy allows you to do tri-grip, or you do So which strategy do you usually use?
So this is a very, very difficult question. But in general, with the available evidence, TTR is still the device that has the most evidence and is so safe from our experience and also from the other global experience. So TTR, if anatomically is feasible, especially if we expect the TR is going to reduce to mild, then that will be my preferred choice. And if the patient's anatomy is not feasible, for example, due to large gap or 5-leaf morphology that we expect the result is suboptimal, then we will consider for eligibility of other alternative device. That is not 100% because the patient still has to go through anticoagulation, RV mismatch, afterload mismatch, and also the CT screening. So, but the preferred option would still be TTR, given the evidence.
Okay, I think this topic is very interesting, but we have limited time, and we have to proceed to the next topic. And the next topic will be given by Dr. Didier Cheche. Dr. Cheche, he graduated from the University of Paris, and this is now interventional cardiologist working at the clinic, Pasteur, Toulouse, and is currently the head of a structural program at that hospital. So let's have the slides, please.
So good afternoon, everyone. So thank you for inviting me to be part of this meeting. It's a great pleasure to be here, and I will try to address within 10 to 15 minutes pure aortic regurgitation and its associated treatment modalities. Just to make sure, do you see the slides?
Yes, we can.
Okay, cool.
Yeah, please.
Okay. So hi, Hsin. So here are my disclosures. So first of all, the first point that is important to discuss and understand is the scope of this disease. In most of the echo-based survey, it seems that the prevalence, the incidence of pure aortic regurgitation is less than 1%. But if we go through more into details and we analyze this type of cohorts of volunteer patients, people without any known valvular heart disease, when they undergo echo screening, it seems that the prevalence of significant valvular heart disease is more important than what we imagine, and particularly aortic regurgitation. And what is also important and confirmed in other studies, with the aging population, the older are the patients and the more prevalent valvular heart disease is. So it seems that the prevalence of pure aortic regurgitation is more important than what we imagine. A very tricky part of that, the management of these patients with pure aortic regurgitation is the diagnosis. And you can easily understand from these quite busy slides that there is a multiplication of criteria because it's difficult to diagnose and quantify pure aortic regurgitation, and it requires a combo of several items. The vena contracta, the location of the jet, the flow convergence, the pressure half time, the LV dimensions, and similarly to the heart valve collaboratory, we can quantify patients as either having mild aortic regurgitation or a severe aortic regurgitation with a orange, yellow to orange zone in the middle that makes it quite difficult to diagnose. And we, most of the time, tend to combine at least 4 criteria to confirm the severity of pure aortic regurgitation based only on echo. But more recently, what has emerged is the potential central role of a CMR. And you see that if we take these regular criteria individually, they are not so frequent in all the patients, and sometimes up to 50% of the patients have no reliable pressure half-time, for instance. And if you take the other criteria, it could even be lower, like 25%. So CMR plays a role, and it's quite interesting when we apply CMR to patients with moderate AR. We can reclassify these patients to severe aortic regurgitation in almost 50% of the cases. So CMR is likely to become more central in the future. Apart from diagnosing fibrosis, it seems to be more efficient, more reliable for quantification of aortic regurgitation. So echo first, and CMR for the patients who can afford that. Exercise testing could be another way to at least try to classify the severity of the symptoms of the patients, because sometimes patients claim to be asymptomatic, and when we go through the exercise testing, apart from the modification of the echo criteria, we can identify potential symptoms that may be helpful to reclassify the patients and to decide whether or not to proceed with surgery. What is the clinical impact of pure aortic regurgitation? So that's maybe something that is a little bit misunderstood, but if we take these surveys of longitudinal surveys of patients between 2 to 3 or 2 to 5 years, you can clearly see that asymptomatic patients with moderate aortic regurgitation at the time of the inclusion in these registries, when they are followed up, they develop for more than 50% of them a severe aortic regurgitation. So that disease seems to progress quite quickly. So it tells us that maybe we should have a better surveillance follow-up of these patients in a more regular way. Another important aspect is that when patients are not treated, if they have a severe aortic regurgitation, you can see that the mortality at 2 years is quite important, quite great, with close to 25% mortality for those patients with severe aortic regurgitation. But it's something that we understand. But even if they have lower grades of aortic regurgitation, there is also an impact on survival. So aortic regurgitation per se is a risk factor for mortality, particularly if the patients are not treated. What about the impact of the symptoms? In patients with the patients who are highly symptomatic NYHA class 4, you can see that the mortality at 5 years average is 30%. But even the patients with NYHA class 2, lighter symptoms, also have an impact on the mortality. So the greater are the symptoms, the greater is the mortality. So we should clearly seek for the presence of symptoms. And that's why I introduced the idea of potentially stress testing these patients to be more efficient in terms of screening. What is the impact of cardiac damage? The first parameter of cardiac damage that is usually accepted is the left ventricular systolic diameter, particularly the indexed one. And when it is above 25 millimeter per meter square, there is a high mortality, even if the patient has moderate aortic regurgitation. So it has an impact. For those patients with less than 25, severe AR is associated with an increased mortality at 2 years. So enlarged left ventricle has a poor prognosis, even if the patient only has at baseline moderate AR. Other parameters that are considered for cardiac damage are the biomarkers like the proBNP, NT-proBNP, the fact that the patient has atrial fibrillation. And the more you combine these items of severe cardiac damage, even combined with moderate AR, it has an impact. These are the green and dotted lines. It has an impact on the survival of the patient. So moderate aortic regurgitation can be really bad when it is associated with signals of already cardiac damage. And there is a better understanding of the potential causes of that higher mortality of pure aortic regurgitation. It may be that the patients are referred too late. And in that survey, the EuroHeart survey, you can see that only 25% of patients with depressed LV function, some cardiac damage, and less than 3% of those with LVEF less than 30% are referred to surgery, despite the fact that they have a significant aortic regurgitation. So it's difficult to diagnose, to identify, but even when diagnosed, these patients, for a quite significant proportion of them, they don't go to surgery. If they go to surgery, even with the surgery, depending on the timing, you can see that mortality at 1 year is not benign, and untreated 24% of mortality, but treated with surgery almost 10% of mortality. So it's a disease that demands a proper diagnosis, a timely diagnosis, and that demands a proper treatment and faster treatment. And we are learning more and more about that. So what are these treatment options? Surgery is the first one. But once again, it has to be integrated into that difficult diagnosis. And you can see that we can, if the patient has a significant AR with symptoms, surgery is the first line treatment if the patient is still operable without any doubt. But those with significant AR without symptoms are more difficult to stratify. And it turns out to combining all the parameters that we have described before, the LVEF below 55, LV and systolic diameter index more than 25, and those, I would even add those biomarkers to understand the level of cardiac damage of these patients and to redirect them towards surgery. So it's not easy. So the new guidelines, ESC guidelines, just published last year, make a big role, provide a big role to surgery with clear cutoffs, and that 25 millimeter per meter square of LV and systolic diameter seems to be the threshold that is accepted, but we could potentially be even more conservative and proactive, I would say more proactive, because based on these echo data, it seems that you have that 25 millimeter per meter square on the right part of the slide, but if you shift the focus towards the left part, you can see that potentially 20 millimeter per meter square could be a better threshold, because starting from this point, we have an impact on the mortality of the patient. So it's likely that in the future, the thresholds are going to be slightly modified towards that target of the LV and systolic diameter indexed greater or equal to 20 millimeter per meter square. So at last, the novelties in terms of treatment of pure aortic regurgitation is TAVI. We know that TAVI with first and second generation TAVI devices not fully dedicated to that indication because of the lack of calcium, the lack of collective knowledge about the sizing, the techniques for deployment. It bears a high risk of valve dislocation or late embolization, residual significant AR, another rupture, aortic root injury, because these patients sometimes have integrated associated aortopathy. So it's quite difficult, particularly because we have also a combination of super large annuli. So technically challenging for the currently available TAVI devices. So low device success, second valve required in a quite significant proportion of the patients with these non-dedicated devices, 30-day mortality above 10%, which is quite high in contemporary practice. And so there is a need for dedicated devices. The purpose study, it remains quite a small study, but it compared dedicated devices like the JenaValve to non-dedicated devices, and clearly there is an improvement in terms of device success, residual AR, the need for a second valve, and overall outcomes, more impactful clinical outcomes like mortality. So dedicated devices who seem to be a game changer for TAVI for pure aortic regurgitation. And one of the dedicated devices that we all know is the JenaValve, but there are lots of newcomers, new players that are going to be integrated in the future, and I'm sure that you recognize many of them, several of them in that slide. The most important thing is to understand how these devices are going to play a role, because as I said, there is associated arthropathy. It has to be integrated. For bicuspid, for instance, we don't exactly know what to do with that when it comes to performing TAVI. Is it going to increase? The diameters, are they going to increase? Are they going to decrease? It's even more complex for pure aortic regurgitation, because we may have to face a leaflet prolapse and so on, eccentric jet, a different orientation of the overall aortic root, and so it may be even more technically challenging to perform TAVI for this patient. So I'm not sure that we will be able to treat all types of pure aortic regurgitation in this high-risk population. So we will need to all collectively understand more about the anatomically suitable patients. So JenaValve with the Trilogy system is one of the most popular device, and you see in that animation the way it deploys, and it's clearly dedicated to that indication. It has proven to be super efficient and safe in the Align AR trial, and as a consequence, there is the Artist trial that is ongoing, and there is a randomizing patients with pure 3 to 4 plus native aortic regurgitation to treatment with either the Trilogy system, TAVI with the Trilogy system, or surgery in a one-to-one fashion, and we will get a better understanding of the performance of that system in this population. There is also one indication that is interesting is the patient aortic regurgitation in left-assisted devices patients, and there is that JenaValve registry that is ongoing to better understand how to position the device, because as you can see on the bottom right animation video, clearly with the devices, non-commercially dedicated devices for pure aortic regurgitation, we may end up with this kind of scaffolding because of the lack of technical features suited for pure aortic regurgitation. So potentially JenaValve could be an option. There is a newcomer in terms of a balloon expandable valve. It's the MyValve Octa Pro platform. Given the stable deployment, the predictability, and most importantly, the potential for overexpansion of the device. And sometimes in this patient, for instance, it's plus 10 cc's that have been added just to make sure that the patient, the device could match the large annular diameter. And as you can see, with a very nice outcome. We're understanding more about the impact of the LVOT shape and the landing zone configuration. And if you watch the right part of the slide, when it is flared with larger LVOT, the embolization rate seems to be greater. So we are learning more and more about the technicalities of TAVI for pure aortic regurgitation, particularly with the balloon expandable platform. It's going to be investigating more in depth through the Marvel study, a registry, multicentric registry with that platform conducted in Europe. So to conclude, I would say that pure aortic regurgitation is a more frequent disease than one we think. It's definitely underdiagnosed and undertreated. A severe AR and its late diagnosis bear a dreadful prognosis in terms of mortality. So that is the most impactful clinical outcome that we want to prevent for our patients. And even moderate aortic regurgitation, when it is associated with LV enlargement and signals of myocardial injury, has a dreadful negative impact. What we also know is that echo-based diagnosis has inherent limitations because of the multiplication of the criteria and the need to combine them. They are not all available in all a single patient. So a potential role, systematic role of CMR in the future has to be envisaged. TAVI for high-risk patients represent a valid treatment option, not with these early generation devices, but with dedicated devices or potentially balloon expandable platforms with a potential to treat larger annuli and with a very, very stable deployment. So it is still work in progress, and these ongoing trials are going to explore future options and indications in this population. So with that, I thank you for your attention, and I know that we are kind of late, but I'm open for a couple of questions if you want.
Okay, so thank you. Well, probably because just one question, okay, please, because it's a way overdue. Okay.
Yeah, I'm Wei-Shen in, and I just want to ask, is symptomatic really important in decision making? I mean, when all the parameters indicate that the patient should be treated, why we still wait for the symptom?
Yeah, that's a very important question, Wei-Shen, and that could be a core aspect of that talk. Maybe we shouldn't wait for symptoms, because once the symptoms develop, most of the time we already have LV and then large LV and signals of cardiac damage. So it may be too late. We operate on these patients, but quite large proportion of them are going to die. So I agree with you. We should be more proactive, and as soon as we have the confirmation of severity of the AR, patients should be treated, and that's my opinion.
Thank you very much.
Okay, thank you.
Thank you.
Okay, thank you. Thank you, Didier. Thank you. The next topic will be given by Dr. Bernard Prendergast. He is the chair of cardiology at the Cleveland Clinic, London, and also he is the consultant cardiologist at the St. Thomas Hospital in Westminster. So please, Doctor.
So good afternoon, everybody, and welcome to London, where it's very cold, rainy, and wet. And I'm very sorry, therefore, I can't be with you in Taipei. It's always a great pleasure to join you for this meeting. And I learned a lot listening to the talks from YY Lam and also from Didier. And congratulations also to Michael Lee for that spectacular case in the preceding session. So I'm going to share my slides with you and turn to the perhaps more mundane topic of aortic stenosis after such fantastic presentations on tricuspid regurgitation and aortic regurgitation. Can you just confirm that you can see these slides?
Yes, we can see it.
Perfect. So what I'm going to do is walk through some of the recent emerging evidence and the trends in thinking about the management of this more common disease, aortic stenosis, with particular reference to recent trials and also importantly to international guideline recommendations. Of course, the principal focus will be the European guidelines, which are the most up-to-date and were published and presented in late 2025, and importantly reflecting the rapid emergence of valve disease and the evidence base supporting progressive management. These guidelines incorporated a large number of new recommendations, both brand new and those which were significant revisions and advances compared with the previous iteration that was published only 4 years previously. Like many aspects of interventional cardiology, valve disease is moving at speed. The first thing is that we have noted considerable expansions of indications for TAVI or TAVR in the European Union. And I think many other areas of the world have taken their lead from these movements. In Europe, of course, we acknowledge the very strong evidence base that had come from the succession of landmark partner and Evolute trials, but there was always a recognition that these trials were industry-sponsored and of limited size, despite their strong statistical power. And it was therefore very important to incorporate the outcomes of the DEDICATE study, a very large study undertaken in Germany, enrolling all comers with 3-leaflet, tri-leaflet, tricuspid aortic stenosis, and significantly enrolling a younger age group than those who had been enrolled in the earlier randomized trials, an age threshold of 65 to 85 years, as highlighted here. And that was borne out in the baseline patient characteristics of this study, where the mean age was 74 years in both groups, but there were, as you will see from the confidence limits, a very substantial proportion of patients were aged 70 and over. And that therefore becomes very important when we look at the results of this trial, where the primary outcome of all-cause death or stroke was substantially lower in the TAVI arm of the trial, highlighted here in blue. And even taking the hardest endpoint of all-cause mortality, there was a substantial reduction in this important endpoint associated with transcatheter treatment in patients of this younger age cohort. So directed by trends in the USA, directed by the previous randomized evidence and this European randomized evidence, an important step forward was made in Europe when the age threshold for use of TAVI was lowered from 75 years to 70 years with a level 1A recommendation, the highest level of evidence available in guideline technicalities. Of course, surgery remains important, particularly for patients with bicuspid valves, as we shall come on to, but is still recommended in Europe for patients aged less than 70 if the surgical risk of the procedure is low. And also remembering the very important role of the heart team in adjudicating the very many grey patients who sit in the middle of these guidelines, and adjudication of their anatomical suitability for these procedures is of utmost importance. These factors which govern these decisions are summarized in the right-hand panel of this slide. Of course, age is an important variable, but we all understand as experienced clinicians that there may be older patients who are super fit, and there may be younger patients with substantial comorbidities which make surgery unattractive, renal failure, respiratory disease, amongst others. And of course, there are specific anatomical criteria that may make TAVI or surgery a greater or less attractive option, according to the risks of the procedure and the feasibility of transfemoral access. So these decisions inform a lifetime treatment algorithm, which is summarized on the top left-hand side of this panel. And importantly, these considerations need to be incorporated into heart team discussions with a very strong level of evidence, one recommendation again, supporting this mode of working in heart valve centers, and also the reporting of the outcomes of these data at national and international level. Moving beyond conventional 3-leaflet aortic stenosis, we should also recognize that bicuspid aortic valve disease is more common as we treat younger and younger patients. And put simply, the randomized data for bicuspid valve anatomy are extremely limited. And for that reason, the recommendation for TAVI in bicuspid aortic valve is slightly softer. We should also remember that other means of access beyond transfemoral TAVI are also appropriate, whether it's transcarotid, transsubclavian, transaxillary, or even transcaval. and these options should be borne in mind for high-risk surgical patients who are unsuitable for a transfemoral procedure. The other important evolution, which has been guided by evidence, has been the application of TAVI in asymptomatic patients with aortic stenosis. And this is now also recommended and confirmed in the guidelines, as you see here from this table taken from the original guideline publication. This evolution, this trend, has been driven by historical data from surgical trials. You see here the data and the outcomes from the AVATAR and recovery trials, demonstrating the beneficial impact of earlier intervention in both studies, but both of these studies being relatively small with limited statistical power. And this algorithm was taken forward substantially in 2025 with the publication of two important trials: the early TAVR trial from the US, enrolling nearly 1,000 patients with asymptomatic aortic stenosis confirmed with exercise testing, and demonstrating the superiority of an early intervention arm with substantial clinical benefit within 1 year of randomization. And supported by a more mechanistic study from the UK, the EVOLVE trial, which explored the cardiac magnetic resonance phenotypes, which are most likely to benefit from this earlier intervention strategy, demarcated by patients with myocardial fibrosis, late gadolinium enhancement, and the very earliest signs of left ventricular impairment. Of course, our evidence and our understanding is continuing to emerge. I've already mentioned some of the limitations of these trials. And of course, to some extent, like all randomized trials, these were selected patients with very severe aortic stenosis and were extremely low-risk procedures. The outcomes of TAVI, for example, in the early TAVI trial were extraordinary, with very, very low complication rates and very, very low mortality. And of course, extending these randomized experiences into everyday clinical practice may be more challenging, especially in low volume, less specialist centers. But nevertheless, despite these caveats, this is very much a trend of management which is now accepted by the international community. And certainly the planning of procedures and the offer of early TAVI procedures becomes an important part of our everyday work, bearing in mind that these decisions need to be made after carefully informed discussions with patients and their families. I've already mentioned bicuspid aortic stenosis, and the only randomized data that we have come from the Notion 2 trial, which sounded a warning alarm to the wide application of TAVI in bicuspid anatomy, recognizing, as you will see here, that the incidence of adverse outcomes was higher in the TAVI arm compared with surgery, particularly as a result of the risks of important complications, including stroke, annular rupture, and significant paravalvular leak. So for these reasons, we need to apply some caution before our enthusiasm extends to bicuspid anatomy, particularly those with more complex anatomical subsets. And I will finally reiterate some of the comments that Didier has made in relation to the treatment of aortic regurgitation. He made a very important plea for greater awareness of this condition, which is under-recognized, under-investigated, and under-treated, and also move towards an earlier algorithm to access to specialist assessment, including advanced echocardiography, cardiac magnetic resonance, and the involvement of heart teams at early stage to allow the earlier application not only of surgery with valve repair when anatomically suitable, but also, of course, the application of emerging transcatheter technologies, which Didier has so eloquently summarized. So the take-home messages from me from the UK in London are that the expansion of indications for TAVI is well underway, and the volume of procedure is growing rapidly in all centers, with an emerging problem of waiting lists and ensuring that patients have access to this technology in a timely fashion. This has been compounded, of course, by the application of the data relating to asymptomatic patients, and it's now becoming routine to investigate these patients early to define their suitability for a TAVI procedure, with the ability to proceed quickly, even in those patients who are managed with close surveillance. There is a call for randomized trials in bicuspid aortic valve disease, and I'm pleased to reassure you that those trials are now underway and enrolling, but of course it will take some years for their results to be available. And we have much to consider and much to excite us in relation to the emerging importance of aortic regurgitation. Thanks very much for listening.
Thank you, Dr. Prendergast. And I think Dr. Jeng, you have any comment?
Thanks for the excellent talk and the special explanation on the guidelines. I think there's a lot change on the new guidelines. So my one comments or questions regarding the asymptomatic severe aortic stenosis. So I know there's a trial, they say some trial they already show there's a in terms of death, stroke, and the rehospitalization is on the waiting group was high compared to the early intervention group. But my question is in the young patient, I think we have to be very cautious. We haven't really considered about the lifetime management, because you do, yes, you increase the hospitalization, but your early intervention, you may also cause a subsequent complications later on in terms of valve failure. So I just want your comments in the future. There's a clinical study. I'm pretty sure for the large study, I think it will be a positive in terms of rehospitalization, because this patient will expect back to the hospital and they have undergoing surgery or either TAVI. But we're hard to consider about the future, the cumulative risk for this young patient. I just want to see your thoughts on that.
Yeah, so this is a super important question, so thank you for highlighting it. Of course, the minute that you implant a prosthetic valve, whether it's surgical or transcatheter, the clock is ticking for the durability of that device, incorporating, of course, the risks of the procedure, because the risks are not 0%, but also questions regarding the longer-term durability of the device and the need for a second intervention, perhaps 7, perhaps 10, perhaps 12, or perhaps 15 years later. Often we don't know, and we won't stray into the question about TAVI durability, because that's a separate lecture. But we are still learning about the durability of TAVI devices, and this year, of course, we've had some reason to reflect on some signals relating to the outcome of the low-risk trials. So we shouldn't reassure ourselves that it's plain sailing and the durability will be long. And secondly, we need to remember that the second procedure, whether it's a TAV in SAV or particularly a TAV in TAV, also carries uncertainties and risks. And the TAV in TAV procedure in particular, we're learning is more complicated than we might have thought 5 years ago. As the numbers of these procedures are increasing and they are being undertaken in widely varying anatomies, we are learning that there are new planning considerations and there are new complications of these procedures which we all need to learn about. So I think these are very important caveats to temper our enthusiasm for earlier intervention in asymptomatic patients. And I think we need to think about these things very carefully, and we need to discuss the uncertainties very openly with our patients.
Thanks for the very nice presentation, well summarized to understand. I have 2 questions. Actually, the age limit is for the TAVR was decreased from the 75 to the 70. Therefore, the proportion of the patient who underwent the TAVR for the bicuspid more expanded. So what is the reality in your country and the proportion? And the second one is to use of cerebral protection devices. Actually, two random study was a negative result. But when we do some cerebral protection, especially in the valve-in-valve and the TAVI in the surgical valve, we very sometimes frequently surprised that the big size of the tissue material was extracted. So what is your practice pattern?
Yeah, so again, very important questions. So firstly, bicuspid aortic stenosis. Of course, we're now seeing more patients with this anatomy because we are looking at patients aged 70 and greater. And I think we need to remember that not all bicuspid valves are the same. Firstly, their anatomical configuration can clearly vary. And certainly patients with type 2 bicuspid aortic valves do very badly with TAVI. So these patients remain surgical candidates in our centre. Secondly, we need to remember that the coronary anatomy can be variable in patients with bicuspid aortic valve disease, and that many of these patients also have associated aortopathy. So there needs to be much greater detail in our consideration and planning for these patients, and a very low threshold to consider surgery if there is any departure from simple bicuspid anatomy. And the role of the surgeons in these discussions remains essential. Secondly, your question about cerebral protection. Of course, the UK trial was the second trial, but the largest trial. And we've also merged the data with the original Index US trial and confirmed that across the board, routine cerebral protection has no advantage compared with routine treatment. But you're right that there are some specific subsets where we have some uneasiness about the risk of cerebral embolism. And you've outlined some of those particular groups, particularly TAV-in-TAV or TAV-in-SAV, and also patients with exuberant leaflet calcification and mobile fronds of calcium. So the use of cerebral protection devices in the UK has dramatically fallen. I forget the data, but in our own centre, we're now only using it in a handful of patients per year. And I think there are similar trends in the US where financial considerations also apply. But there are some individual scenarios where I think it is in the patient's interest to use one of these devices. And also remembering there may be some selected patients with mitral valve disease as well, having mitral valve interventions, who will also benefit from cerebral protection.
Okay, so since the time is way overdue, so we have to move to the next topic. Thank you. And the next topic will be given by Dr. Ono, and he's from Tokai University School of Medicine. He's going to talk to us about the new transcatheter mitral valve replacement device.
Thank you for your kind introduction, and always a great pleasure to be back here in Taipei. For the next several minutes, I would like to give a talk regarding novel devices. And now we are facing transcatheter mitral valve therapy. So thanks to recent iteration of the mitral TEER devices, mainly MitraClip and Pascal, we can offer favorable results to majority of the patients. I would like to briefly share our cases. This was a very large P2 prolapse case, as you can see here, extremely large flow conversions with several torn chordates. Using XTW devices with a very nice control of the MR, and we ended up with a residual trivial MR. This was a G4 system, and now, not in Japan, but G5 system is available in US and I think in Europe. And even with these non-central lesions, this is a AC commissural valve prolapse with chordae rupture. NPR, most of the time with these non-central lesions, makes your life much easier. And with this dedicated imaging, we were able to achieve good outcome with a single Pascal ACE device. But we still cannot provide excellent outcome to all patients, obviously. Like in this specific patients with restricted leaflets, it's always tough with some degree of calcification. And these kind of anatomies also for surgical mitral valve repair is not favorable. So we need to have another dedicated device, which is a potential mitral valve replacement device. That's because our recent report from OCEAN Mitral Registry that if we end up with a residual, moderate or more degree of MR, the patient has a worse clinical outcome. So better to achieve, obviously, with a mild or less MR at the end of the procedure. And there are a lot of things to be considered when we try to address these MR patients using mitral TEER devices. The baseline anatomical complexity, obviously the baseline mitral valve area matters, together with annular and leaflet calcification. So often very old patients has combined mitral valve calcification, MAC, and MAC-induced mitral stenosis limits this procedure. So there's a kind of a consensus that obviously very central and good leaflet quality patients, we can offer excellent outcome. However, in patients with limited mitral valve area in the baseline or the combination with some degree of stenosis, calcification, restricted leaflet, posterior leaflets is very still challenging. So maybe we need to address these patients using other devices such as replacement device. So what is the current decision algorithm? Of course, in many geographies, we still don't have access to TMVR devices. Still, some of them are under clinical trials. But by imaging assessment, if we can anticipate a good outcome with less than mild MR with transcatheter mitral valve repair device, we basically go for repair approach. And most of the cases, I believe, it's edge-to-edge repair. And if that is not anticipated and residual moderate or more MR is suspected, we need to go for other approach, such as a replacement approach. However, as been discussed with the tricuspid space as well, if the patient needs to take anticoagulation. And on top of that, there's always a limitation of anatomy. So after replacement therapy, there's an issue of potential LVOT obstruction. So we need a thorough examination of these kind of patients. So several devices are under clinical trials. Some are CE mark and FDA approval. The earlier adoption is the Tendyne device, but this is only from the transapical device. The other device, majority of devices are now available with a transfemoral transeptal approach. And actually, this is the report from the real-world clinical practice from Choice MI Registry. As I mentioned, always a difficult anatomical limitation. Therefore, those who have been screened for the potential therapy, 746 patients, only 30% have actually received TMVR. A majority of patients were screened out due to anatomical reasons. This is a report which illustrates what was the majority of the reasons for screening out, and it was obviously the risk of LVOT obstruction. Some of the patients develop extremely large annulus that the current device cannot reach, and also involvement of the MAC, extremely calcified leaflets, annulus, and mitral stenosis. So I would like to share two devices. This first one is Intrepid, Medtronic device. Now more than 700 patients have received this device. It started from a large sheath 35 French system, if I may correctly remember. The longest term follow-up is around 6 years plus. And now we are available with a transfemoral approach. It started from transapical approach. Now transfemoral approach is available. So Apollo trial, this was actually previously a randomized control trial with TMVR using Intrepid versus surgical mitral valve replacement. Actually, we were one of the investigational sites, Apollo, part of the Apollo Japan, but unfortunately due to COVID pandemic, this trial was stopped. And now this is a new trial design. It's no longer versus surgical mitral valve replacement because it's very tough to enroll patients in that circumstance. So now this primary cohort is for patients with either primary or secondary MR, and they also have a MAC cohort. So these are the endpoint studied in this trial: all-cause mortality, heart failure hospitalization, and QoS score. This also has a MAC cohort, as you can see here, dealing with extremely calcified MAC patients. This device also sits well with no significant paravalvular leakage. Obviously, the screening process is extremely important. And this second generation system is now available. This is Voyager 29 French system. It's now slightly smaller profile and can go with from the transfemoral and transeptal approach. 3 types of valve sizes available: 42, 48, and 54. And this is a representative case of this device using Intrepid in MAC patients. 67 years old, relatively young patients, severely symptomatic NYHA3 with combined mitral stenosis and regurgitation, preserved ejection fraction. Due to previous radiation, she has calcified ascending aorta, which precludes from a surgical approach. A history of left main PCI. Then STS score is 7% and deemed high risk for mitral valve surgery. So this transesophageal echo shows very limited leaflet motion due to calcification and in addition, severely calcified annulus. We can appreciate this severely MAC imaging here with the transesophageal echo, together with a significant amount of regurgitation. So based on the CT analysis, the perimeter of this patient is 101, and it falls in the 42 millimeter device size, and this was the CT screening result for this specific patient. And obviously the next step is to precisely analyze the potential neo-LVOT. So full phase using CT scan, multi-phase scan is mandatory from 10%, 20%, 30%, 40%, 50% as seen here. This potential neo-LVOT varies from in the cardiac cycle. So we need to carefully examine in each phase. So finally, this patient received 42 millimeter Intrepid valve with a transfemoral transeptal approach, very stable and deployment here shown. After the deployment, there was no significant paravalvular leakage, but some degree of transvalvular leakage. But most of the time, in the follow-up, this transvalvular regurgitation gets better over time, as you can see here, with trivial mitral regurgitation, with no significant LVOT obstruction in this case. So this is the report in Eurointervention by Gilbert and their colleagues, 5 years follow-up of all-cause mortality and heart failure hospitalization. Still, this early phase, some degree of signal of early death, so still needs to be improved. But in terms of mitral regurgitation, up to 5 years, it's quite durable and stable over time. So the next is Edwards Sapien M3 system, which was recently approved also in the FDA. I guess it was approved in CE mark earlier last year. So this device is unique in terms of two-step approach. First, the dock delivery in the subvalvular space, and then followed by the SAPIEN M3 valve implantation. As I mentioned, it's a two-step approach from the transfemoral and transeptal approach. After this transeptal axis, the first step is the dock deliveries in the subvalvular space, because basically the leaflets are not calcified and we need to hold this device within this space. So we need this dock for this specific system. It could be a bit complicated, and obviously this transesophageal echo guidance is critical. This is the step of this dock delivery here, and followed by SAPIEN M3 deployment. This phase is almost similar as a valve-in-valve or valve-in-ring procedure using the classic SAPIEN balloon expandable platform. The post-deployment transesophageal echo seems remarkably well. And as you can see here in the ENCIRCLE trial, they assessed the patients with significant mitral regurgitation who was deemed for not favorable for surgical candidate or transcatheter edge-to-edge repair treatment. Main study up to 300 patients. They also have MAC registry here and failed transcatheter edge-to-edge repair registry. Key inclusion criteria shown here: significant symptomatic MR, and some of the exclusion criteria here shown as severely depressed LV function, and patients who are planned for aortic or tricuspid intervention within the next 12 months are excluded. So this device was approved last year in Europe as well as in the US, and I think commercially based treatment will be starting this year. So as for take-home message, transcatheter mitral valve repair replacement offers the promise of durable MR elimination with some mid and long-term data available, but still not over 5 years. Workup intensity, including echo image, CT image, and cardiac cath, both left and right cardiac heart cath, versus TEER makes it challenging to enroll these patients into clinical trials. High screen failure rates up to around 70% mostly due to device sizing and potential LVOT obstruction, limit trial enrollment as well as in daily clinical practice patient treatment. A number of unknowns yet, including LVOT gradient, durability, anticoagulation, concerning thrombosis and LV remodeling, warrants longer-term data. Thank you for your kind attention.
Thank you, Dr. Arnold. Are there any comments from the audience or from panelists? Yeah.
So maybe I can ask the question. Yohei,
sure.
Again, very excellent talk as always. So it's always good to hear about TMVR, but there's a lot of problem with TMVR. So with multiple platforms that are undergoing, so the T-tier procedure is so good, so safe, and the exclusion rate is actually not very high compared to the tricuspid arena. So which kind of anatomy do you think is actually the unmet need for mitral space for TMVR?
Excellent question, Ken. Thank you so much. I think, as you mentioned, I think less than 10% of the patients falls into those kind of red zone category in our contemporary practice. I think those with definitely combination with MAC and mitral stenosis makes the TEER procedure difficult. Of course, in non-central lesions, starting from baseline mitral valve area around 3.5, if it's non-central lesion, it could be treatable. But in large A2, P2 lesion, it could be difficult. So those kind of patients definitely, and patients with rheumatic heart disease kind of feature in the leaflets or the commissure adhesion, those kind of also carries risk for stenosis. And the one I showed, extremely restricted leaflets, those have risks for mitral leaflet tear as well. So I think those kind of patients, but not a lot.
Maybe I'll just add, I think most cases can be treated very well with TEER, but I think one other subset is those that had recurrence of MR after TEER, maybe 5 years later, and those that you cannot put another TEER device and you can't do surgery. Maybe those are quite good candidates for TMVR. We can lacerate the clip out. Yeah.
Definitely. Has anyone in the panel has tried the laceration of the pre-implanted TEER device and placed?
We don't have TMVR here, right?
Yeah, that's right.
Okay, thank you so much. And the last topic will be given by Dr. Xian from our hospital, Zhongshan General Hospital.
Okay, my talk should be shortened. It is my great pleasure to present the TAVR in SAVR current state of the art. Actually, I want to show some of our new data from our analysis. As we know, we have put many aortic bypasses during the past decades. So no wonder when the valve failed, we are facing how to treat them. Valve-in-valve TAVR versus Redo-TAVR, we can show that the short-term result or immediate procedure success rate was really favored valve-in-valve TAVR. However, the hemodynamic performance of the valve-in-valve TAVR is inferior to the Redo-TAVR. And after 3 years, the survival curve crossed, which favored Redo-TAVR. So current guidelines still recommend the 2A recommendation for valve-in-valve TAVR. However, because the population is getting older and older, and for second intervention, I think most of the patient or even the physician will choose transcatheter approach. So up to 2035, it is estimated that no matter the valve-in-valve TAVR for surgical valve or transcatheter valve will be increased dramatically. In dealing with failed surgical bioprosthesis, I think two issues should be considered. That means the coronary issue and the hemodynamic performance. For hemodynamic performance, as you can see, balloon versus self-expanding valve have a different result. The post-procedure gradient will be higher in balloon expandable valve in failed surgical valve. So this may compromise the long-term outcome. As we mentioned, in small surgical valve, if you put a transcatheter valve inside and you use balloon expandable valve, the gradient will be much higher than that of the self-expanding valve. And if the surgical valve was small, the long-term outcome would be poor. So up to 8 years, there is significant difference. If the surgical valve is small valve, the long-term outcome will be compromised. We know that valve-in-valve TAVR works, but it's not perfect. As we mentioned, the reintervention, the rate is still higher in the long run. So pre-existing severe PPM or device malpositioning and the use of balloon expandable valve are predictors of reintervention. That means if you use a balloon expandable valve in a small surgical valve, that is the worst combination. We all know that bioprosthetic valve fracture can help. It can increase the EOA and lower down the pressure gradient. And even you can choose a larger size of THV for the transcatheter approach. However, the timing of BVF is still controversial. Pre-implant BVF may result in acute AR and hemodynamic compromise in some series. However, the recent data are challenging the BVF afterward, because we do have some data showing that if we dilate the THV or too aggressively, but it may compromise the long-term damage because of leaflet damage. So in our center, we start from the very beginning. We think that we should break the valve before we implant the THV. Given the, as I mentioned before, given the BEV and small SAV is considered the least favorable combination, so we chose to a pre-implant BVF. In our center, ever since 2018, we use this approach for every small SAV with a true ID smaller than 21 millimeter. This consists of 78% of our surgical valve failure patients. In those 97 patients underwent VIV TAVR, 78% of them were small annulus, and of them, 35 patients underwent BVF. As you can see, if you do BVF or BV modification, you can get a really high device success rate. That means the use of only one valve and without significant gradient, more than 20, and no significant power leaks. The statistical difference was significant. And also you can have a bigger EOA and lower pressure gradient. We have also analyzed the 5-year follow-up. As you can see, the patient undergoing BVF or BVM can have a significant better survival, long-term survival. Although using the multivariate analysis, 30-day clinical heart failure and SDS score was still the strongest predictor. But as you can see, there are signs showing that BVF and the BVM can improve survival in the long run if we have a larger number. So this is a typical case. In 2016, we put the 23 millimeter Sapien XT in a failed Magna valve, which was a small one, 21 millimeter with a true ID of 19. At that time, we don't have the concept of BVF, so the procedure ended up with a really high residual pressure gradient. The THV failed in 2024. This time, we do aggressive pre-dilatation with an Atlas score 22 millimeter to break the surgical valve. Then we put the 23 millimeter FX. This time, the residual gradient was 7 millimeter only. How to deal with the acute AR after BVF? In our center, in those patients with modal failure of stenosis or have poor LV function, at high risk of acute AR and the circulation collapse, we developed the so-called protective BVF procedure. That means we place 2 LV wire, one for ballooning and the other for valve deployment. We will advance the valve in the ascending aorta and stand by there, and we do BVF. After withdraw the balloon and the wire, we advance the THV and deploy it immediately. In this way, we can save time and shorten the hemodynamic compromise period. The other issue is coronary. As we know, when we do valve-involved TAVR, we will encounter the risk of coronary obstruction or sinus sequestration. This is especially true when the surgical valve is external mounted. In vivid classification, if the sinus was effaced or the coronary takeoff was low, the coronary risk will be really high. So in this kind of patient, if the VTS-CJ is smaller than 2 millimeter or the VTC is smaller than 4 millimeter, you should consider leaflet modification. There are many kinds of procedure or techniques to deal with the coronary risk. Chimney technique is the most commonly used. Other are leaflet modification procedures. This is the basilica. We traverse, we cut the leaflet, and then put in the SEV. As you can see, the result was really good. And this is another example, which is a TAVR in TAVR case. If we want to put a second valve in this small THV, failed THV, the coronary risk is high, so we did the unicorn procedure. So with all this, I would say VIV TAVR is a valuable option for patients with failing biprosthetic valve, offering a less invasive alternative to repeat surgery. However, PPM is more common in VIV TAVR. BVF can help to mitigate this issue. Significant risk of another significant risk is VIV TAVR is coronary obstruction. And pre-procedure CT is crucial to identify the patient at risk. And you may need adjunctive procedures such as basilica or unicorn to overcome them. Then with ongoing improvement in addressing those procedural challenges, I think the volume of VIV TAVR is expected to increase in the future. And you can use BVF or the protective BVF to mitigate the risk of hemodynamic collapse during the BVF procedure. I thank you for your attention.
Thank you, Dr. Yin. Since we 1 hour, so we still have 2 sessions afterward. Yeah. So we have to stop. I have to close this session. So thank you so much for everybody to watching for staying with this session. Thank you. Thank you.
Let's move on. This session is designed to discuss brain protection during TAVR. As we know, when we do, I would say, left side procedure, including the mitral and the aortic, I think cerebral protection is always a concern because stroke is a catastrophic complication of this kind of procedure. So with the invention or introduction of cerebral protection device, we buy in that concept very well. And if we discuss with the patient and their families, do you want to use it if the protecting device can reduce major stroke? Almost all patients or families accept that. So in our center, we routinely use cerebral protection device, and the success rate of device deployment is more than 98%. So based on this, I think this is a very interesting issue to be discussed, because I rarely seen such a, discrepancy in study result, trial result, and the clinical practice. If you see the trial result, it seems that you should not use cerebral protection routinely. But who would be the best candidate to undergoing cerebral protection? Maybe we can have a better appreciation of this issue in this session. The first talk will be delivered by Kenichi Ishizu from Kokura Memorial Hospital, Japan. He will cover the issue regarding risk of stroke after TAVR according to THV types. Please.
Thanks so much for your kind introduction, Dr. Yin, and I appreciate the opportunity to present here today. My talk is about a device selection to reduce stroke after TAVR. This is my COI, and despite recent technological advancements and extensive plate experience, peri-procedural stroke following TAVR remains a serious concern, which may significantly impact patient mobility, mortality, and long-term quality of life. This figure shows results of a famous transcranial Doppler study investigating stroke timing during TAVR procedure. Procedural transient signals were detected in all patients of the study, predominantly while THVs were being positioned and implanted. Thrombotic material and tissue-derived debris was captured in around 70% and 60% respectively. And the captured tissue fragments predominantly originated from large arterial structures. So, I believe that an important mechanism causing strokes during the procedure would be that plaques shaped off by the delivery system in the aortic arch, subsequently embolize in the brain during THV positioning and implantation. Then, which of the two type THVs is more offensive against aortic arch atheroма? THV frame VAV barrier expandable valve is not covered, but distal flex of the delivery catheter potentially facilitates intentional avoidance of arch plaques, while self-expandable valve is covered by smooth capsule, as shown here, albeit with no distal flex feature. So we aim to investigate association between aortic arch atheroma and the post-TAVI stroke according to the THV types. We retrospectively evaluated nearly 2,000 patients undergoing transfemoral TAVR using barrel expandable valve and self-expandable valve. This data is one without brain protection. Patients were divided for groups based on the arch atheroma severity as shown here. This table shows the processes type used for each atheroma severity group. Barrel expandable valve was more frequently used for patients with greater aortic arch atheroma severity. But this slide includes a key message of my lecture. In the barrel expandable valve cohort, stroke incidence was significantly increased only in the shaggy arch. However, a stepwise increase of stroke incidence was identified across the aortic arch severity groups in the self-expandable valve cohort. However, baseline characteristics were significantly different between balloon-expandable valve and self-expandable valve, so we performed multiple variable analysis focusing on the difference in stroke risk between two valve types. Even after adjusting for clinical confounding factors, the use of self-expandable valve was related to an increased risk of stroke in patients with non or mild trauma, moderate trauma, and severe trauma. In patients with shaggy trauma, shaggy arch trauma, in patients with, no significant difference was observed between the two valve types. Therefore, we can understand that our study demonstrated the effectiveness of arch non-touch technique appropriated using flex weight with bring back tension of the LV wire as shown in this video. At the timing, this reflex with bring back tension of LV wire and slow advancement is important. Finally, I'd like to propose the evidence-based stroke prevention strategy according to the aortic arch atheroma severity as well as the THP types. Since adopting this strategy in our institution, no single patient presented pre-procedure stroke among the recent nearly 200 consecutive cases. Thank you for your kind attention.
Thank you. Well, we have similar data showing that SEV, if you have multiple resheathing and retrieval of the device and the deployment was too complicated, the sheath might catch something during resheathing. So multiple resheathing is a predictor of more debris captured by the cerebral protection device. Yeah. Any other comments?
Thank you. Thank you for your great talk. That as an interventional cardiologist, from my perspective, I always think that this kind of scenario is just a bit like the routine thrombus suction during the ST elevation myocardial infarction. All these kind of suction trials fail to demonstrate the superiority of routine suction in STEMI. However, in some selective cases, I think that suction, thrombus suction is quite effective than the routine practice. And of course, as you demonstrate that in some scenario, especially for some ugly aortic anatomy, that I think this kind of patient is quite worse to spend the money to use this kind of cerebral protection device, since that the stroke rate is quite high. And also it's great to know that you prove the concept that the balloon expandable valve with the flexible tip that may reduce this kind of stroke risk. And I also know that in China, they got some flexible self-expandable valve. I think maybe it can just buy in the same concept that maybe it's not belong to the balloon expandable or self-expandable. Maybe this concept should turn into flexible system and non-flexible systems.
Thank you. Okay, thank you very much. The next talk will tell us the trials. How to read between the lines. My colleague from Hong Kong, our good friend.
Well, thank you, Dr. Yin. You probably at the beginning have already elegantly summarized my talk, actually. you gave the conclusion already. Just show you some of the evidence of cerebral protection device. Can you see my slides? slides up? Yeah, okay. So really, two big trials together with some registry data. These are my disclosures. We know, I've heard from Professor Pendergast's talk that we are expanding the territory of TAVI procedure, and we are now treating lower risk and younger patients. So we are expecting the number of TAVI procedures to be increased dramatically in the very near future. But if you look at the incidence of stroke, although we are moving to younger patients, lower risk patients, but the incidence of stroke actually is still more or less the same, stands at about 2 to 4% among all the different procedures. So we don't really see a decline in stroke as we move to lower risk and younger patients. And if you look at the MRI-proven brain lesions, among the different procedures, you would notice that the highest incidence actually occurs in TAVI as compared to all other transcatheter or even surgical procedures. So this brings us to think whether we really need to protect the brain during our TAVI procedures. And we know from our experience, if we do more TAVI procedures, we should have less complications. This is true for vascular complications. This is true to prevent bleeding complications. But if you look at stroke, even for high volume centers, you do 400 TAVRs per year, same incidence of stroke occurs. So it doesn't really means that you do more TAVI procedures, you will decrease the incidence of stroke. This is something that not preventable. And we also know that once the patient develops stroke, the chance of the patient being, the mortality, will actually increase quite dramatically by 4 to 6 times, 4 to 6 folds, as compared to patients who do not develop stroke. So when we look at the different cerebral protection devices, not many actually are in the market. In Hong Kong, we used to have Sentinel and TriGuard, but now TriGuard also pulled out from the Hong Kong market. We only have the Sentinel device now. It is a 2-filter system, putting in the innominate artery as well as the left carotid artery. And the purpose is to actually filter more than 90% of the blood flow to the brain, except probably the left vertebral artery. And when you look at the filters at the end of the procedure, I would say more than 90% of the times that you will actually see some debris being captured by the filter. Although this might not end up in significant clinical stroke, but it will actually impact on the patient's future outcomes. These are the various registries, clinical trials being done with the Sentinel cerebral embolic protection device. If you look at the IDE trial, yes, there is a quite significant 63% reduction in the incidence of stroke, but it only just reached the significance level, 0.05. When we look at the single center studies, when they look at their experience, we can see that the cerebral protection device actually seems to be very useful, markedly reduce the incidence of stroke. But when we look at even the registries, you see that it's sort of borderline positive or sort of not a significant outcomes in terms of stroke prevention. And then comes this randomized trial. This is protected TAVR trial conducted in the US. 3,000 patients, 1,500 each arm, with and without cerebral embolic protection device. And they are looking at 72 hours all stroke. And as mentioned earlier, this is a negative trial because the incidence of all stroke doesn't show a significant difference, although there's a trend towards less stroke with a cerebral protection device. The only positive is the instance of disabling stroke. You can see the very significant reduction in disabling stroke. And this is both being conducted in US and out of US. So if you look at the US cohort, there's a significant reduction in all stroke as well as disabling stroke. But for centers outside the US, they don't really see a difference in the use of this Sentinel device in stroke prevention. Conflicting results. Then comes this UK trial, the BHF Protect TAVI trial. A lot more patients, more than 7,700 patients divided into with and without cerebral embolic protection devices, and also looking at 72 hours stroke rate. Again, this was a negative trial. You see that there is actually not much difference in the use of cerebral embolic protection device or not in terms of the stroke outcome at 72 hours. And even look at the subgroup analysis, you don't really see a difference between the two groups. Brenda also mentioned about this meta-analysis. When you pull the two big randomized trials together to do a meta-analysis, you will see that actually, if you look at the intention to treat population, again, there's no reduction in the stroke incidence at 72 hours. The only positive result will be given by the per protocol analysis when the cerebral embolic protection device can be fully deployed. So I would say if you look at the two RCTs, still the evidence is not really that strong. But if you look at the individual patient subtypes, like in this valve-in-valve, they look at the nationwide readmission database, look at the database and pick out those patients with valve-in-valve TAVI being done, and then with and without cerebral embolic protection device, looking at the primary endpoint of major stroke post this valve-in-valve TAVR procedure, then you see a significant difference in terms of overall stroke as well as major stroke. Of course, this also translates into the 30-day and half a year readmission rate. The second category is these patients with atrial fibrillation. If you look at those patients who have had the cerebral protection device, you can see that there's a much less incidence of stroke as well as major stroke. Again, this translates into less mortality in the hospital as well as less 30-day readmission. We also mentioned about this bicuspid aortic valve stenosis. You will see that when you look at the use of Sentinel in this group of patients, a lot more operators will tend to use cerebral protection device in bicuspid aortic valve TAVI procedure. You can see a lot more being used. And again, if you use cerebral protection device in this bicuspid TAVI, you will see, again, significant benefit reduction in terms of all stroke as well as ischemic stroke, and then translate again into mortality together with stroke as well as the length of hospital stay. Even if we look at patients who develop stroke, and then for those who have used cerebral protection device as compared to those without cerebral protection device, you can see that when we use cerebral protection device and the patient also end up with stroke, they have actually less in-hospital mortality, and more of them can be discharged home as a result of the less stroke severity. So this is another benefit of using the cerebral protection device, even if the patient do develop stroke at the end of the procedure. So we have always to bear in mind this stroke is really a devastating complication of TAVI. This is clinically significant stroke. But what we are looking at is just the tip of the iceberg. What we are not seeing is this minor stroke, transient ischemic attack, neurocognitive decline, as well as silent cerebral infarct, which is not apparent when the patient is being discharged, but it will actually impact the long-term outcome of these patients when we look at this silent brain infarcts, you can see that the instance of silent brain infarcts are actually much, much higher in TAVI procedures, mainly because of this embolic dislodgement during the procedure. And then when we look at the cost-effective, when we look at the cost of these patients who had developed stroke, you can see that actually this adds a lot more to the healthcare cost. And if you look at the patient lifetime after developing stroke, actually the cost is much, much higher than the procedure itself. So these are something that we ought have to bear in mind. We have been using this sentinel cerebral protection device for about 10 years from now. And I can tell you this is a very simple procedure, very easy device to use. And I'm sure Yongzai will tell you more about these tips and tricks afterwards. This was our first case, only 3.5 minutes to implant the filter, even for our first case. Eberhard was actually proctoring us at that time. And this was the debris that we can capture. And if you look at our patient's filter, all the debris that we can capture, we don't know whether these will end up in clinically significant stroke, but these are the debris that we can capture. I can tell you more than 90% of the chance we will have these debris being captured. And as Dr. Yin has pointed out, we talk to every patient in our center and ask them, show them the evidence and ask them to choose. They are paying out of their pocket. And more than 90% of the chance they will say, yes, please go ahead and use it. So my take-home message is, remember, stroke is a really devastating complication of TAVI. For now, I would say evidence do not support the routine use. So no definite predictors of stroke during TAVI, and these cerebral embolic protection devices still are not for routine use. But when we come across specific patients like bicuspid patients, valve-in-valve, previous stroke, elderly atrial fibrillation patients, or we see a lot of aortic atheromas or severe annular calcification, that's a time we really need to think carefully and discuss with the patient carefully. Since the device is very safe to use, very easy to use, so when we move to younger, lower risk patients, we don't really want to end up with stroke for these younger, lower risk patients. So in the absence of harm, I would say I would tend to protect the brain with a useful device. Thank you very much for your attention.
Yeah, thank you, Michael, for your excellent talk and convincing data. Yeah, Dr. Su, you want to comment?
Yes.
Thank you, Michael, for your excellent talk. I want to ask a question not just for you. I also want to ask the Dr. Yin and in Zhongshan General Hospital. I actually believe that CEP can reduce the risk of embolic stroke during especially high risk of TAVI like valve-in-valve and bicuspid. But this procedure itself may also a reason of iatrogenic embolic stroke, maybe in some special anatomic features. So to balance the risk and the benefit, what kind of patient maybe the risk is more than benefit, to how to judge this condition by maybe CT anatomy or other consideration. Thank you.
Well, maybe I answer first. Frankly speaking, for all our patients, we use more than 80–90% of TAVI procedure. We seldom see really complications end up because of this device. Very, very safe device. We usually don't have the information on the great vessels because it is the CT only look at the at most looking at the arch. We don't really see up there. But I can tell you we don't really see any atheroma dislodgement because of this device. It is a very small device, and I don't think there's a chance of embolic stroke because of this device. And if we look at the trials, actually the safety profile of this device is very good, less than 1% of complications as a result of this trial. Dr. Yin, you want to supplement?
I just want to say the most important thing is to achieving successful device deployment. But it is really easy. If you are worried about that, please invite Dr. Lee, me, or another Dr. Lee. Dr. Lee proctored us just for one case. And we have performed more than 300, so don't worry about it.
Yes, we have 2 cases of stroke after embolic protection device. And they are all valve-in-valve patients. And why we use the embolic protection device still have stroke, we check the MRI. The embolic is surround the posterior circulation. So at that moment, I realized that it is very important because from the trial, they taught us about the location of embolization. And I think the neuroimage is quite important because they should do the sub-analysis. If the patient is focused on the posterior circulation, we need protection the left subclavian artery also. And this is why the trial failed. But the Boston did not support the neuroimage, so that's, maybe this is why the trial failed.
Prof. Ian,
okay.
What is, Prof. Ian,
what
is the failure rate of your deployment? Because we occasionally find tortuous anatomy. Do you still try it? And in such tortuous anatomy, are you able to deploy both filters at the same time? Because we've had some problems in tortuous anatomy. And how often do you encounter that?
I leave Dr. Lee to answer the question because you want to save time and skip his lecture. But what you are asking is the tips and tricks.
Yes, there's two tips. The first is subclavian artery tortuous. So there's usually have a loop over here. But remember, you should, when we do the TAVR procedure, we always keep the safety area from the neck to the leg, so that we can compression your subclavian area. And when you push the device will have some resistance, so that you push down the device so that you can go into the involving artery. The second problem is the bovine arch. So the bovine arch is got very difficult because there's a different anatomy. It's just side by side, or there's a common trunk. So we always use the alpha loop. Even as a anterior posterior position, you can use the alpha loop. So that you can use the alpha loop, go to the left subclavian artery, and then this is the very important point. You just turn very slowly, and sometimes you push the device a little bit, so it have a space to turn the device, and then it will have some tension over there, and suddenly you will feel the device was freed immediately, and then you can gently pull up the device. So the tortuous is not a problem, and sometimes you need to deploy the first basket when the device in the descending aorta, and then pull back the device, and then close the first basket a little bit, and then turn to the ascending aorta and curve the basket and into the left carotid and deploy to basket.
But there will be failure cases. Before we open up the sentinel, we actually always test with the J-wire from the radio. If the J-wire can go smoothly, we will open up. If we have to struggle, we can actually use a tiger catheter to to go down and then exchange for stiff guide wire, 014 guide wire. But if it is really difficult, calcified, like the old lady, we can give up anytime without opening up the central device. It seldom happens, but it happens.
Yeah, in our center, the success rate was 98%. But in the first trial, large randomized trial, they select the patient anatomy beforehand and invite the experienced implanter. And the success rate was more than 96%. But in the UK study, they invite all comers. Some of them even don't have any experience in doing so. So the success rate I remember is 81 or something, 83, okay. So that's the difference. And that may be something to do with the result, I would say. So if you want, Proter, here.
Yeah, for me, that's a suggestion that don't do aorta flush in the beginning, because when you aorta flush in the aorta is some debris in the ascending or the arch will debris will become a turbulence. So I will go on the anatomy landmark for deploy, and then deploy the second basket. That's just when first open the first basket and do the angiogram at the first basket, and then you can see the left coronary artery. So we deploy the left coronary artery.
Okay, thank you. Dr. Xu, your last case presentation? No? Yeah. Yeah, he just invite everyone to for pottering. Dr. Lee, want to say that only?
Thank you for inviting me to give a lecture, cerebral protection device during TAVR. I'm Joseph Xu from Far Eastern Memorial Hospital. Several vascular events after TAVR, contemporary stroke rates remain 2 to 4%, and the 30-day mortality is 6-fold higher than who doesn't suffer a stroke. So I think the most important to remember is the risk factors. If you don't want to routine implant the cerebral protection device, so the prior stroke, calcium burden, bicuspid LTVOP, predilatation, postdilatation, valve-in-valve, Redo-TAVR, or leaflet modification. And stroke developed 50% within 3 days and 80% within 1 week. And the microLEE has just showed that the TAVR is the highest instance, the detection of the lesions from MRI. So the composition of the captured material, including the thrombi or calcified debris or valve tissue, and also the LT wall tissue, sometimes get some myocardial tissue, and the foreign body from the catheter. So there are many types of the cerebral protection device, and the Sentinel is the only approved in Taiwan. So you can, from the distal radial artery, also the brachial artery, and implant the proximal filter and the distal filter. The pore size is 140 micro. And I think I can skip this. So it's the capture and the remove. And Dr. Yongzai Li also mentioned that there is protected territory is 2% from the left vertebral artery to the posterior circulation. So my most memorable case is the type 1 bicuspid LTVOP stenosis. The annular size around 24 and delta about 14 millimeter, and you can see the calcium burden here. Also a low coronary height, 10 millimeter. So we do it in 2022, and we do the predilatation and use the coronary IVUS to detect the distance, and do the postdilatation with TrueFlow, and the result is good. And we can catch some material, capture and remove by Sentinel. So risk factors in this case is bicuspid, LTVOP, calcification burden is high, and we do the predilatation or also do the postdilatation. Another case is the risk of the sinus sequestration in native LTVOP stenosis. As an 88-year-old woman suffer from the dyspnea, and the coronary height is low, and the STJ height is also low, and the VT-STJ is only 1.6, so it carries risk of the sinus sequestration. We performed the unicorn procedure, and the leaflet traversal, and the peripheral ballooning, and the intra-leaflet deploy with MyValve, and the final angel. And you can see we still capture some visible debris. So there are also 2 cases of the bovine arch, just the Yongzai Li mentioned. So I think I can skip my lecture today because everyone talk about all the material. So it's the tortuous innominate artery. So you can use the stiff wire to navigate your device and open. You can see you can open the proximal filter smoothly. This one we don't use the alpha loop, but you can still navigate your wire to the left CCA and push up the distal filter. The second case, however, the DSA can show the bovine arch. We use the alpha loop here. You can see the curvature and try several times. You can give your wire to the LCCA and just gently pull up the sheath, and you can navigate to the LCCA and set up the distal filter. So the both trial, protected TAVR or BHF TAVI trial, doesn't recommend the routine use of the Sentinel, but there are still risk factors, just as I mentioned: prior stroke, calcium burden, bicuspid valve, pre-dilatation, post-dilatation, valve involved, Redo-TAVR, and the leaflet modification. And Professor In said that the success rate of the BHF Protect TAVI is less than 90%. So I think if you want to you do it safely. So maybe there is new CEPD flower coming to Taiwan, 12 French transfemoral access, range from 25 to 39, and the 17 micrometer filter, and Noticulous C mark trial already got the C mark approved. FDA ID trial. Always love to be here. Thank you for your invitation. Thank you.
Thank you. Any final comments of the case and the decision?
Thank you, Dr. Xu, for your amazing case sharing. May I ask, what's your current strategy in Taichung? How do you do routinely or just selectively?
Yeah, I selectively recommend the family to receive the CEPD. So generally, I do not recommend, because if I use the BV and I would not do the pre-dilatation, direct TAVR with BV, first implantation, just finish the case, I will not tell the families to afford this device. However, if the self-expanding valve, because I'm not so confident to just finish to just one time. Sometimes we will recapture or resheath. That I will tell the family this information. Otherwise, if we want to do the pre-dilatation, if we want to have the case of the bicuspid valve or calcification or leaflet modification, we will strongly recommend the patient, or even the Lampoon procedure, sometime we will recommend the patient to receive this. Okay. Thank you for asking.
Okay, that seems to be a very good ending. You already summarized the important issue to use a cerebral protection device. Usually in this kind of workshop, I would like to ask everybody, raise your hand, if there has been no budget limitation, will you use it in every case, including your family or you? Yeah, that's the answer. Thank you very much.
for staying to the bitter end. I know we, not just me, we are standing between you and your dinner. So, Cheng Kao Melha. Okay. So, very happy to be able to moderate this session with Dr. Kao Poon. And we've got a few interesting talks and high-level speakers with us today, giving us insights into a bicuspid valve. So I think I'm kicking off soon, right? First, right? Okay, great. So I'll just kick off now then. So my brief today is to talk to you about TAVI for bicuspid valve, stenosis, prime time, or some way to go. My name is Jimmy Hon. I'm one of the cardiothoracic surgeons from Singapore. My disclosures. So I'll just zip through my slide deck and be very efficient with this session. So the discussion point today is really talking about definitions, surgical outcome. Then we talk about some TAVI versus surgery outcome in bicuspid valve specifically. And then my little conclusion based on the evidence we present today. So bicuspid valve, just a bit about prevalence. In Western population and Eastern population, the prevalence is very different. Western population probably average about 5% on the whole, but Eastern population, the Chinese and the Southeast Asia, we see about at least 20-25% in Singapore, and in China towards 50%. So this is very clearly a very different kind of pathology that different countries sees. So classification, I don't need to say too much about this. Most common type 1 and then type 0. Probably type 2 is the rarest and it's probably the worst ones to get TAVI valve into. Now, sizing of bicuspid, there's bicuspid aortic stenosis got a few major challenges. So the location and the amount of calcification makes it very difficult to size, and itself presents a lot of challenges. Just the shape of it, the obstruction it causes, it can be a tube-like stenosis, it can be a flare anatomy or a tapered anatomy based on where your restrictive zone is caused by the amount of calcium in the annulus or supraannular area. And as a result, the challenges are that on the left-hand side of the screen, you have the non-circularity of the orifice, giving you impaired valve durability. On the right-hand side, you can see the apposition to prevent PVL is a challenge. And also, if you try to force it too hard, then you will run the risk of injuring the root and causing a root rupture. So 2020 guidelines is old news now, but as you see, TAVI is firmly, surgery is firmly towards the younger age group patient, towards the 65 or below kind of age group, right? And a lot of bicuspid patient lies in that category. 2025 ESC guidelines last year, released last year, and the major thing that need to flag up is that bicuspid valve got a 2B and only a 2B indication. And we'll see why bicuspid valve only got a 2B. So use TAVI in bicuspid valve stenosis if surgical risk is high and if the anatomy is suitable. So let's have a look at the evidence of using TAVI in low-risk patients, TAVI in low-risk patients. So these are very common, these are very well-known trials that we talked about a lot today. The partner, the notion, the absolute low risk. But we need to absolutely bear in mind that these risks were run by patients. They are old patients, they are transfemoral only, and none of the bicuspid pathology were included. These were all exclusion criteria, so no bicuspid valve patients were in it, and all the high-risk anatomies were not in it. And bicuspid valve with heavy calcification is definitely not in this group of trials. So we need to understand that, and we cannot just superimpose these trial results onto bicuspid patients. So why are we using TAVI in bicuspid patients? The evidence for TAVI for bicuspid patients predominantly comes from retrospective series. So retrospective selected patients, and these are selected patients, right? And that's why we only get a 2B recommendation at best. So let's look through the evidence systematically. Safety of TAVR in low-risk bicuspid patients, okay? So this is a fairly decent-sized cohort, over 65,000 patients, and you've got tricuspid, you've got 56,000 patients, bicuspid, you've got 9,000 over patients. And if you can see that 30-way outcome are pretty impressive. These are surgical patients, so surgical valve replacement, very low 30-day mortality. And if you just look at the low-risk cohort, they are equally low. So the 30-day mortality, really, we are looking at about 1%. So surgical valve replacement for bicuspid patients are actually is a very safe operation. If you look at the sort of medium-term result for surgical replacement of bicuspid valve patients, you can see that the Kaplan-Meier curve are very similar between bicuspid and tricuspid. Now, bicuspid valve patient looks a bit better, and that's because these patients are a bit younger. So that's why the curve looks like that. And if you particularly just look at the lower risk patient, STS PROM score of less than 3%, again, those two curves are very much together. So no big difference at 5 years. So this particular paper looks at slightly longer term results of bicuspid pathology after valve replacement. You can see that the 10-year results are very similar between the two groups. So surgical valve replacement safe in bicuspid patients. So that one we know. This basically tells us that if you do surgical valve replacement in bicuspid patients, their lifespan goes back to the normal population. This is a Swedish study. You actually can put patient back onto their normal lifespan compared as far as this paper is concerned. You can get lots of these sort of different papers, publications in the literature. 30-day mortality fairly low, and 5 years and 10-year survival is good. So surgery is okay in this group of patients. Now, of course, one caveat is not all valve last the same time. So we know that some surgical valve are better than others. So surgeons should choose their valve carefully and use things that have been time proven. Another point is that in surgical option, you are able to correct any aortopathy. So guidelines are very clear. If you are doing open heart surgery to change the valve or do CABG, then if your ascending aorta is above 4.5, then we should aggressively try to rectify that during surgery. And the reason is because in this group of patients, over a 20-year period, there's a large proportion of patients will progress, the aorta will progress into proper size aneurysm or dissection. So this is a problem that can progress, is progressive. So we should aggressively treat that. So we saw this 2B recommendation. So now we are going to look at bicuspid versus tricuspid TAVI results. So most literature will say that bicuspid and tricuspid gives you similar TAVI results. So this is what most literature will say. But interestingly, particularly in the cardiology literature. So that's in terms of survival and all-cause mortality, that sort of thing. But we also know that not all bicuspid are the same, depending on location and also amount of calcification. This important presentation showed very clearly that the lesser the amount of calcification, then your survival curve looks better. If you've got very heavily calcified bicuspid valve, your survival curve is pretty bad. In fact, the survival curve is different from day one. Okay, so not all of them are the same. So the heavily calcified ones are the ones that are a bit difficult to accept. Then you have this publication. This is DDS publication published a few years ago now. Bivalute registry is a bicuspid registry. So the conclusion and the abstract says that no problem, bicuspid TAVI is safe, all-cause mortality no different. But if you look a bit closer, the stroke rate is actually 4.7%. So we know that stroke rate in TAVI at 4.7% is a bit high. We are really looking at about below 2% kind of stroke rate for TAVI now, especially in low-risk patient and especially in young patients. So 4.7% is a number that's a bit high to me, but unfortunately this wasn't flagged up in the abstract. You actually have to go into the main paper to look at the numbers itself. So similarly, if you look into the numbers, 4.7% stroke rate, we saw that. Pacemaker rate is 25% in this particular registry. So young patient, low risk patient, that's a high number for me to accept. So that's that. This is a different paper, also a bicuspid aortic stenosis TAVR paper. So mean age is 70.3, fairly young patient, SDS score of 1.4, low risk young patient. Again, it's consistent. The stroke rate is 4%. And the permanent pacemaker rate is 15%. So again, it wasn't flagged up in the main abstract. It's something that is not really discussed much in the paper. You have to go into the paper to dig these numbers out. So this really prompted me. So this was the paper that prompted me to look into bicuspid valve. So when Notion 2 trial presented their 1-year data this is about 3 years ago now in EuroPCR. They looked at the data and it seems that the all-cause mortality, the stroke rate, the rehospitalization combined endpoint seems a bit high for TAVI. So this was surprising. So Notion 2 is a low-risk younger patient trial. So it's a TAVI versus surgery in a group of younger, low-risk patients, 75 and younger patients. So this was surprising to all of us when they presented this. So when they actually looked closer, the problem was with stroke. Stroke was higher from the very beginning, and it extended out to 1 year data. So if you look carefully at the stroke cohort, actually the problem was with the bicuspid cohort. The tricuspid patients were actually okay. The results were good, similar to surgery, but the bicuspid cohort was 4.1 versus 2%, so doubling the surgical stroke rate, and that extended to 1 year. And as you can see, the odds ratio is very clearly very different between the bicuspid and tricuspid valve. So this was the 1-year data. And subsequently last year, they presented the 3-year data, Notion 2 3-year data. Again, those trends carried on over the following 2 years. And and again, the stroke rate persisted, doubling the surgical cohort. Then, and you can see this is self-explanatory. So the odds ratio are very much in favor of surgery for the bicuspid cohort. So that's that. And lastly, this was a paper I dug out last night. This is an Israeli paper publishing for just under 600 patients of bicuspid versus tricuspid. And you can see that it seems that even the survival in this particular cohort of patient there's a different in favor of surgery, and the odds ratio at the bottom of the curve of this slide is very much different. Although this paper inherently got a lot of problems. It's a different population. You're not comparing like for like, but I think the message is that it's not straightforward. Bicuspid population. There are signals to tell us that there are clear signals to tell us that you cannot superimpose a tricuspid data onto the bicuspid. There are a lot of work still to be done. So this is my little summary. So surgical valve replacement in low-risk bicuspid patients is safe. Is still the gold standard. Associated aortopathy is progressive, and we should treat it according to the guidelines. TAVI should be used in caution for bicuspid patients, especially those with hostile anatomy. So heavily calcified bicuspid, the type 2s, I think we should be very careful in pushing TAVI in this group of patients unless surgically is inoperable. Concerns remain using TAVI in the younger low-risk patient, younger low-risk bicuspid patient. RCT comparing TAVI and SAVR is in progress. I think I eagerly await the results of that. And I think cardiologist, surgeon should work together to improve the outcome of TAVI in this group of patients. It's not that we are going to put TAVI away and put surgery back. I think the technology needs a lot of refinement. I think we should find new device innovation, maybe areas like cerebral protection, we should consider that in this group of patients. Anticoagulation strategy may need to be different in this group of patients, and also sizing for optimization. With that, thank you very much. I think I'm within time. Happy to take questions.
Jimmy, thank you very much for the masterful overview of bicuspid. So I think if you were debating yourself, you have chosen the still some way to go for bicuspid and TAVI. So how do you account for a high stroke rate in bicuspid? Because tricuspid, definitely lower stroke rate, right, with TAVI than surgery.
So, I mean, I've got no data to substantiate that, but the fact that the valve is not opening fully, I think, plays a part. Clots can form, halt can form, and embolization of these clots is a possibility. And I think the fact that we are actually giving up a lot of effective orifice area to heavy calcium is also a problem as well.
I mean, there's 2 multi-center trials happening, and this will be heavily scrutinized and watched. Absolutely, because we are all doing bicuspid TAVIs. We think we know what we're doing, and I'm sure we'll get told how we should do TAVIs in bicuspid. But I mean, the message that you've proposed is at least a cautionary tale. Any comments from the... please, yep,
yes. Thank you for your great talk. And when considering the short outcome, we should avoid a case with a hostile calcification with a type 1 or 2 bicuspid valve. And when considering the long-term outcomes, what kind of case or anatomy should we avoid?
I think the type 2s are definitely a no-no. So the type 1s, I think if you've got a very heavy calcium that forces you to give up a lot of effective orifice area, I think those are not good. If you are born with a hole this big and half of it is full of calcium and you're only putting a valve filling the other half of the EOA, I think those are bad news as well. So I think if you are confident that you can regain most of your effective orifice area as close to the annulus as possible, then great. I think you can make the whole thing round and give yourself a good EOA. But if you think that your valve is going to, be oval shape and you're not able to take back a lot of the effective orifice area, I think those are the ones that you should avoid, unless patient is high risk and or very, very old.
Thank you.
Thanks, Jimmy. We'll move to the next speaker. I think that's been changed to Dr. Zhao now, who'll step in for Chen Mao. The topic will be valve selection for bicuspid aortic valve. Thanks.
Well, thank you very much for your introduction, Professor Poon. I think it's difficult to give this lecture after Professor Huang has given a comprehensive lecture regarding TAVR versus TAVR in bicuspid aortic valve stenosis. Okay, I'm sorry that I cannot move to the next page. Okay, so as it is known that in patients in their 70s, the percentage of bicuspid aortic valve exceed 50%. And with the current guideline-directed trend of TAVR expansion into patients who are older than 70 years, I think we are encountering more and more bicuspid aortic valve. And actually in China, we are doing a bicuspid aortic valve stenosis from the starting of the clinical trials. And from the pivotal trials conducted in China, we can see that in Venus and MicroPort and also SAPIEN XT trial, the mean age was around 75 to 77 years old. And in line with this, the percentage of bicuspid aortic valve patients included in these trials was around 40%. And also in the real-world registry, we can see that the mean age in this kind of registry is typically 73 years old, and the percentage of bicuspid aortic valve was around 45 to 50%. And one important difference of Chinese patients from Western population is that type 0 bicuspid aortic valve is much more prevalent in Chinese patients. We can see that from this carry registry led by Professor Cheng. Type 0 constitutes about 40% of all bicuspid aortic valve stenosis who underwent TAVR. And also, according to the NTCVR database, which was presented by Professor Pan Wenzhi, the percentage of bicuspid aortic valve in Chinese TAVR patients was around 40%. And as Professor Hong has just demonstrated, TAVR has been considered as just 2B indication for TAVI, according to the latest ESC guideline. And this is because that we are still facing many technical challenges when performing TAVI in this specific group of patients. And importantly, calcium is one important anatomical challenge, and the other anatomical challenges including horizontal aorta and the associated aortopathy. And this kind of anatomies could increase the complications significantly. For example, paravalvular leak, aortic dissection, or valve migration. And this might be the reason why bicuspid TAVR in bicuspid performs less favorable as compared with SAVR. Although this is not a dedicated trial to compare TAVR versus SAVR in bicuspid anatomy, but this has important implications which remind us to be very cautious when selecting bicuspid aortic valve stenosis patients for TAVI. And currently in China, our center is leading a multi-center international clinical trial, which will compare TAVR versus SAVR in patients with bicuspid aortic valve stenosis. And this trial is currently enrolling patients. Although it is very challenging to persuade our patients to perform SAVR, but we are still enrolling patients smoothly. And also there are two other clinical trials who are also comparing TAVR versus SAVR in bicuspid aortic valve stenosis. I think this kind of trials will provide us with some future insights regarding the efficacy and safety of TAVR in this challenging group of patients. And I think Dr. Hong has already covered this kind of data. And because we do not have randomized data, we can only rely on those observational data when we are assessing the efficacy and safety of TAVR in bicuspid aortic valve stenosis. And the general conclusion is that self-expandable valve and balloonic expandable valve perform equally well in bicuspid versus tricuspid patients. But we should be cautious that those group of patients might be very selective. So regarding the device selection for TAVR in bicuspid aortic valve stenosis, we only have this limited data. And according to a meta-analysis, we can see that both devices have its advantages and as well as disadvantages. And for balloon expandable valve, the pacemaker rate is lower and paravalvular leak is favorable, whereas the annulus rupture risk is a concern. And also in a most recent large-scale registry study, the conclusion is similar. And because balloon expandable valve is associated with increased risk of annulus rupture and less favorable hemodynamic performance in bicuspid aortic valve stenosis, whereas self-expanding valve is associated with additional valve implantation and a higher risk for paravalvular leak. But according to a small study which assessed the long-term durability of self-expandable versus balloon expandable valve in bicuspid aortic valve stenosis, it seems that self-expandable valve performs better in bicuspid aortic valve stenosis with small annulus. So this might have some implications for the selection of valve types in bicuspid aortic valve stenosis patients. And regarding the topic today, how should we select valve for a specific patient? I think it's depending on CT evaluation and also patient preference. And the first concern is always safety. And we do not want to encounter disastrous complications such as annulus rupture. So for a patient with very severe aortic valve stenosis, we will tend to select self-expandable valve. And maybe this is why in China, self-expandable valve is used much more frequently as compared with balloon expandable valve. And also we will need to consider device success and also lifetime management, such as the future requirement for coronary access or the pacemaker implantation issue. So in our center, for a bicuspid aortic valve stenosis, the selection of device is based on a case-by-case algorithm, and we will discuss the CT evaluation by the heart team, and we will assess the aortic valve calcium as well as the distribution and location, and also we will see whether there is dilated ascending aorta and there is horizontal aorta, and also the parameter of the annulus is a consideration. And for patients with, say, dilated ascending aorta or horizontal aorta, we will tend to select balloon expandable valve. And for patients with small aortic root anatomy, we will tend to select self-expandable valve. And also, we are in favor of self-expandable valve for bicuspid patients if the anatomy is type 0, because we have encountered some unfavorable experience when performing TAVR in type 0 bicuspid patients using balloon expandable valve. But this is a debatable issue. I think different centers may have a different experience. So I think, so in conclusion for my lecture today, I think device selection is still a controversial issue. And this just reflects our center's experience. And we also would like to hear your advices and recommendations regarding this. Thank you very much.
Thank you, Dr. Zhao. Thank you for stepping in and beautifully presenting that in a clear fashion. I think your last slide is actually quite important. I mean, you are a center of expertise given the exposure you have. So some of that, I'm sure a lot of the audience took a picture to remind ourselves how we should approach this. I'll just open to our panelists. Any questions or comments? I think the topic of the two devices are always controversial. I mean, we argue as well in tri-leaflet aortic stenosis. I think it's hard to have one size fits all. I think for tri-leaflet, 90% can be either. Will be easily and well done, but maybe for bicuspid, there's going to be some nuances about which is preferable, and we'll learn from your trial, the believers, for those who believe in bicuspid TAVI. Jimmy?
I've got one quick question. Thank you very much for the great presentation, Dr. Zhao.
Thank you.
You said you are more you favor self-expanding valve in your unit for type 0. Can I ask, what's your post-dilatation strategy for this group of patients? Do you post-dilate as per what you would do for a normal tri-leaflet valve, or you would be more conservative? I think sizing is everything for bicuspid. It's a completely different idea on how you size these patients. So I'll be very intrigued to hear your experience.
Okay, thank you very much for this important question. Actually, for type 0, this is a challenging group of bicuspid aortic valve patients because usually it's more challenging than type 1. And for this group of patients, typically we will require balloon post-dilatation. And in our center, we usually take a conservative pre-dilatation and post-dilatation strategy. And usually we will select a relatively small balloon for both pre and post-dilatation. For example, for 26 millimeter self-expandable valve, usually we will select maximum 20 millimeter balloon for pre and post, and maybe sometimes 22 for post-dilatation. And we will also consider the calcium. For example, if the diameter from calcium to the opposite side is only 20, we will not select a bigger size for the pre-dilatation. And the concern of TAVR in such kind of patients when using balloon expandable valve is because of this. We are in fear of the risk of aortic root injury. And actually, we have encountered maybe two such cases when we are trying to perform TAVR in type 0 bicuspid patients.
Yes, thanks very much. We had some unfavorable results maybe 10 years back with bicuspid, heavily calcified bicuspid results to patients as well. But we've returned, in Singapore, we've returned to balloon expandable purely because we've learned a lot from the China experience, and that we realized that sizing for heavily calcified bicuspid valve is a completely different kettle of fish. You really got to be very aggressively downsizing these balloon expandable valve. Basically is giving up territory to the calcium and not trying to regain those territory. I think self-expanding valve, the safety is that it naturally gives up those territory for you, and you post-dilate using a smaller balloon. Whereas balloon expandable, we have to actively give up those territory. Yeah, so that's all I have to say.
I think type 0, you can't just size to the annulus, particularly if it's tapered. I mean, if your ICD is smaller than your predicted, if it's tapered and it's smaller than the annulus, you size the annulus, you rupture for sure. So I think these are the lessons we've shared and learned from you guys as well. But thank you very much for your presentation. We'll move on now. Thank you. So it's my
Thank you very
pleasure
much.
to invite Chen Mi to talk about CT to fluoroscopy. 7 cases of self-expanding valves. Thanks.
Thank you for the introduction. And this is not all about bicuspid valve, but it's some about them. So this is our agenda. Don't move your eyes. It's really crowded pictures. So the first, let's go to the CT. It's Hsin LVOT prosaline aorta. We can see the annulus is 20.5 and LVOT is smaller, is 18.5. It may make me some trouble. You can see also from the long exercise. And the others, what we also learn from, because when the smaller LVOT always has the problem when we do the pre or the post dilatation because it's smaller. So at this time, we not only look at the pre-meter, but also area, because the balloon, we need to look at the area. So from this, we know it's even smaller because it's quite over. The next, we need to look at the presaline aorta. So this is definitely a contraindication for the surgery. And the projection is okay, not too much horizontal aorta. Let's see what happened. So we choose the relative conservative because according to the LVOT, we choose 18 balloon for the pre-dilatation and 23 self-expanding valve. We started with the nadir of the pigtail. And then we check, as usual, we check both the height in the coplan view and the LAO view without the parallax. And then with the fast pacing, we release it. So with the relative good height, so we can achieve relative good result because there's still some private leak. And the second patient has a really bulky LVOT calcification. We can see there is lots of stuff there. And this we have the inside the stomach have the parallel leak, have the end rupture. And what's special for this case, you can see there is actually this is a really classical sign. The right cusp and the non-cusp has the really calcified. And what will happen, we will see later. And also with this sign, and this is a relative horizontal. We choose a 24 true dilatation because in this really strict calcification, while we want to a non-compliant balloon, it can give us the fast deflation, much safer. And we release our self-expand valve. And I don't know whether you have spotted it. This is the incomplete stent opening. And later, what our strategy, we need to go deeper and release the valve again in LVOT. Maybe then we check the valve a bit. But now you can see the second release is in the left coronary side, is right above the aorta, annulus. So we try the third times. And it shows a good height, good result. So let's spot the difference. How do we understand the ISO, the incomplete stent opening? It is easy if you have the good feeling of your valve, you know which size should open in which the dimension. And also we can see it's the asymmetric with the different cells. In the outer curve is more the intensive. And this is what we learned from the CT. It's usually happened when there is really calcified between the right and the non-coronary cusp because our delivery system usually lie on the out curve, so it can cause the highly chance of the ESO. Okay, let's go to the third case is a valve in valve 23 adverse perimont. And now from the CT, also from the app, is between the 23 and 25, the navigator valve. So usually in this case, now our experience change, we usually go to, if in the borderline, the gray zone, we go to the smaller one. And we want to choose, achieve a high implantation. And we did the post-dilatation with the 22 millimeter high pressure, but no fracture. And the high implantation can achieve the really good full expansion. And the fourth case is a degenerated biobento with a 23 millimeter trifecta. This challenge comes from the really tortuous and even enfolded the aorta. And also the one is not so obvious in the ascending because you know the bento sometimes always has the enfolding in the ascending. And also we know the trifecta is a leaflet external sutured, the stent. So the coronary risk is usually higher, but luckily here we have a 6.3 millimeter. And what happened? When we retrograde crossing the degenerative valve, usually more difficult, and more difficult with the trifecta. And what makes it more difficult if you have really tortuous access, because your catheter has the good, really sensitive for your maneuver, because a loss of friction along the long path, you cannot turn as you want. And the good solution is now we can advance a 65 millimeter gorges, also help with your access. But if sometimes you want to save money, you also can use a 70 centimeter destination sheath if you don't go through with the valve. This makes our crossing the valve even more difficult, too much friction to control the rotation of the catheter. And then we implant the self-extended valve through the 65 gorges and achieve the high implantation. And then we post dilatation with the 22 true dilatation balloon. This is the final result. You can see there even really enfolded in the ascending aorta. And the number 5 case is a full mantle jagged aorta you will see later, and it's a degenerative stentless bioconduct MAFAN, and with the severe aortic regurgitation. And what is the really top one challenge here is the patient has a bypass between the left iliac bypass to the mesenteric artery, which means it's very dangerous if we advance the big bone sheath in the left side. And what we have in the right side, we have a covered stent for bun. So here you have 2 options. You can go deeper, go to the superficial femoral artery, or you go higher, go through with the V-band with the covered stent. And that's when you see this, you get fainted. You have this such difficult jagged aorta. So then we realize we need to say 1 centimeter is better, so we want to go higher. And luckily, we have a really experienced vascular surgeon. He told us how to do it with the foreband. We can do the puncture on the foreband, then we use the 6 millimeter and 8 millimeter balloon to dilate the stented covered stent. Then we put the 2 stent. And also this case, for sure, we need to use the 20 French gorges to went through all the V-bands and we went through the aorta. And you can see, because now we saved the centimeters, so our gorges can went through even the aorta. This helps us a lot to go through all the big friction of the access. Then we put the self-expanding valve. It's quite direct implant in this case. And we release the valve with the 22 millimeter Z-band balloon. And finally, what's a bit special for this cover stent? When we do the knot pusher with the ProGlide, and we also need to make the hand to put some reverse throw several times to make the knot is tightened. And the last case, not the last, number 6 case is the pure aortic regurgitation with the dilated aorta and the previous mechanical mitral valve replacement with multiple cardiac surgeries. What we can see from the CT, you can see the aorta is quite sticked to the sternum, which means high risk for the redo open heart surgeries. And also you see the annulus parameter is 75, it's a pure AR, we need oversizing. Usually this we can go to the 29 navigator directly. But however, it has a smaller LVOT, it's 65.5, so we are quite struggling between whether we should use 27 or 29 navigator. And also there is acute aortic arch, but we can see it's a relatively young patient and not so much calcification. So this we didn't use the gorges. And the third thing is it has a really near the mechanical valve. When we measure this, only 3 meters below the annulus. So finally, we decide the 29 navigator. We don't know, maybe 27 even better, and what we can see what happened here. We crossing with the flex nerve safely in such sharp aorta. And this is our first time we try to went high, but what you see here is quite inverted stent. And also our delivery system is quite central, not push a lot in the outer curve. Then it's nothing to surprise, our valve pumped out. The next time we go deeper. Okay, and you can see what happened when we go deeper. We touch one of the mechanical mitral valve leaflet. So we cannot leave like this. Then we gave the third attempt. Luckily, we choose the not high and not low place, and we find a really good projection to spot our mechanical valve leaflet. This is the final release, and with the final angiogram. And we also check the sharp aorta arch is good. Okay, let's come to the bicuspid aortic valve. It's not so common in the Switzerland for the type 0. This is a really old patient. It's 83 female, and it has the severe aortic stenosis with 89 millimeter mercury and moderate to severe aortic regurgitation. And we can see it's 22 millimeter annulus and really calcified with the 10 millimeter above the annular level. And what we can spot here is the direction is because this is mixed. Like this has each coronary, each cusp. And so usually the direction is around the 1 to 7 o'clock. And it's really opposite to the arch. And the coronary height is okay, not a big problem. Access is okay, but left is better, so we went with left. We didn't do any downsizing, we just used the normal sizing chart and choose the Evolute Pro 26 millimeter. And we advanced the access, it's nothing too much special, and exchange with sapphire wire, and we check the valve. Okay, this is a 20 millimeter pre-dilatation. We can see we push the leaflet calcification open, but it's recalling a bit. Okay, we may need to return to the, no. And we start implant the valve. And we start from the 0, from the pigtail. Actually, I think the position is not so bad, but you also can see because the leaflet orientation is really constrict the delivery system. I think there are lots of push, but we cannot go to the outer curve enough. So the coaxial is limited. And then we deploy the valve goes deeper. We did the post-dilatation. And let's see, the final result is acceptable, but definitely there's some parallel leak. So maybe we can put the discussion here. This is a case from 8 years ago. And is that device at that time and that technology maybe almost 10 years ago. I don't know whether we have the better strategy today. And so in conclusion, CT helps us to predict the surgical risk, such as porcine aorta and reduce open heart surgery risk, and recognize the small LVT makes a major difference. The Chinese 8 sign can predict the incomplete stent opening, and the 65 centimeter gorge is facilitate a lot for the difficult accesses. And in the valve-in-valve procedure, optimal frame expansion may be more important than implanting a larger valve to achieve lower gradient. Thank you so much.
Thank you very much. That's a very quick 15 minutes masterclass of how to deal with difficult cases. That full metal jacket was pretty impressive. Any questions from the panel?
Yes. So the case number 5. I would like to ask you, can you give us more information about how to stop bleeding with the covered stent puncture already? So how to stop it?
Yeah. How do we stop or start?
Post procedure.
Yeah. And first we have an experienced vascular surgeon. And he also do the endovascular implant. So he told me, oh, this is already my 3rd case. You should trust us. Then we trust him. Then we choose to puncture the covered stent. At the beginning, I think the things different is you need a 6 or 8 millimeter balloon to pre-dilatation. Otherwise, you cannot advance your big sheath. And after the balloon pre-dilatation, we put the tube ProGlide as normal. And then we do all the case as normal. Then just when the last step, when we recheck the sheath, we make the knot. Usually we use the knot pusher to push it, then finish. But in this case, we need to make our hand to make the knot, make the direction and the counter direction several times, like the surgical case. Because this may be not like the vessel, you can use the sleeper knot to tighten it well.
Why didn't he go SFA? It looks big enough. Did he tell you why accessing the SFA wasn't a good idea? Or it's too small?
Yeah, we discussed this, whether we should go to the superficial, the branches, because we think about this, the jacket aorta is really challenging. So we want to save each 1 centimeter, then we can implant our gorge sheath as fast as possible. Also, you see, luckily we implant our gorge sheath already almost ascending aorta. But I think if you don't have such a gorge sheath, such a jacket aorta, you don't have an experienced vascular surgeon behind you, definitely you can go to the superficial femoral.
How long ago were the metal jacket implanted? How long ago was the metal jacket implanted?
Yeah, how long? Oh, this I cannot remember.
The reason I ask is probably it probably was endothelialized. So because if it's a freshly implanted ones, then I think all the friction is going to cause some trouble negotiating. But well done. This is such an impressive case to complete without problem.
Yep, I guess it's not fresh at all. And so when we spot this, I saw there are different type of the stent.
Yeah, please go ahead.
Thank you for a nice lecture of a great and a beautiful slides. And my question is about type 0 bicuspid aortic valve stenosis, and a self-expandable valve has a lower opening force and can mitigate the risk of root injury, but the low opening force cannot defeat the calcium force, and at point of no recapture resulting in hemodynamic collapse, I think. And you encountered such a case?
Oh yes, actually, I got this topic by Professor Cao. he fixed my topic to talk about self-expanding valves for the bicuspid aortic valve. And actually in Switzerland, Switzerland has a bit higher than Europe. We have around 15% of the bicuspid aortic valve, but really rarely type 0. So I found this case almost 10 years ago. Most of them is type 1. And I think it's a good discussion in the last, the valve selection. Actually, I want to mention at that time, I think because bicuspid aortic valve is really challenging anatomy, I think really should select also by the operator's experience. If this operator really good at balloon expand valve with SAPIEN, he knows everything, can ensure safe, good result, then go SAPIEN. If this operator is self-expand valve dominated center, then why not use your experience to handle the challenging anatomy? And I trained with 2 teams. So one is balloon expand valve, we treat all the bicuspid. We also have lots of publication about it. And another, like this team, we prefer the self-expand valves. So I get most experience in general, my feeling, if you are really experienced sapien, you can achieve really good results, and no parvalvular leak. But if you are not so, because we use lots of trick for like flare the inflow, lots of this. But if you are not so experienced, then self-expanding valve can ensure safe implant at least.
Great. So I know Professor Yin has offered not to delay dinner, so has cancelled his talk. So it's my honor to close the day. It's been a full-on learning day, and it's been an absolute pleasure to share with friends and colleagues all the teachings. So I know there's dinner plans for all of us, so we might just move on. But thank you very much to the panelists, the speakers, and presenters. You have a good night tonight, and we'll see you bright and early tomorrow.